morning, everybody. Good morning. I'm trying to find a place that, I can't stand behind podiums because then you will only see the top of my fuzzy head. But boy, that's a bright light. Thank you for being here this morning. I know that travel has been really difficult, and a lot of folks got stuck, got diverted, their planes got canceled. And we love Chicago, and we're happy to be back in Chicago, although we like it a little better in some other months, but only because it's hard to get here. Although it's really fun, I don't mind. Walking carefully to not slip, it's all good. And we're really happy that you're here. So thank you. We've got more folks who will be trickling in, but I wanted to try to keep to our schedule. And today our meeting is protecting what works and keeping proven practices in place. And it's a really important theme that we thought long and hard about, because the things that we have worked on together, that we've worked on together for many, many years, many of them are being threatened with being dismantled, being defunded, being taken away. So we want to leave you today with lots of good information that you can use when you go back to your affiliates, and for the legislators in the room, what they can do for their advocacy. And we, of course, start the day by catching some fabulous legislators doing wonderful things, because we spend a lot of time in their offices yelling at them, telling them what they should do, telling them what they shouldn't do, asking them for things, and today we're saying thank you. So I want to start with some really important housekeeping. We got our really important housekeeping slide here with our funders. Yes? No? Oh, there we go. Number one, most important piece of housekeeping is thanking our industry partners. Our Regional Policy Council would not exist were it not for our industry partners. And for the couple of you in the room who may not know what the Regional Policy Council is, welcome. It is one of Mental Health America's signature programs. And we have been doing meetings around the country for a number of years where, again, we catch people doing wonderful things, but we also share information all across the states, all across the country, amongst our affiliates, amongst our partners. We speak with legislators. We partner with the national legislator groups. We're very happy to have Sean Sloan from CSG here with us this morning, and you'll hear from him in a few minutes. But I really want to start by saying a thank you and calling out in alphabetical order, because I try not to play favorites. I want to thank AbbVie, Alkermes, Beckley Psytech, Bristol Myers Squibb, Compass, Johnson & Johnson, MindMed, Neurocrine Biosciences, Otsuka, Pfizer, Sage Therapeutics, and they have an alliance with Biogen, Takeda, and Teva. Thank you so much. Help me thank our wonderful industry partners. The other very important bit of housekeeping is the restrooms. Out that door and turn to your left. So I always scope that out and I let everybody know. So again, I'm really glad to hear you, to have you here with us today. And unfortunately, as I said, a few people are missing, but some very, very important people are here today. Like my personal dear friend and MHA's general counsel and head of the policy committee of MHA of Illinois, Mark Hireman. Mark's going to come up here, and he has a very important legislator to say thank you. And unfortunately, even though she's local, at the last minute, she wasn't able to join us in person. But Mark's got some fabulous things to say about her, and we've got a video.
Morning, Mental Health America. Sarah Feigenholz here. So sorry I can't.
I'm supposed to speak before the senator, although if the senator wants to speak before me, I always say, of course. So I am here to say a few words about why we've decided to honor Senator Sarah Feigenholz She is an amazing supporter and sponsor and advocate for people with mental health conditions in this state. She served in the Illinois House of Representatives and now is a state senator. She happens to be my state senator, and even though I just moved 2 miles, I'm in this little sliver of the district, so that if I walk 100 feet to the east, I'm in the water. If I walk a block to the west, I'm not in her district, and a block to the south, I'm not in her district. I don't think the district is gerrymandered just so I could continue to have her as a senator, but if it was, thank you to whoever wrote the reapportionment and boundaries for the state legislature. Senator Feigenholz has been a champion for the things that we care most about. What do we care most about? We care most about access to medications and other kinds of treatments. So among the things that she has been doing is fighting to make sure that our Medicaid program pays for all medications. She's worked with Representative LaPointe to make that true, to remove restrictions on access to medication in Medicaid. We do have Representative LaPointe here who will speak to us a little later. And she's also worked on every kind of bill that accounts about health insurance and preventing health insurance companies from discriminating on the basis of mental health. I'll just talk a little bit more about the most recent thing that she did, which provoked an editorial in the in the Wall Street Journal complaining about our state. She passed a bill that provides screening for all students, high school and grade students, with regard to mental health. This was an important thing. We screen for vision, because everyone knows that if you can't see the blackboard, you can't, well, there aren't blackboards anymore, but I'm very old. If you can't see the whiteboard anymore, you can't really learn. And similarly, health conditions can interfere with our ability to be good students when we're young. And it's important for parents and teachers to know when people have mental health conditions. And so she was the principal Senate sponsor of that bill, which passed and the governor signed into law. So that's what she's done for us lately. Whenever there's a bill, you can always go and, with regard to behavioral health, you can always go to Senator Feigenholz, and she will say yes, yes, yes. She won't just say yes reluctantly. She will say yes enthusiastically, either to be a sponsor, or if you already have a sponsor, she will join on. She's an amazing person. I'm thrilled to be her constituent, and I encourage you to all say, applaud for her remotely, even though she's not here, and then you'll hear from the senator in one moment. Thank you so much.
Morning, Mental Health America. Sarah Feigenholz here. So sorry I can't be with all of you today. I am so excited to get this award from you and so excited to share this work with Mental Health America, with the Kennedy Forum, with all of the advocates. When you take a look at the progress we've made in this country around mental health and mental health parity, it's all because teamwork makes the dream work. I will never stop fighting for mental health being treated the same as any physical health. And I also want you to know that Illinois is making incredible strides. I am so proud to collaborate with all of my colleagues who are social workers, behavioral health providers. We have done some amazing things, and there's a lot more to do. So God bless all of you. I miss you, and thank you again for this great honor. Let's keep fighting.
Senator couldn't be here, and I have had the wonderful opportunity to have some long conversations with her. She is fabulous, and we have her award here because Mark's going to deliver it. Other awards have already been shipped to the legislators who couldn't be here. But let's get a picture of you. Let's do the long and short of it. Where's Alexander?
I'm the long, she's the short, in case you didn't know.
And we'll get a picture to send to her of her award.
I can walk to her office from my home, and we'll do so.
There we go. You know what? I can't see you, Alexander. Where are you? Right. Oh, yeah. Okay.
They're going to turn on more.
Woo!
Make it harder for us to see.
Yes. Yes. Thank you.
Thank you.
Thank you, Mark. Thank you. Thank you. Okay, can we turn those lights down just a little bit? You know, and part of the problem is, you know, I tease about not standing behind the podium, but also the way the lights are, they're designed for taller people. So, okay, here's the one advantage, folks, to being short. You know, in the airplane when everybody's been sitting for 3 or 4 hours and they try to stand up and they're all hunched over, I can stand up. Just saying, I can't reach the overhead bin, but if I look a little helpless, somebody helps me. It's all good. It's really not anti-feminist. I can't reach. Okay, so our affiliate from Michigan, our wonderful affiliate, Marianne Huff, was planning on being here today. And unfortunately, Marianne's mom passed away. So Marianne is not with us. And she knew that mom was at the end, and she was going to send a video introducing her legislators, who, by the way, have sent us videos. Marianne was unable to come. So Marianne sent me some lovely remarks about her legislators from Michigan. So if you'll bear with me a minute, I'm going to actually step over to where I can read the notes that Marianne sent me, and we really want to send out some warm appreciation for the 2 legislators from Michigan. So am I in order, Representative Vanderwall? Yes, thank you. So Representative Kurt Vanderwall is the chair of the Michigan House Health Policy Committee. He has championed greater access to behavioral health, workforce growth in behavioral health, and provider flexibility, something that's really important to us. During his tenure as senator, he sponsored and passed the Student Mental Health Apprenticeship for Retention and Training. That's a big one. It has a great acronym, SMART plan, which legislates tuition assistance and apprenticeship pathways to recruit and retain school-based mental health professionals in Michigan schools. Currently, Representative Vanderwall has proposed House Bill 5114, which would expand the Michigan Public Health Code to recognize physicians' assistants as mental health providers, which would allow them to legally provide mental health services under state law to increase access to treatment. We're really pleased that MHA can recognize, and Marianne has nominated Representative Vanderwall, and this is really all about his commitment to the wellness of young people and those who provide them services. We've got a video, and I'll just step out of the way.
Good morning, everybody. Hey, State Representative Kurt Vanderwall. And I just wanted to say, first of all, thank you for all that you do. Mental Health America, you continue to advocate so much for those that just need some special attention to help them on their way. But I want to say it's a great privilege of mine as state representative to continue to advocate for mental health and to continue to work on that. I want to say thank you very much for this award. I apologize that I can't be there in person. However, we are in session and duty calls. So again, I just want to say thank you to all of you that are in attendance, all of you that nominated me for this award. It is really, truly an honor. And again, we will continue to work hard for everybody that is suffering from any type of mental health needs or crisis. But again, thank you, everybody. I appreciate it. I want to wish all of you a great Christmas and New Year. And thank you again for this award. I will truly cherish it. And thank you again. Have a great day, everybody. Bye-bye.
I'm sorry we couldn't get his enthusiasm here in person. One of our great privileges is giving lots of hugs to legislators, but at least we have one in the room. Representative LaPointe, we're going to hug you a lot today. Oh, there you are. Excellent. We have another outstanding legislator from Michigan, and this is Michigan State Senator Michelle Weber. And Senator Weber is a champion for oversight and accountability of mental health services in the state of Michigan. Oh, excuse me, wait, do we have Michael or Michelle? Thank you. At the top of this page, it says Michelle. Thank you. That'll teach me not to look at the video first. Excuse me, Senator. His request for an independent audit of the Michigan Department of Health and Human Services and the Office of Recipient Rights, it uncovered some systemic failures, which he is working very hard to fix. Senator Weber has co-sponsored Senate Bill 1048, which would reform how psychiatric hospital oversight and patient rights are handled. The bill that would add independent patient advocacy organizations as permanent members of the Recipient Rights Advisory Committee. He's a great friend to mental health. Our MHA in Michigan is called the Mental Health Association in Michigan. And last week he participated in a panel that was hosted by MHA in Michigan, and it focused on youth mental health and juvenile justice. It spotlighted the state of mental health care for young people and concerns about their involvement with the criminal justice system. We recognize him today as a legislative champion for his willingness to partner with advocacy organizations and to sponsor legislation which protects people living with mental health conditions.
Hi, I'm State Senator Michael Weber from Michigan. I wish I could be there with you this morning in Chicago, but I want to begin by expressing my deep gratitude for the work you do to support those seeking mental health care across our country. Thank you from the bottom of my heart to Mental Health America and the Mental Health Association of Michigan for nominating me and for honoring me with the 2025 Legislative Champion Award. This means a great deal to me. I accept this award not just for myself, but on behalf of the many patients and families in Michigan who inspire and guide my work, advocating that mental health care is health care. Every day, families place enormous trust in Michigan's mental health care system. They trust that their loved ones will be treated with dignity. As lawmakers, we have a moral obligation to make sure that our government is protecting vulnerable patients receiving mental health care. Over the past 2 years, I've listened to parents and former patients share their experiences about Michigan state-run psychiatric hospitals. One thing is clear: for far too long, those seeking mental health care have not received the same adequate treatment. No vulnerable person should ever be left unprotected in a system designed to heal them. That's why I turned to Michigan's independent Auditor General for answers. They investigated the Office of Recipient Rights, which is Michigan's patient complaint system. The audit confirms that our state government is failing to protect the rights of mental health care patients. Nearly 30% of sample patient complaints alleging abuse, neglect, serious injury, or death were not retrieved or acted on until 2 to 12 days after being filed. This should have been done within 24 hours. Video surveillance and audio recording capabilities at state psychiatric hospitals were often missing or not working. For over 40% of the investigations reviewed, video and/or audio evidence could have helped solve patient complaints. These are just a few of the stark findings. Now that we have clear insight into our mental health facilities, we can take real steps to protect patients and the families who rely on this help. Through my work, I introduced legislation that add representatives from Disability Rights Michigan, Mental Health Association in Michigan, and ARC Michigan as members to the Recipient Rights Advisory Committee. I have also introduced legislation that would require hospitals to have patients' written notice of their rights. This award is a reminder of the progress we've made, but our work is far from over. Every vulnerable person in Michigan deserves the care that we've sworn to protect. Every patient deserves to understand their rights, and every family deserves honesty and transparency from their government. That's why I continue pushing for legislation to strengthen patient rights protections and bring transparency and oversight to our mental health care system to ensure people in crisis are treated with dignity and that families have the information they're entitled to. Mental health care is health care, and as long as I'm serving in Michigan's capital, you'll have a committed advocate working every day to make things better. Thank you again for this incredible honor, and thank you even more for the work that you do for standing up for vulnerable young people and adults who need care, compassion, and a safe place to heal.
You know, for those of you who know, I'm going to take a little license here. We've been doing this for a long time, and we love working with legislators. In fact, many of them have become our good friends. And it's really interesting to see the differences between states. And we know that some states have phenomenal parity laws and phenomenal rights laws, and they keep getting better and better. And then we have Senator Weber, who is fighting really, really hard to bring Michigan up to some of the standards that some of the other states have. And I loved hearing about Senator Fagenholtz's bill for checking out, doing that checkup for kids. And we know that one of the things that comes out of these meetings is sharing that kind of legislation. And I think back to the state that I live in right now, Colorado, and now Senator Daphne Michelson-Jeannet and her bill, and how other states are copying that. So we are so happy to be able to share this kind of information, not only among our affiliates, but among the legislators. So it's really lovely. We have one more award this morning, and that's from actually my home state. So while I live in Colorado, my heart will, all right, I'm a Philadelphian. I drink water. There's nothing I can do about that. I can't hide that fact. From Pennsylvania. And Laurie Barnett-Levine, our affiliate from Southwest PA, was planning on being here. And again, it's a little hard to get here sometimes, so Laurie was unable to be here this morning. But Laurie has an introduction video, and then we have a video from Representative Dan Miller. So,
Hello, my name is Laurie Barnett-Levine, and I'm the CEO of Mental Health America of Southwestern Pennsylvania. I am honored to be able to honor Representative Dan Miller of the 42nd District of Pennsylvania in Allegheny County. Representative Miller has done many things for the disability and mental health community. And one of the reasons that I thought it fit to nominate him was that he has sponsored, coordinated, and advocated for a disability and mental health summit. This May, the summit will be in its 12th year. He has touched thousands of lives with this summit, educated legislators and the community from both sides of the aisle. It informs families, it informs individuals with lived experience. It's widely attended by providers, again, people with disabilities and lived experience, family members, and even the governor of Pennsylvania. Representative Miller has advocated for 911 dispatchers, first responders, and juvenile justice reform. He has defended Medicaid along with federal legislators. He has said that Medicaid is essential. It's a life-sustaining program. It helps Republicans, Democrats, and independents alike. It is promises kept. Representative Miller is the son of immigrant parents. He is the first of his family to be born in America. He's the son of a single mother. Representative Miller has made public service an important part of his life. From being a member of the National Guard to being a team leader of the AmeriCorps. Representative Miller passed the bar exam and became a public defender. He worked again with youth. He also became a volunteer firefighter, and he was awarded the Medal of Merit for attempting to save a 3-year-old girl from a fire. He has received numerous awards for his advocacy from the disability and provider community and the advocacy community. He even received an award from the United Steelworkers. I thought it was high time that he also received an award from Mental Health America. So it is my honor to have been able to nominate Representative Miller for this legislative award. Thank you.
Hi everyone, Dan Miller here, and I just want to say thank you for everybody over at Mental Health America who honor me in any way as an advocate in relation to mental health and disability. You know, I'm very honored to be in a room full of people who care and to be in a fight for things that matter. So I'm looking so much in relation to mental health and disability. It's, you know, we're kind of looking for people just to keep promises, right? Promises made. You know, even here in Pennsylvania, I'm glad when we take steps forward, but we're still trying to create a system that works, create a system that we promised would be there, create a system that provides stability and opportunity for everyone. And that's actually one of the things I love about talking about disability and mental health, is that it really is one of those issues that should and does transcend politics. I can't tell you how many times that I've benefited from self-advocates coming to talk to me about the challenges. And occasionally they'll say something like, well, I'm a Republican, I'm a Democrat. And they'll be like, well, but you know, I really care, thank you for caring about this. And I'm like, look, if these issues are ever seen as the purview of only one party, then the entire system will collapse, right? Disability and mental health is an all-in type of effort here. It requires everybody. And just like if there's a problem with access in one county, it's going to have a problem in access in another county. If another state is doing things better than us, we in Pennsylvania have to get measured up and have to meet that goal, or the inverse that comes across when we're not doing what we should be doing. And look, for too many of us who are policymakers, we think that just necessarily passing a budget or posing for a picture is enough. But we have to be sure that a system really works. It has to be sustainable. We have to be sure that people who are providing those services can afford to do so. And we have to do things in a way that provides access no matter where you are. In a diverse state like Pennsylvania, as big as we are, it has to be available everywhere. And if we're going to be leaning into things like telemedicine, and we have to be sure it can work. And when we're trying to encourage people to seek out help, we have to be doing the best we can to combat stigma. These are all things that we have to try and do together. And the only way forward is for us to do that together. Look, Medicaid is essential. It's life-sustaining. It's something that needs to exist. States cannot backfill Medicaid, right? In relation to mental health, if the system isn't funded, you're going to create a catastrophe, right? You're going to have a human catastrophe in the wake of that. And we're barely keeping our head above water now. We have to push. We have to do better. That's why in my office, we did focus so much on Medicaid this year in relation to our Disability and Mental Health Summit that we do. We did a big Medicaid push in August with 5 virtual events. We did a couple press conferences and tried to bring people together from every spectrum to talk about why Medicaid is so important. And if the federal government turns away, the future is not behind us, right? It's in front. And we have to do it in a way that brings everybody together. So listen, thank you for at all thinking I'm of some value in this arena. I could tell you that I learn from listening, and that's always been the key. So listening to people and self-advocates who share their stories and tell me what's working and what's not working. And then hopefully trying to craft with my friends in my caucus here a pathway forward that makes opportunity more likely to exist. And hopefully with a degree of satisfaction and enjoyment that we would all hope for. Thanks again for caring about mental health and disability. Thank you for all your work, Mental Health America, and your staff's work for getting things done and providing those services. I appreciate everybody paying any mind to me at all. Thanks a lot. Sorry I can't be there.
can see why we love state legislators. They really care. And we are really privileged to have built relationships over the years with state legislators and state legislator groups. We are very grateful. And I'm really excited right now that one of our former awardees is here with us today to tell us not only about the fabulous things that she's done for the reason we gave her award a couple years ago, and the things that she continues to do. And my dear friend Mark Hireman just told me that there's a big article about her in the Chicago Tribune today. Mark, did you want to say anything about it, or would you like me to just go on? Because I just am so taken. I had the great privilege, and thank you, Sean Sloan from Council of State Governments, and our partners also at NCSL National Conference of State Legislatures. We got to work on some joint projects together with all the legislators across the country. And one of the people I got to know was Representative Leslie LaPointe. And I was very humbled and very honored to be invited to the meetings and to the task force and to work with them and to learn about the amazing stuff that is going on all over the place. And as Representative Miller said, how we really help each other and how we learn from each other. So I'm going to shut up and I'm going to invite the woman of the hour in the Chicago Tribune and our dear friend, Representative Leslie LaPointe, please.
Thank you, Debbie. You are always so warm, and I'm so grateful that we got to meet way back in the day at CSG when we were all working on the behavioral health care workforce. Good morning, everyone. I am really excited to be here in person with you at this Regional Policy Council meeting. Before I get started with a few reflections, I just want to know, are there any legislators in the room? Okay, no. Are there people who speak to legislators as part of their jobs, who have ongoing relationships with legislators? Okay, excellent, great, love knowing that. So I am a social worker turned policy advocate turned state representative. And in my 6 years in office, I've learned a few things, as you might imagine. But first and foremost, one of my big lessons is that we urgently need more people with social work backgrounds, with behavioral health backgrounds, with human service backgrounds, not only coming into government and politics, which some of you I'm sure are in government and politics, but coming into elected office. So if there's nothing else that you remember from the reflections I'm going to share, please remember that. We need to change the type of people that will even consider running for elected office. And I've just seen some amazing colleagues and their reflections resonated with me. In terms of me, 21 years ago, I started my career at a group home with kids with special needs. I was the tender age of 22, and I learned about diagnoses, I learned how to dispense medication, and I even learned how to physically restrain kids. I liked the job. The $9 an hour was rough, but I liked the job. I loved the kids. But I immediately was struck that we are doing this wrong. We are separating kids from their families. We are giving them diagnoses at the age of 5. Insurance companies have to have that diagnosis to be able to do what we need them to do and get kids basic access to care. And I carry those lessons with me now as a policymaker. And now we're here together. We are all leaders engaged in the fight, and it is often a fight to get access to behavioral health support for our kids and adults. And we are doing that at a time, we don't want to forget, that our private health insurance companies are experiencing record profits. And that's not something we should forget. We are also doing this work at a time where the biggest funder of mental health and addiction treatment in this country is facing an existential threat. And I'm sure we all know that that is Medicaid. So at this moment in time, if we're talking about behavioral health access in the United States, we cannot overlook Medicaid. And I'm really glad to hear the Michigan, or that was Pennsylvania, I got them mixed up already, that he mentioned that front and center. If we're gonna talk about behavioral health access in this country at this moment, we cannot overlook the big changes in HR 1. And I wanna put a really fine point on that, and I wanna encourage anyone with a policy voice, which is anyone, we all have a policy voice, to get familiar with what those changes look like in your local communities and in your state. And I'm going to repeat something I suspect we all know because you work in this space, but it's really important to clarify and be precise because people on the street get Medicaid and Medicare mixed up all day long. And we don't want to cause more anxiety for people and by insinuating that Medicare is going away. So we've got to be precise with our language. But to be very clear, the direct hits for Medicaid are coming to the ACA expansion population, which people on the street have no idea what that is. You do, but we have to remind people and educate people. That is the population of adults between the ages of 19 and 64 that don't have dependents. And these are folks that never had access to health insurance because they're below a certain income until we passed the Affordable Care Act at the federal level and states went on to expand Medicaid. And in Illinois, we did that in 2014. And I did homeless street outreach in 2012 and 2013. So I have walked with so many single adults between the ages of 19 and 64 that had severe mental health issues and severe addiction issues and had zero access to any type of health care. So I want to paint a picture of Illinois so you can think about your state and make sure you're ready to talk about the existential threat of Medicaid being decimated. So here in Illinois, we have 3.4 million people on Medicaid. 3.4 million people. And of those 3.4 million, 770,000 of them are the Medicaid expansion population. And I represent the far northwest side of the city of Chicago. It took me about 25 minutes to get here with not too much traffic this morning. I represent a middle-class district with a lot of public sector workers. It's not a poor district, it's a middle-class district. I represent 108,000 people, and of all the people I represent, 31,000 of them are on Medicaid. And that's a middle-class district. And of those 31,000, 7,500 are the ACA expansion population. So as an elected official who takes my role to represent people and support people in my district very seriously, I am zeroed in on that 7,500. Those are my constituents that are at big risk for losing Medicaid. In terms of the budget, and again, these are good things to know about your state if you're working on behavioral health, which I know you are. In Illinois, our general funds budget is $55 billion a year right now. And in any given year, we get $21 billion in federal money related to Medicaid, $21 billion. And over the next 10 years, we are slated to lose $51 billion in federal Medicaid reimbursements. So every single one of us who cares about mental health access should know the local landscape in our communities and in our states. And I know that we do feel it in our bones that the Medicaid cuts in HR 1 not only will hurt people, but they are going to blow gaping holes in state budgets across this country. And they create an existential threat for our community-based providers that take mostly Medicaid and our safety net hospitals that by design take mostly Medicaid. And some might say, oh, that's political. It's math. It is literally math. Almost every single policymaker I meet wants more mental health support. They want more addiction treatment for kids, adults, for first responders, for us. But far too many of them just don't get, at least half of them, don't get that HR 1 actually hobbles our ability to get the thing that we say we want. Have to talk about Medicaid if we're at an event and we're talking about behavioral health. It's a little past 8 a.m., so now I'm going to talk about something more positive so we can get a pep in our step. I'm going to talk about the bill that is about to be signed into law that was on the front page of the Chicago Tribune this morning. And I got to tell you, waking up and seeing the word behavioral health in a big headline on the front page of a major newspaper in this country is very validating. And you should take credit for that validation too. We need more of that, not less. So we know, at least I feel strongly about this truth, that the two main levers to get more access to care, if we're talking about behavioral health, are increasing reimbursement rates. No matter who the payer is, we got to increase the reimbursement rates, and we have to decrease the administrative burden or the red tape that providers face. And that red tape is worse for behavioral health than it is for physical health care, and it's worse for Medicaid than it is for private health insurance. So here in Illinois, we are hyper-focused on those two things. It sounds pretty boring, it's not sexy, but reimbursement rates and the administrative burden. And despite what I call the hellscape of the prognosis for Medicaid at this moment, we did just have a major victory, well, once the governor signs it, which I think he's going to do Friday, to increase private insurance reimbursement rates for behavioral health and decrease the administrative burden or the red tape for behavioral health. So let me talk to you a little bit about this bill. It doesn't even have a cool name. We just call it HB 1085. So HB 1085 creates a rate reimbursement floor for behavioral health that private insurers have to pay. They cannot pay less than. And because I know I have policy nerds in the audience, that rate reimbursement floor is going to be in the ballpark of 141% of Medicare. Why? Because Millman and Manat tell us that that is the benchmark that will bring behavioral health more in line with physical health care. The bill also slashes the red tape that providers face, for example, by forcing insurance companies to pay for multiple services that happen to be accessed on the same day. If you see a psychiatrist and a social worker on the same day, they should get reimbursed for all those services. And also, for example, by demanding a shorter and clearer timeline for credentialing. We keep hearing that 6 months, 9 months, 12 months for a provider to get credentialed with a private insurance company is hobbling providers' ability to actually provide care, which is what ultimately we all want. This bill came from the everyday experience of consumers, and let's be real, including ourselves. I'm sure many of you have experienced this. Consumers who struggle to find providers who take our insurance and all too often only accept self-pay. So with that, we are all left with a choice. Do we pay $200, $250, $300 for 60 minutes of psychotherapy on top of our monthly premiums that we are also paying? Or do we just forego care? There's very few of us that have the liberty, especially if we're talking multiple times a month, to pay that extra out of pocket in addition to our monthly premiums. So at the end of the day, not only is this an access to care victory, it's an affordability victory at a moment in time where across the income spectrum, we all need more affordability. And I'm glad that that word was in the Tribune article this morning too. So why are there so few providers in network? I know many of you know the answer to this, but it's important for us to connect the dots for the public and for policymakers. Illinois data shows that comparable behavioral health providers are reimbursed on average 30% less than physical health care providers. And I'm talking about comparable providers. Studies have been done. So we're talking about physician's assistants compared to licensed clinical social workers. Why are the social workers being reimbursed 30% less? It's because we've let the insurance companies do whatever they want. And we've never valued behavioral health in line with physical health care in this country. We are getting there. The other reason providers don't join networks, the red tape is too damn high. It is too damn high. So why would any of us, if we are providers, join a network? So in this country, even though we like to say that mental health care is health care, our policies, if you dig deep, you don't even have to dig that deep, really, it's not complicated, say otherwise. So I am so proud that Illinois is the 4th state to do a bill like this, the 4th state, a bill that sets a reimbursement floor that demands that private insurance make changes so people can actually use the insurance, when I say people, I mean us too, that we already pay for to access a full suite of behavioral health. So we're talking about New Hampshire, we're talking about New York, Washington State just did this in May, and now Illinois. And just with any really good policy, it's not gonna flip a switch. This is not gonna go into effect in Illinois till January 1st, 2027, but when it does, people will be able to better use their insurance to cover a full suite of behavioral health for ourselves, for our kids, for our first responders. I'm very excited about this bill, and I'm so proud that it passed with bipartisan support. I'm going to touch on just a few other things. I talked about reimbursement rates, talked about the administrative burden. So if we're forward-looking and we know that so many states, every state is about to have a giant hole blown in their state budget, I'm realistic. This is not necessarily the time where we're gonna have victories to raise Medicaid reimbursements, which is a key lever to get access to care. So I'm not gonna fool myself. We've gotta focus on things in the next 3 years that can get us access to care that won't blow up our state budgets even more. And I will be over here fighting to transform our tax system to get more progressive revenue, but that's not gonna happen overnight. So I'll be over here doing everything I can to reduce the administrative burden and the red tape, and that shouldn't cost money. And it's very boring to talk about, but once you get talking to providers and consumers about all the red tape they have to deal with, prior authorization, concurrent review. In Illinois, we use the IM cans. The list goes on and on and on. When you talk about it, people get really excited, well, some people. And so I'm convinced that's what we need to hyper-focus on in the next few years because it won't cost us more money, but it will bring us more access to care. The other quick thing I want to touch on that's maybe a lesson you can take to your state, another thing that doesn't cost money that will get access to care. In Illinois, a few years ago, we passed a big bill that was quite controversial that opened up social work licensure. And social workers, by the way, are the biggest provider of mental health care in this country by volume. We have about 30,000 licensed social workers in Illinois. But we got access to data that showed that for the LCSW exam, the pass-fail rates were extremely racially and age disparate. And it is not because, for example, Black men aren't ready to be amazing social workers who we urgently need. It is because the test, which is standardized, is racially and age biased. So we couldn't see that data in Illinois and do nothing, even though the company that administered the test was not happy that we wanted to change this. So we passed a bill in Illinois to create an alternative to the LCSW exam, to make sure that our licensure was based on the years of education and the field placements and the supervision that anyone getting an MSW has to go through. I know because I've done it. And this bill came into effect in January 2024. And every quarter we go back to our Illinois Department of Financial and Professional Regulation and we ask them, how many people have gotten licensed through this LCSW alternative? And we got the data last month, and in that first 21 months of this bill, 762 new LCSWs exist because they went through this alternative to the exam route. It cost us zero money. And those are all folks that would be working in the field even without this alternative, but they would be doing it not licensed at all or at the basic LSW licensure level. And it means they'd be making $25,000, $30,000 less. And so after a while, when you're making 50 grand a year as someone with an MSW doing clinical case management at a community-based mental health center, and you're dealing with all the red tape, and your kid needs to go to college because everybody deserves to have options and grocery prices are high, you look for a new field. You look for a new field. So I uplift that too as another policy lever that will get us more access to care, that will bring more people into the field at a time where we don't have a lot of extra money, and we probably won't for the next 3 years. So I have no doubt that no matter where you sit in the behavioral health space, that you too have a short list or you have a long list of lessons that you are ready to share. So at events like this, please share them. I am going to be here for most of the day because I have to show up and take in all the amazing policy things that you are doing around the country. Thank you for having me here. I'll turn it back over to Debbie.
Thank you. That was wonderful. Okay. We're running a little bit late, and Sean's going to come up, and I'm going to introduce him in 1 minute. But Leslie, I really want to thank you. I want to thank you and all the social workers. And you know, I've been saying things like, oh my God, we're in Chicago in December and it's so cold. But one of the reasons I too am a social worker is this is the home of Jane Addams. And when I was reminded about Jane Addams and Hull House and Chicago, I'm a social worker. So thank you, Leslie, for uplifting the work that we do. And everybody in this room is an advocate. With that, I am very, very pleased that we have Sean Sloan here with us this morning. Sean is the policy manager at Council of State Governments, and we've been so pleased that we have been able to be friends with Council of State Governments. And Sean's got some really important stuff, again, around Medicaid that you're going to share with us, so please.
Debbie, thank you so much, and good morning, everybody. On behalf of my colleagues at the Council of State Governments, I want to welcome you to Chicago. I'm Sean Sloan. I'm a public policy manager in the Lexington headquarters office of CSG. Excited to be here this week. It was roughly 36 years ago, give or take, that I was preparing to move up to Evanston to begin my graduate year at Northwestern University's Medill School of Journalism. So it is good to be back. I have been at CSG for nearly 20 years now. In recent years, I've been fortunate to be part of a couple of great projects we've had at CSG that touched on mental health policy. These days, though, my primary gig is putting together our Medicaid policy academies, which we do in DC in the late summer, early fall. We had a great week in DC this October. Tim Clement from MHA was one of the many experts we called on to help us assess what has been a pivotal year for the Medicaid program. Among the attendees for our Medicaid Leadership Academy this year were state policymakers that should be familiar to many of you. Representative Ed Clear from down in southern Indiana, Representative Steve Eliason of Utah, CSG National Chair Senator L.G. Sims served as one of our Academy co-hosts. Director Lizzie Whitehorn from the Illinois Department of Health and Family Services, plus Medicaid directors, administrators, and cabinet secretaries from Kansas, Nevada, North Carolina, and Wisconsin. Legislators like Representative Nicole Macri from Washington State, and of course, Representative LaPointe from right here in Chicago. And Lindsay told me this morning that one of her constituents, one of her middle-class constituents that she talked about is one of my musical heroes, Jeff Tweedy. So now I know where to go when I need Wilco tickets the next time. About a month later, it was good to see a few of those same folks at the Medicaid and Mental Health State Summit in New Orleans. As policymakers, they recognize how essential Medicaid is to mental health. As our friends at Inseparable told us in the title of a report earlier this year on what's at stake for states, Medicaid is mental health. For those of you joining us for the CSG National Conference this week, Medicaid and mental health are both on the agenda. Tomorrow morning at 9 a.m., I invite you to join my colleague Cassidy White for a session on how states are improving health outcomes and controlling healthcare costs. Then at 10:30, Gainwell is presenting a learning lab called Medicaid at a Crossroads, What States Need to Know About H.R. 1, SNAP, and Rural Health Transformation. Tomorrow afternoon at 3:15, the CSG Intergovernmental Affairs Committee and our National Director of Federal Affairs, Jay Nelson, host a panel on preparing for the impact of the Federal Budget Reconciliation Act on the states. That panel will include another veteran of this year's Medicaid Legislative Leadership Academy, Brian Sigritz of the National Association of State Budget Officers. I invite you to join me Thursday morning at 10 a.m. for our session on emerging trends in Medicaid. We will hear from another veteran of this year's Medicaid Leadership Academy, Jennifer Moore of the Institute for Medicaid Innovation. She will talk about what the unwinding taught us about Medicaid redetermination that may be applicable for implementation of more frequent redeterminations as part of the work requirements in H.R. 1. She'll highlight various community outreach strategies that states deploy to stay in touch with enrollees, as well as state strategies to mitigate enrollment barriers. She's also going to hit on a few other highlights from IMI's annual survey of Medicaid managed care organizations that she always does a deep dive on for us, and put those in the context of other challenges ahead for state officials in implementing the cuts and changes of H.R. 1, including specifically in the area of behavioral health. We're also going to have a great panel featuring the aforementioned Lizzie Whitehorn from Illinois DHFS, who was part of one of the best sessions, I think, that we've ever had at a CSG Medicaid Policy Academy this year. You know, due to the government shutdown that was going on at the time, we had to pivot from a planned session with CMS to one featuring state Medicaid agency officials, including Director Whitehorn. We will also have two state legislators from Iowa and Kansas who are part of a new program that CSG has had this year called the Medicaid Leaders Development Program. Phase 1 of the MLDP, which received support from the Commonwealth Fund, culminated in the first of our two policy academies in October. We will be continuing to support that cohort of legislators into 2026 as they engage with colleagues in shaping Medicaid policy. We're planning state visits to some key states and many other activities as part of that, so please stay tuned. But please plan to join us Thursday morning for that 90-minute session on emerging trends in Medicaid, particularly if you'd like to get a taste of what our policy academies were like this October. Thursday afternoon at 2 p.m., my colleague Cassidy White has a session called Beyond the Crisis, How States Are Advancing Mental Health and Well-Being. At 3:15, some may be interested in our fiscal forecast session on preparing state fiscal leaders for the next budget cycle and beyond. Friday morning at 9 a.m., Cassidy is back with a session on state strategies to grow the mental health provider workforce that will highlight the strategic investments, training pipelines, and innovative policy approaches that states are exploring. Also Friday, our friends from the CSG Justice Center will talk about how states can ensure that investments in behavioral health improve justice outcomes. And there is so much more as well, including sessions on housing and artificial intelligence and civility. We hope to see some of you at a few other sessions and events throughout the week. Looking ahead, I've mentioned that we have a lot planned for 2026 as the Medicaid Leaders Development Program continues. We will be planning our next round of Medicaid Policy Academies, hoping to find some dates next year that are more in the late summer time frame so we don't interfere too much with fall campaign season. Lots of other things in the works across the CSG Health portfolio that Cassidy and I jointly oversee, including something that has long been the dream of our CEO, David Atkins, a mini med school for state policymakers. We will be seeking partners to help us get that off the ground and to support our other work in the year ahead. So if you'd like to partner with us or attend one of our events, please don't hesitate to reach out. Thanks so much to Debbie and the entire MHA team for all of the great work you do in support of mental health policy. It was great hearing from and about all of these great state policymakers today. Have a great Regional Policy Council meeting, and for those sticking around, have a great week with us at the CSG National Conference. Thanks, everybody.
Thank you, Sean. Thank you. As I promised, we're going to talk about things that we know work and things that we want to see continue and things that are very important. We've heard about Medicaid this morning. We're going to hear about something that people confuse the terms for, and that's diversion and deflection. And we are so privileged today to have Jack Charlier and Corinne Vanderweel with us to talk about proven strategies for deflection on this 10th anniversary of the deflection movement. And you will soon learn the difference, if you don't already know it, and I know many people in this room do, about diversion and deflection and why they both have important roles, but there's an important difference. So Jack, Corinne, come on up. Let me come down. I don't know, is there a clicker? It should be right up there, yes? Clicker, folks? Yeah.
Who wants more PowerPoints, by the way?
Okay, click.
Yeah, there we go. Yeah. Good morning, everybody. My name is Jack Charlier, and I am the Executive Director of Task Center for Health and Justice. It's not up there. Task Center for Health and Justice is right here in Chicago, so welcome to my home city and the city of my birth. It is called the Windy City, so in Chicago it is totally okay that you show up to places, get on stages with your hair looking like this. Everybody understands it, because if you walked in that wind tunnel that was out there, this is what you look like when you hit the stage. So welcome to Chicago, welcome to the Windy City, and it's great to have you with us when you are visiting. Who has had Chicago pizza already? Raise your hand. A few, no, only a few hands have gone up. You need to go have Chicago deep dish pizza. Quick trivia question. What is type of pizza is Chicago actually known for? Deep dish is true, but it's more the tourists. Anybody know the type of pizza Chicago is actually known for?
No.
Tavern style pizza, which is what? Cracker crust, super thin crust. So go have some deep dish, but if you find tavern style, that's super cool too, and that is very, very authentic Chicago. Again, welcome. As I said, my name is Jack Charlier. Task Center for Health and Justice. There we go. Now you've got the slide up there. We are a national and international nonprofit that works operationally throughout the state of Illinois, all 102 counties, providing services at the intersection of the justice system and the treatment system. Wherever those two intersect, that's where Task works. We work with police officers doing deflection. We work with courts, jails, prisons, probation, and parole doing diversion. Corinne will get a little bit into that. Task is, as I said, headquartered right here in Illinois. So if you have any questions about Task or the work we do as an operational entity, let me know. We also are a national and international technical assistance, which is the government word for consulting. We help implement solutions at the intersection of, guess what? Public safety, public health, the justice system, your state or your county's justice system, and your treatment system in your state, county, or parish. We work very closely with the Council of State Governments. You are our close colleagues on much of the work that we do also. Want to give you a shout out. And finally, want to give a shout out to Debbie, who is a great, great, wonderful colleague. She is the gun woman. I'm the drug guy. Those are our nicknames. I always say I'm not that drug guy, but I'm the drug guy because I specialize in drug crime reduction. And Debbie, of course, brings the very powerful message around how it is that we are better able to address reductions in gun violence. So I want to give her a shout out, and Mental Health America. And we've got something for Debbie and Alicia actually at the very end, but we'll save it. Okay, with that way too long introduction, over to Corinne, who will take us through the first 72 PowerPoints, right? You're doing the first 72?
Yes,
okay.
First 72. Yes. So I'm Corinne Vanderweel. I'm a senior program manager at the Center for Health and Justice. I get the honor of working with Jack. So if you guys ever know him, you'll know how much fun that can be. So today, what we're going to go over, and talk a little bit very quickly about the federal funding cuts that recently occurred this year, why deflection matters, advocacy 101, so what you can take back to your communities and your legislators to advocate for deflection and how that applies to mental health. And then we'll do a closing and call to action. So Jack told you that we are a TA site that we do different TAs, so this is some of the stuff that we do. It is also on some of those cool one-pagers that are on your tables that you saw me and Jack passing out, so if you want to know a little bit more about that, some of the stuff that we do, this is here, or that's there too. We also do a lot of specialized deflection initiatives. We work with veterans, so we do a lot of deflection for veterans. We're also doing deflection for youth, and we do what's called Police Chief Executive Summits, so getting our law enforcement officers more bought into this. So as many of you know, this past April and this past year, there have been some significant federal cuts to our funding, and that has affected multiple different agencies, multiple of our partners that we work with, multiple of our own sites that we work with of deflection sites, and that's why it's really important for us to think about how we can kind of reimagine what we can do with the current funding that we still do have. So I'm going to lay the base of what deflection is. How many of you actually know what deflection is in the justice system? Okay, a couple of you. Some of you are like, I don't know. Lindsay, I think I actually saw you at the Capitol and told you about this. So I think you've even got my card somewhere. So deflection, and this is from PTAC. So Jack is the CEO of PTAC. That is the global field and voice of deflection. So I'm going to read off from the slide because this is like the actual official definition of deflection. So it improves public safety by referring people with unmet substance use disorders and behavioral health needs as early as possible into community-based support services treatment and away from arrest and prosecution. So usually deflection is done early on before a crisis or an arrest or an overdose occurs. So think very early on when law enforcement first meets them, when they're very early in their substance use or mental health conditions and they haven't quite fully entered the justice system. And deflection does have a variety of different stakeholders. So it's going to have the treatment providers, you're going to have law enforcement, fire, EMS. Some even have the judges and prosecutors involved. It all kind of depends on what that community wants. So understanding deflection initiatives are, they are made to identify and respond to the underlying problems. So deflection isn't just to, reactive, we're being proactive and we're really trying to address the reasons for people coming into the justice system. So not just putting them away and saying, hey, let's put you in jail. We're going to address those underlying substance use or mental health issues. I know as a former case manager for mental health court, I had clients who had mental health issues that ended up in the justice system because they had unmet needs and unaddressed mental health issues where they were either schizophrenic, didn't have the correct meds or any meds, and they got involved in the justice system in that manner. Many of them didn't even realize why they were there. They didn't know what they did wrong. So deflection, this is a way to early on address those issues and get them into the help that they need. So deflection really is a new tool for our first responders and the justice system where they can get people connected to a variety of different services, whether that's treatment, substance use treatment, mental health treatment. It can even be treatment with doctors. They also can get them into housing, other recovery support services. So it might even look like just getting someone connected into self-help groups, AA, NA, those kind of things, or any different types of services, even as simple as just getting an ID so that they can get into different services as well, them on their own. So this can be done when substance use or mental health is at play, or even unhoused. Somebody, I think it was Lindsay, who was talking about she worked with a lot of the unhoused population early on, and she saw that. And this is where deflection could absolutely come into play. So it usually happens before an arrest. So this is before filing an arrest and charging someone. Jack, feel free to at any time jump in. So, so oftentimes when people think of public safety, they think of justice system acting alone. So for you in the mental health field, how many of you feel that you work in public safety? How many would you say, like, I work in public safety? Okay, we've got one. Most of you probably actually do, because by addressing those needs in the mental health world, you actually can help address public safety. Like I said, going back to, as a case manager, my clients that had schizophrenia or had other unmet mental health needs, they became a public safety risk, right? That's why they ended up in my care, and that's why they were under my case management, was because they became a public safety risk. But by the time they were done with my program and they had addressed those needs, they were no longer a public safety risk. And that's where deflection really comes into play, is where we're supporting public safety through public health. So if you're wondering kind of like for prevention and the justice system of where deflection kind of lies, so think about it. If prevention, prevention is wonderful and it's a great thing and we need prevention, but oftentimes prevention tends to fail, right? Somebody's going to end up using substances, but before they get into the justice system, there's often a time where people are using substances, they haven't gotten caught, they aren't in the justice system yet. Maybe they've come in contact with law enforcement or first responders. Those are the opportunities. Those opportunities where they're coming in contact, but not being arrested. Maybe it's an overdose. Maybe it's just a, hey, can you check on this, of a welfare check. It's those calls where we can get people connected to services, where prevention has failed, but they still haven't entered that justice system. So how many of you know what diversion is, at least? Justice system diversion? Okay, good. At least we've got a good amount of you that know that. So there is a difference between deflection and diversion. And deflection is going to be on in the green there. So some of the differences between deflection and diversion is that deflection is pre-filing. So it's before charges, before we've filed anything, before they've even been arrested. It's also much more community-based. So with deflection, we're keeping people in the community. We're keeping them at their homes, at their jobs. We're keeping them with their families. It's also community-based driven. So instead of diversion, where they have that probation or parole officer, or when I was the case manager, it was the case manager that worked for the courts, that they're the ones saying, hey, you have to go to treatment, you have to go to do this, you have to do that. Instead of that, we have the behavioral health provider saying, this person actually really needs this and would benefit from this. No, this treatment wouldn't work, so let's not try that. So it's all based in the community, in the community and the community service providers. So instead of the justice system having all that control and saying, well, maybe you returned to use one time and failed, you're going back into jail. With deflection, they don't have that. It's how can we support you? And it's also optional. People participate. They do not have to participate in deflection. It's optional for them. Whereas diversion isn't usually super optional. It's more like the judge said here, I'll give you an option to either go to jail or do diversion. Not super optional there. So deflection really is all about building this bridge between the public health system or the treatment system and the justice system. Jack, you explained this amazingly yesterday in a way. I've been working with him 3 years, and every time I listen to him, I always learn something new. He said in law enforcement, they already have a bridge built of when law enforcement comes in contact with somebody and when they bring them to jail and arrest them. They have that bridge built. They do not have that bridge built that is from when they have contact with them to treatment providers. And that is what deflection does, is building that bridge from law enforcement to the treatment providers and connecting them. But with deflection, law enforcement only does 1/10 of the work. And really, that's all they need to do. While the treatment system does 9/10 of the work, because that's where the most benefit comes, is from the treatment providers. So with law enforcement, all we want is to leverage their contacts. Like I said, oftentimes people with SUD, behavioral health, come in contact with law enforcement before they seek treatment. As a former law enforcement myself, I know that. I saw that often, where you come in contact with them in a variety of different ways, where they haven't sought treatment, they don't think they're that bad yet, whatever excuse it is, they haven't sought treatment. So that's what we want, is leveraging those contacts, because law enforcement comes in contact with them first and early on. But we also need those interventions, because we can refer people to services all we want, but if there aren't those actual interventions, if there isn't that treatment, there isn't those medications, that connection to different services, housing, whatever it may be, there's never going to be a change, and they're still going to come in contact with law enforcement. So we absolutely need the interventions. And one other thing that is actually super important in deflection is having what we call deflection specialists, or relentless engagement. So when the officer comes in contact with someone, instead of just referring them just to a treatment provider and saying, hey, you know, over here we'll take Bridgeway in Illinois. If you guys know Illinois, Bridgeway's a big one in Illinois. So instead of saying, hey, you should go to Bridgeway, actually having someone there say, hey, let's go get you to Bridgeway, let's make the call together, let's fill out the paperwork together, let's get your ID, because you need an ID, you need insurance, whatever it is. Let's get you transportation to that. Let's walk you all the way through, all the way across that bridge. Again, that bridge of law enforcement to treatment. How can I help you? How can I walk you there? Calling and saying, hey, I know your appointment's in 5 days. Are you ready? What can I do for you? If there is a long wait time, getting them connected to other services, and just being that trusted person to engage them. And that is what's key with deflection, is that engagement. And that is where you get higher rates of people going into treatment. So deflection really is all about the numbers. So in post-adjudication, we can get to about 6.9 million people to get them connected to different treatment services. Pre-adjudication, we get 10 million. How many do you think we could get connected to services if we do pre-arrest, before they even get arrested? This is you've got to somebody's got to participate. 17 million? Okay. Any other guesses? 20 million. 61.5 million. And remember, if we get to people earlier on in their substance use or mental health, oftentimes it's less treatment, right? If they're really deep into a substance use disorder, oftentimes they need inpatient, but if we get to them earlier, we actually can use less, there can be less treatment involved, right? Maybe it's just IOP, even some people can get back on with just support groups, so it's actually saving money as well in that manner. So why deflection matters. So law enforcement actually can strengthen deflection. They are, as you saw, one of the main drivers that we do need, because they can spot those behavioral health concerns early on. Whether they know what exactly they are, we don't want them to diagnose, to say, I know this is substance use, mental health, whatever. They may not be able to tell the difference, because the mental health sometimes can look like substance use to officers and vice versa. But they can see, like, hey, there is something at play. There's something going on here. And we really want to leverage that so that we direct people to different treatment and to different services. And this actually can help establish for a lot of different communities that deflection and getting people into treatment and that public health approach to public safety is actually part of their culture. And it can actually turn the culture and the response from the community into a more positive manner. So officers actually can be catalysts of the community well-being. So they can model that compassionate care instead of always going towards an arrest or whatever that may look like for them, if it's always just going to an arrest or transporting to a hospital. It shows that they care. Often law enforcement go into it to become people that can help each other and that can help the community. For me, that's what I did. And they get stuck in the cycle of all I do is arrest people and bring them to jail, and then they're out and about again and nothing changes. So with deflection, that helps them be able to actually make a change in someone's life. And that can have a huge community impact, not only in the community for the officers themselves, but the community at large, because the community of law enforcement officers will see that this has an impact and makes an impact for some of the people that they have come in contact with. But it can also make that community impact of having that, seeing that officers are making a positive impact and are actually helping in the manner that we're hoping to. So deflection can show other partners as well that early intervention works. Like I was saying, getting help earlier actually can be a reduction in cost because there's going to be less treatment needed oftentimes, or less contact with the justice system, whatever that may look like. Deflection helps build a more coordinated response because you do have that deflection specialist, that case manager that's there helping that person get from law enforcement and coordinated into the different services. And they can help them, figure out what's the best route to go there, what do I need, so that it's a quicker way into services as well. Jack, now it's over to you.
Thank you. How many of you have spoken on stage before? Raise your hands. This light is a monster. So I want to tell you something. I've spoken on stage, I've been on TV, all that, and I don't say it with any arrogance. I've been like, am I being interrogated? Or what is it with this light? I'm mesmerized. So, all right, thank you, Corin. Corin's got shiny shoes. I do not. So I hope that what I say is as interesting. I want to begin my comments, which kind of follow the slides, kind of not. I know you guys can all read, so I tend not to read the slides. I take the angle about advocacy for any kind of thing, because this is now the advocacy portion. You're all advocates. I take the angle as follows. Think of the average citizen. Think of the average elected official, and in this case, because we're going to talk about law enforcement, and I come from law enforcement also, think about the average officer. So for advocacy, right, advocacy to them, what would the average officer think about this? What would the average elected official think about it? What would the average citizen? And what I mean by that is with the multitude of things that those three groups, right, they're people, but those three groups have coming at them, what resonates the most? Not what resonates the most for me as someone who believes in deflection and works at the intersection of public health and public safety and treatment and justice. I can do all that stuff all day. It's irrelevant. So as you see kind of what we've put together for you, that's the approach that I take to this, is someone who's super busy and has tons of things on their plate, what is going to cut through and get to them. So I won't read the slides. I'll hit a few points, and then I am very interactive, so get ready to be asked some questions and to answer them. And I should acknowledge Lindsay, who you heard from earlier, is a longtime colleague of mine. She's also my state rep, and I don't treat her any differently because of that, and that's honestly, but a longtime colleague of mine, and she is a huge advocate, as you already know, for you and your work and for deflection. So I do want to give her an honest shout out. I would not say that if that were not the case, right? We don't ever do that for elected officials, but I do want to give her a shout out because she is a great, great advocate for the work. So let's start here. How mental health partners can engage law enforcement. How many of you have done, again, you can read the slides. How many of you have done engagement with law enforcement, say chiefs, superintendents, commissioners? Raise your hand. Okay, good. Number of you. Shout out one or two things that you have used that might be different than what's up here, or have you used some of what's up here? What did you use that, I know it's not like this. Oh, I said this and then this happened, but what did you find to be good arguments for you? Just shout it out, please. Or maybe you had no success, in which case we do need to read the slides. Say it again. I love that. That is something the average officer might or might not think about, and that's because they're doing their day in, day out job. But if you're dealing with chiefs and superintendents, efficiency, and you know what that translates to for the police, how many squads vehicles do I have available to me at any time to respond to calls? And the longer, it's called squads are down. When a squad is down, the car is unavailable to do what? Other stuff. You're calling. They're unavailable to do other stuff. Deflection. So again, you can read the slides. Tucson Deflection Initiative, one of the better deflection initiatives, if not one of the best in the United States. I say that because I don't really like ranking things. Part of the work they did was to show that an arrest takes about twice as long as a deflection, about twice as long with the same outcome. Isn't that cool? So if you're talking with chiefs, the idea of efficiency as in how many of my officers are available to do the work, that's a big point. That's a big point. One more of you who raised your hand who said, yeah, I've talked to chiefs, superintendents, commissioners, and what did you say that said, boy, that seemed to land? Yep. Saving money. Okay. Yeah, save money in the budget, and I think the way I would reframe that, and that's excellent, is you could hire more officers, you could buy more squad cars, you could buy more body armor, things like that. Absolutely. Because saving money in and of itself, I think, is a kind of a cliche, right? It's a cliche in that, well, we save money. Well, the county did, but the city didn't. You all know all that, so I'm not going to say it. Right, exactly. So I love that. So what all this slide is saying to you is kind of taking your experience and giving you some items that we have found over the years. Fewer repeat callers. I said I wouldn't read them. I said I'd point out a couple things. Fewer repeat callers tying up units. In the world of drug use and mental health, and I'm going to stay in the non-crisis space, do not be in the crisis space. In the non-crisis space, as Corin said, as I think many of you know, officers are encountering all day long people who have mental health issues, substance use disorders, and it takes them a lot of time, and there are the repeat calls. I know you know that. That is a talking point to say deflection in your community, chief, will help your officers focus on the things for which they became officers, which is to go get the bad guys. There are people who have done bad things for whom arrest and incarceration is fully and totally appropriate and makes sense. And your officers are not spending their time with them, and we know that because they're responding to low-level calls that are generally not about things that are related to actual criminal violations. And that's an important thing to say, but say it from the standpoint of not tying up their officers, right? Okay, let me pick out one more here, and it's going to be on a workforce issue, which is an issue you face. And guess what? Everybody's facing a workforce. I have no idea, by the way, post-COVID, where everybody went. Like everybody's short workforce. Hotels, police, mental health. I don't know where everybody is, but they're gone. Understaffed patrol. So another way that you could go at this from deflection, from the standpoint of the idea of why would a community want to do deflection is, Chief, how many vacancies do you have right now? And she's going to say, I'm 15% vacant. I've got 20 people ready to retire, and the pipeline isn't ready to go yet. Those vacancies are a huge problem for them. Is the workforce shortage a problem for you or not? Raise your hand. Maybe it is, maybe it isn't. Just a few in here, okay. I will tell you that in the world of SUD, which is mostly, again, I'm the drug guy, mostly from where we come from, it is a huge and major problem. We do not have the workforce sufficient for the demand. Forget the need, just the demand alone. The need is much greater always. But police right now find themselves in a fairly serious workforce issue. So you could go at it from that standpoint. So again, just pointing out a few of the ones that you might not otherwise think of. Okay, where's the clicker? There we go, cool. Leveraging law enforcement. How many of you have had a police chief, and I'm just using that, doesn't mean that there aren't others within the policing world that could do this, have had police chiefs stand up for you at a press conference and speak on behalf of, maybe not a press conference before legislators, before the public, and speak on behalf of the value and importance of your issue? Just raise your hand again. Just a few, okay? So again, it's good because if only a few hands goes up means this is new material. Like we're comedians. This is new material for you. It's new material. So this is new for you. I want you to engage your law enforcement leaders after you've established a relationship with them, after you have found a shared way in which to message and understand each other, not from your standpoint as an advocate. I don't want you to do that because all you're doing is bringing to them all the stuff they've heard. Bring to them the angle and the approach that resonates with them. Then, once you have that relationship, and it's just that easy, right? Go in, 5-minute conversation, this will happen, is I want you to have law enforcement stand up in front of your community, in front of the press, and in front of the legislators. Why? Because survey after survey after survey tells us the law enforcement across both political parties, Democrats and Republicans, African Americans, white, Latino, yes, that's true, all different parts of the country, ranks almost always as one or two as the most trusted institutions in the United States. Always. Like we see these polling done all the time. Specific communities here and there, it will vary. I'm not saying that. But I will tell you that if you are not engaging and leveraging your law enforcement leaders to stand up in a uniform in front of an audience, all of whom knows them. Judges, they might not be known. Prosecutors, they're elected, who knows? Prisons, probation, parole, nobody in the public knows anything about that. They don't care. It's not really relevant for the most part to their daily lives. But the police are. I'm asking you to go and make the good argument, then listen to what they say to you and come back to them with something that will help them, and then get them to stand up in front of this light, because if anybody will stand in front of this light, you know they're on your side, and have them advocate for you. It is powerful. Back in 2016, 2017, one of the groups that works in the field of deflection had a conference of police chiefs standing up talking about why Medicaid mattered. That was like stunning. And guess what? Lots and lots of people showed up. If treatment leaders were to do the same thing, almost nobody would show up. I'm just being honest, like almost nobody would show up. If you called a press conference and said 3 police chiefs are going to speak about deflection, about mental health, about their encounter, people will show up, the press will show up. You can put treatment leaders, put the same press release, same press advisory, probably no one's going to show up. Just calling it like it is, right? I don't even know if press conferences exist anymore nowadays anyway, but I'm offering you that leveraging your law enforcement leadership is super important. While the boxes up here you can read, I do want to tell you the field of deflection is about 10 years old, so it's a very young field. How many of you have heard of drug courts, treatment courts, mental health courts? Okay, those go back on the order of already 30 years. So I like to say deflection at 10 years old, we're like second or third graders. We hopefully act a little bit more mature than that, not always, but we're in about second or third grade age-wise. Mental health courts, treatment courts, Judge Leifman on the mental health side, drug courts had their own kind of genesis. That's 30 years, and everybody wants to like be that now. If you know crisis intervention teams, CIT, 1988, Memphis, that's going back 40 years, right? So deflection is still young, yet the fact that it is still young, the foundation upon which it's built, which is early outreach and rapid and continuous engagement with people in the community who have mental health and substance use disorder, but not at the crisis point. We have 5 decades of research, and you all know that better than me. I'm not a researcher, I'm not a clinician, nor do I play one on TV because I'm not on TV. But if I were, this would be my show. My show would say, we have 50 years of data that tells us what you guys already know better than me, that if we get to people early, and we engage them, and we get them rapidly into treatment, and we keep them into treatment. And I'm using treatment as a proxy. Everybody just chill. It's a proxy for all sorts of stuff. Different crowds react to that differently. We know that we get better outcomes. Deflection works. We have about 100 evaluations on the field, which is not a lot. It's not a lot. About 100 evaluations, some federal research going on. No surprise, it works. Why? Because we have 50 years of your effort, your work in your field that already tells us rock and roll. We know that if we get to people early, this will work. Okay, do I want to pull anything out here? I think, again, that top right one, if you're talking to law enforcement, which is a big part of this, the time that it saves police departments. Okay, this is not my slide. I think I saw it first this morning or something like that. Corin's laughing at them like, okay, I'm before a mental health audience. I don't really know mental health. Again, I'm the drug guy, so I'm not sure about this. Is this slide correct or not? What do you think? I'm being honest. Like, what do you think? Is this a good slide or is it not a good slide as you read it? You guys are the mental health experts, and I'm not being funny. Okay. Good. Well, let's just skip it then. How about that? We'll just skip it. I'm not sure what it means, so we're going to skip it. Okay. No, sir. I'm sorry? It's what? CIT stats. Okay. Yeah, and I do have some words to say before we head to close about that too. So healthier outcomes, lower costs. Again, the idea here is everything that you know already, is the saving of money, is the better outcome. You all know that already. The difference is that the audience you're going to bring it to is law enforcement. Law enforcement 20 years ago, and I say this generally, I'm talking about all law enforcement, not just police, right? All police are law enforcement, but not all law enforcement are police. If we work in the field, kind of that's the thing to know. But nonetheless, for all law enforcement, 20 years ago, the idea of law enforcement working with public health was a joke. It was laughable at best, right? CIT was in its early stages. Anyway, that was about mental health crisis, and that was really how to make sure the officers weren't hurt, the individual wasn't hurt, and that was it. That was really kind of the initial focus of it all. 10 years ago, the idea became that, yes, there in fact was some important work that could be done underground by, and I'll say public health and public safety, mental health mostly. This is when deflection kind of started working together with law enforcement. But it still wasn't widely accepted. I can tell you now, on the 10th anniversary of the word deflection, the field of deflection, and the movement of deflection, that law enforcement is entirely on board with the idea that for them to do their work better of public safety, that's their job. They're not here for public health. They're not here for public health. Don't make that mistake. They are here for public safety, that they need you. They need Mental Health America. You are at a moment in time, ladies and gentlemen, where you engaging with law enforcement, and very few hands went up when I asked that question, is something you now need to do. They are ready, they are prepped, and they have some understanding of it. They don't need to have a lot because they've got you. You don't understand how to arrest someone, how to book them, how to do and execute a search warrant, right? You don't need to know that. You are prepped for them. They are prepped for you. Please, if there's any call to action that comes from this time with me, I even put on a nice tie for you guys. I wasn't going to, but Debbie's here, so I'm like, I'll put on a tie. Please, when you get back home, wherever that is, go see your police chief, go see your commissioner and say, this is who I am. I would like to work with you. I'd like to talk to you about this thing called deflection. And I think that working together, we can have a shared space around shared goals. Quick anecdote, I had asked earlier, and again, because I sit on the drug side more than the mental health side, I had asked about drug courts. How many of you know it? Almost every hand went up. I can tell you, so my justice career is about 30 years on. My focus is on crime reduction, drug crime reduction, and reduction of victimization by people who use drugs, misuse, drug addiction, are in the drug trade. Like, it's a serious, very serious problem in communities, the harm that's done all around. I'm very clear on that. When the drug court movement started, it was laughable at best to have judges say, why would you have a team in my courtroom talking about something different for how we treat drug offenders? That's the language that was used. Now it is the feather in their cap that they want, right? Like a judge wants to be something, they want to be a mental health court judge, they want to be a drug treatment court judge, no longer called drug court. That's the specialty courts that they want. But it did not used to be that way. Deflection is very much in that direction. We're at about 1,600 to 1,800 sites across the United States in about 10 years. This is not said competitively, but compared to the speed at which drug courts moved and CIT moved, we will in 30 years outpace the number of drug courts, and in 30 years is in 20 more to go, and the number of CIT sites. I don't say that in a competitive way. Those are my very close colleagues. As a criminal justice guy, those are my close colleagues. I say again, and I'm repeating, that the time is right. The space is now for you to go and meet with your law enforcement leadership and open up the door to collaboration. Is that fair? Good call to action? Super simple? Cool? Okay, we're going to take some questions. I have one last thing I want to say about Corin's presentation. Not about her presentation, but about the word that I want you to leave with. So the call to action is go to your law enforcement leaders and go ahead and introduce yourself to them and say, I'd like to do something together. By the way, this is also about talking to legislators. We've got a legislator here. I think she's probably better equipped than I am to respond to messaging. Anyway, all politics is local, so you really do have to know what's going on there in that regard. I want you to think of the word early. So Jack said we're going to go do deflection. Cool, that's one thing. The second is I want you to think of the word early. Why? Because you are my colleagues on the mental health space. And if there is a space that I don't want you to get confused in, is that deflection is early, whereas much mental health work with law enforcement has been at the crisis space, That is good work, it's important work, it matters. Absolutely. Deflection says we can go earlier than that. We can go much earlier than that. Why? Because in the United States, and most people do not know this, when the police encounter someone, they encounter someone, they don't arrest them the majority of the time. Did you know that? The majority of police encounters with the citizenry in the United States does not result in arrest. The numbers vary by community, but it can be high as 60 to 80% of encounters are not involving arrests, right? Most of the public thinks an officer sees someone, they arrest them. That's crazy because we'd have everybody in jail at some point. I've been encountered by the police, right? It's not the case. It is those encounters where no arrest is an arrest and charging occurs. That's where I want you to speak to. That's where I want you to continue to think, hey, on mental health, we want to think of crisis, absolutely, but I want you to get up early from that. Get up early and go earlier than that when you're meeting with your law enforcement leadership and also your elected officials and say, I'd like to talk to you about early encounters, Chief. Commissioner, I want to talk to you about these early encounters where your officers are not arresting people, but they're smart. Officers are smart. They already know that something's happening, and they're going to see him again. And the next time or the time after that, it's going to be the morgue. It's going to be a real run where now we've got to arrest someone. It's going to be an emergency room or some kind of crisis. Deflection says, and I'll close with this, the motto of our field in deflection is, why wait for an arrest? Why wait for a crisis? Keyword, an arrest. If we said the arrest, it's inevitable. Through the work of deflection and what's going on in the United States right now, those early encounters are flipping the script and flipping the narrative that there will be no arrest if we do our work early and not wait for the crisis, the overdose, or the situation to occur. Fair enough? Cool. Now, I want to do something because our time's almost up. Debbie and Alicia, would you guys come up just very quickly? And I'm glad to take questions because we actually have a couple minutes. Debbie and Alicia we're part of PTAC. The Police Treatment and Community Collaborative, which is the global voice of the field of deflection. Debbie just stepped down as our secretary of the board, so I want to acknowledge that and say thank you. And Alicia and Debbie were with us. We are a global movement. They were with us in Kenya last year when we did our Deflection African Summit. And so I have for you we just came from New Orleans, like literally, where we celebrated the 10th anniversary of deflection, and I have for each of you the PTAC pin, well, each of them, not each of you. The PTAC pin, I know that was like a bummer, like, oh, he's got something for us. He's such a nice guy. Oh, no, he doesn't. Okay, forget it. I've got for each of you the pin celebrating the 10th anniversary of the word, field, and movement and deflection. And Debbie, for you in particular, thank you for your leadership in PTAC and the global movement. Thank you.
Thank you, Jack. Thank you, Corin.
Absolutely. There you go. Yeah.
Thank you.
Absolutely.
You
We
know,
have time
and
for a few
you
minutes
guys
if you
haven't gotten rid of me.
No.
And what I have said to Jack since the minute I met him, and thank you, Ben, for introducing us to Jack, is that whenever we talk about substance use disorder, we have to talk about mental health. And
Yes.
whenever we talk about mental health, we have to talk about substance use
Yeah.
disorder. So thank you for the partnership, and
Amen.
thank you for the gift.
Amen. Amen. Yes. Very good.
Do we have time for
have a couple
questions? I
minutes?
can't
Just a
see
couple questions?
anybody out
I
there.
think
How are we
so.
doing? All right,
Yeah.
Barbie's got a question.
A couple
so-
questions,
Get away.
please. Yeah.
Do we need a
Only
microphone?
easy questions, though. I don't drink Diet Coke till 11 a.m., so easy questions, please. Do you need the microphone for the audio? Are there, okay, I don't know if there's audio.
I'm bringing it, Barb.
Okay.
Getting judges in drug court to understand the current treatment? It does often include buprenorphine, and allowing that as part of the regimen for drug court. We have a tremendous problem with a lack of understanding, even through education, of allowing people to really be able to follow the regimens of which are not current with clinical indications necessarily.
Yeah, so judicial discretion. Everybody knows what discretion is. We all want it in our job. There's law enforcement discretion, judicial discretion. It exists, and it's just part of the U.S. justice system. What I would say from a process standpoint, I'm a technical assistance provider. From a process standpoint, I would go, so this can be a bad answer. I would go to All Rise, which are the folks, you know, who provide really leadership like PTAC does for deflection. So I would go to All Rise, and I'm glad to do that connection to you. I know them, and they're great, great colleagues. I would go to All Rise, number one. Number two, the judicial landscape is a very education-oriented landscape. They're very deep into that, and like all professions, they're deep into hearing from each other. So I'd go to All Rise and say, here's a problem I have. How have you addressed that? and they will help you with that. And then the second thing, I would go to organizations like National Judicial College, which is one of the training organizations for judges, and I would bring that to them. And third, in your state, what state are you with?
New Jersey.
New Jersey. So the New Jersey has some kind of administrative office of the courts. And those are the routes where you get them, number one, to know what is the legal landscape that might be preventing that, or might not, right? It might just not. And then two, go the education route with judges. That is a profession uniquely wired for professional education from peers in closed settings. That is how they do their best learning. So I'm giving you a process answer of how I would approach it, and we have done that many, many, many times. Usually it's not awareness of how medications work, addiction, treatment, things like that. It's not generally ideology or obstinance. It's just didn't know, didn't understand, and no professional legal body has offered me the guidance on that. Does that make sense?
Yes, thank
Yeah,
you.
yep,
Really helpful.
Yep.
No, we're out of time.
Oh, there's one more question. Is that okay or not? Oh, okay, we're out of time.
So, yes, so I will be around for the rest of the day. So if you have questions, please feel free to find me. I do have the sparkly shoes on, yes, as Jack said. Jack will be with us just a little bit too. So we are more than happy to take questions on the side or give our card to you.
Thank you, Jack. Boy, am I a lucky woman to have such wonderful friends, I gotta say, from everybody in this room. It's really been wonderful. And speaking of wonderful friends that we've known for a long time, I am really excited to have Dr. Eric Rafalayan here with us today. Eric, where are you? Oh, there you are. We in advocacy know Eric from when he was a congressional fellow and did phenomenal advocacy, especially around 988. And now he is helping everybody in the country, but especially psychiatrists, his profession, really understand about ways to talk about, here we are again, what works, how we show what works, how we keep having what works work. So please help me in welcoming Dr. Eric.
Trying to customize this for my height. Let's see if it stays up. Can you all hear me okay? Okay. Good morning, everybody. So as mentioned, my name is Eric Rafalayan. I'm a psychiatrist. I'm based in San Diego. I'll just start off by saying I wear a lot of different hats, so my comments today are on behalf of myself and the Committee to Protect Public Mental Health. So I'm not the state of California, not the American Psychiatric Association, not the VA, but happy to talk about other roles as well. So starting off, let's see, clicker. Is it the screen button? Okay. Other green button. Okay, there we go. So responding to mental health misinformation. So there has been a lot of stuff out there, especially in the past 12 months, but really over the past few years, about what works, what doesn't work, what mental health means, what a diagnosis means, what psychiatric medications do or don't do, what causes mental illness. And so today I wanted to spend some time not necessarily rebutting or responding to every single thing you may have heard on social media or coming out of the federal government, but really to help us reframe and talk about what are 3 things that we really know about mental health and mental health treatment and what matters for people living with mental health conditions and professionals that are trying to support those folks and their families. And so there are also leave behind materials which you can use. I was told they are on a QR code on your table, but if not, I also have a few hard copies here and they are on our website. So we'll get to that in a little bit as well. So do a little bit of call and response, a little early. We'll try and get it. And also coming from California, we're 2 hours earlier than this. So the greatest barrier for Americans seeking mental health treatment, by and large, no matter the demographic, no matter where in the country, no matter what political party, no matter your age, what is the greatest barrier to mental health treatment? There we go, lack of access. And so I also realize that I'm talking to an audience that understands some of the nuance, but what we're trying to do here is not necessarily re-educate, but help reframe some of these so that when you are talking to a journalist, when you are talking to an elected official, when you are talking to families that are really confused because they are just seeing all this stuff on social media or online or in the news, that they can help understand, okay, well, these are things that are true, that matter to us, and are things that we need to make sure people understand. And so one specific piece of misinformation that's coming out is that, well, one of the greatest barriers is that people are over-medicated. And yes, there's a kernel of truth in here that we want people to be on the right medication for them and no more than that, and medication may not be part of everyone's mental health journey. But this is now conflated until we're spending at the federal government a lot of time and energy chasing down these, in some ways, these kind of ghosts of problems. And so access, not excess, is the true crisis. And millions of Americans of all ages cannot get the coverage that they need. And really also the care that they need. And this might be because of coverage issues. This might be because of workforce issues. So maybe you have insurance coverage, but you can't get the care you need with that coverage. And framing the problem as over-medication really distracts from this major issue, which is that a significant number of Americans, and perhaps up to half of American adults, cannot get the care they need for either a mental health condition or a substance use disorder. And so I work as a psychiatrist primarily with folks with more severe disabling mental illness, so often that's the emergency room, that might be an inpatient unit or a residential program, also at the intersection of 988 and crisis services, so I really appreciate the points we just heard about collaborating with law enforcement. When someone comes in at the point of crisis and we still can't get someone, and the best I can tell them is, okay, you're here at the emergency room because you are withdrawing from alcohol and you're trying to get help from that, and the best I can give you is say that, well, here's a piece of paper with a number that you can call a program, and they'll tell you that the wait list to get into the residential program is 6 weeks. Good luck, and we're going to send you out of the emergency room now. And so this is what people are dealing with in California, which we might say is a high-resource state or a state that has really tried to invest in services. And so this is the problem that American families are facing. We've heard some about Medicaid, and I want to really hammer this point. Supporting Medicaid supports the mental health of Americans. And the #1 coverage provider of mental health for children and adults in the United States is Medicaid, no matter what state you're in. And this is something I think that gets lost when we talk about, well, who benefits from Medicaid and, well, what does Medicaid really do? Supporting Medicaid supports the health of America, including the mental health of America. And approximately 1/3 of the individuals that rely on Medicaid or are covered by Medicaid are children. This is also another major fact that also people don't understand or are in some ways misled to think that, well, the people that are on Medicaid are just people that didn't work hard enough to get their own insurance through an employer, or there's some types of implications around that. But really a substantial number of the folks that rely on Medicaid are children. And then in addition to protecting Medicaid, there are other interventions and that the data show us do work for expanding access to care. So mental health parity laws, so that is treating mental health the same as physical health in terms of how they're covered by insurance. Workforce investments, and you'll probably see a theme that you've heard this from other speakers this morning or the other legislators, because these are what the data shows, and what we need help with is helping the broader public understand that we know that these issues are out there, everyone acknowledges that, and this is the way that we can get there. Not by saying that Tylenol is causing autism or these other kind of distractors that are out there that are really taking away our attention and energy from working on the things that we know work. So workforce investments, telehealth, which is really often the only way that folks in rural communities can get access to specialty care, or folks that are elderly or have more disabilities and unable to travel as frequently, and reducing stigma and discrimination. So you may notice that some of those stickers on your table have some of those same messages as well. But these are things that we know work, but the bottom line under here is that access is the #1 issue affecting American families who are trying to seek care. Okay, the #2 point that I want to talk about now. Psychiatric medications are evidence-based, and political attacks recently are misrepresenting this evidence. And so what does evidence-based mean, and what are these medications for? So we'll talk a little bit more in that details. But broadly, all medication, whether in the United States, whether for a mental health condition, for cancer, for diabetes, for stroke, it goes through a very rigorous FDA process. And this process is so rigorous that the majority of medications that are developed actually don't make it to market. Like a physician cannot prescribe them because they didn't pass these multiple, very expensive processes that they have to do to get approved. And so they have to demonstrate both efficacy and safety. And the trials happen the other way. They demonstrate safety first. So first say, is this safe, and theoretically, can this work, and does it scientifically make sense? Then in animal models, is it safe? And then in humans, is it safe? And then in humans, does it work? And so it has to pass all of these 3 trials at substantial numbers. And so what you can know is that there's a very data-driven, expensive process in place to make sure that once the medications get to you, that they have passed this process and they are both safe and effective. So that's why you hear that term, safe and effective. That's the FDA process. And what we also know in the field is that these medications can be life-saving for people. And it's not just something that you take because it's fun to take. You take because this really helps with something that otherwise can be profoundly disabling for people, whether that is depression, whether that's substance use disorder, whether that's schizophrenia, whether that's bipolar disorder. And we also know that for folks, these medications might be the difference between them being able to have the quality of life that they want, to have a family, to have a job, to be able to go to school, or to not have that, and to be in and out of the criminal legal system or in and out of hospitals. And so for some people, these medications make a really big difference. For other people, maybe medication isn't the primary support, or maybe it's not even a piece at all. And there are other parts of what we would consider a comprehensive mental health treatment plan. So that could be therapy, that could be social support, that could be peer support specialists, this could be exercise, could be nutrition, could be other interventions. But what the data shows us is that for folks that have the most disabling symptoms, having all of these together works better than either just one of the pieces by themselves. And medication is a piece of that. Another thing that I want to talk about is, so all medications have a balance between, they have a benefit and they have a risk. And so for a good physician, they're always balancing, okay, for this particular patient in this particular circumstance, what is the ratio of the benefit and what is the ratio of the risk, and what is the right balance for this person depending on what their priorities in their life are. And one of the things I want to leave you with is that for the most commonly prescribed mental health medications, psychiatric medications, the rate of side effects is actually quite low. And the side effects are actually generally either uncommon or not that severe. And a data point here, so we actually have data on this, like what types of medication interactions or side effects bring people to the emergency room. And so there's actually a top 10 list. Many of them are related to blood pressure or stroke or other common conditions. And these top 10 lists account for 75%, so the majority of all of the reasons why someone would have to go to the emergency room because of they're having some sort of medication-related effect. And none of those top 10 are psychiatric medications. And so when we hear, well, it's this, psychiatric medications have side effects and this, again, there's this kernel of truth, this ghost of truth that yes, all medications have side effects or the potential for side effects. So we don't want to, be unclear about that. But the rate and the severity gets really, this is where the misinformation, disinformation comes in. Because what about all those other medications? Do we see people fear-mongering about the side effects of diabetes medication or the medication for your stroke, and so therefore you just shouldn't take medication and you should just live with your untreated diabetes? So we don't hear that in the same way, and there's this stigma or discrimination around mental health conditions that continues to be prevalent in how people think about medications, and also, unfortunately, how the federal government is messaging about many of these medications recently. So I apologize, some of it looks like it got cut off there, but other overall risk profile for SSRIs and other commonly prescribed medications is similar to that for other chronic conditions like diabetes and stroke. Diabetes and high blood pressure. One particular piece I wanted to leave, the FDA a number of months ago, it all is kind of a blur, all these things are happening, had convened some sort of panel of experts, or what they determined as experts, to talk about the risk of medications for pregnant people. And they messaged out some sort of conclusion that medications were not safe in pregnancy. And again, this is a really information to the point of disinformation about what the evidence actually says. So the evidence tells us two things. One is that the number one cause of pregnancy-related death is a mental health condition or mental health-related reason. So this is actually really scary, and many people don't realize this. But again, there's this like the stigma, this discrimination about how this is talked about, how families talk about this, how people understand their own symptoms and explain or express when they need help. But this is really scary to know that something perhaps partially preventable or fully preventable is the number one cause of pregnancy-related death for pregnant people. And for those that need SSRIs or antidepressant medication, again, peri-pregnancy, perinatal depression and other psychiatric conditions are really serious. Actually, the highest risk time in a woman's life for her to have mental illness, is just kind of statistically, is in the time while she's pregnant and the 12 months after. So this is the highest risk time for that woman to have depression, to have a psychotic illness, to develop bipolar disorder. There's a lot of hormonal changes, there's a lot of social changes, there's a lot of life changes in that point. And so this is just kind of a confluence of a lot of different pressure at once. And so for that person, medication may be something that makes a big difference for them and their family. We also have data now on kids that are born to mothers who are suffering from depression or other conditions related to this pregnancy. And those kids, it turns out, do worse. Not related to medication, but because mental illness is kind of stealing away the parent's time and energy and attention, and the developing child doesn't get the benefit of that. And so when we talk about these medications, they really not just benefit the mother, but also the child and perhaps the whole family. So these are two data-driven points to know just when we think about, okay, for a pregnant person, that person should be talking to their specific physician to determine what's best for them and their family in that moment, rather than it being, I'm scared about this medication in general because I don't know what it's going to do. Okay, another question. High quality care depends on, and I've kind of been alluding to it a little bit during this discussion, and it's kind of a trick question because it could depend on a lot of things. But I think something that high quality care cannot exist without is shared decision making between the person getting care and their chosen health professional. If we lose that, then it's really hard to say that this is high quality care. And it is also really hard to say, what is the purpose of this care? Is this because a system is trying to push this person into a specific situation or outcome, or is this person really getting care that they feel preserves their values and helps them get the quality of life that they and their family want? And so something that I and the Committee to Protect Public Mental Health is really worried about is this intrusion of government into kind of the healthcare and health decision-making sphere, and also into these like very personal, important health decisions. And so there are, really large overarching ways that we can see this happen. So HHS has proposed of RFKs wanting to collect a database of people with autism, and their personal information would be perhaps collected and used for means that they never consented to. ICE trying to access or actually successfully accessing the healthcare records of people that are seeking care. This is really scary, not just for those folks, but just preventing people from even wanting to get care in the first place because they don't know what's going to happen when they share what's going on for them and their families. Other types of care that are getting targeted, whether it's reproductive health or gender-affirming care, but the Department of Justice saying we are going to allow or not allow certain care, or really, really going to crack down on professionals that are providing this care or try and target people that are looking to get this type of care. So this kind of, governmental, federal, bureaucratic overreach into people's personal lives and the decisions about the health of themselves and their families, this is really scary for us. And we think that this is a piece where it's something that people should be talking about and should be understanding is happening. And this is something that worries people and prevents them from getting access to healthcare, not having too much medication. And so I believe, and the Committee to Protect Public Mental Health believes, and generally physicians believe this, but the best care occurs when treatment decisions are made collaboratively between each person, each patient, and their chosen healthcare professionals. And so that it's important that person gets to choose who their healthcare professionals are. That person can have a choice of, do they want their family involved? Sometimes that's a very important piece. But that this is really where the locus of where these decisions should be made, not because the federal government is telling you this or that. So what can we do? So there's a lot of work to be done, so I appreciate everyone being here and for everyone's time and attention. To try and simplify some of this, so this is, we've collated these 3 messages and some of these data points into this 2-pager. And so again, this is at our website, protectpublicmentalhealth.org /misinfo, MISINFO. I have a couple hard copies here, and we have, hopefully with the QR code there. But so I hope that this is a helpful framework of talking about what is important to patients, to communities, to families, to physicians when we talk about, well, what's going on with mental health, and there's all this kind of noise out there. What are 3 messages that are pretty much always true no matter who you're talking to and on behalf of who you're talking for? And so a little bit about the committee. So this is a professional advocacy organization really of psychiatrists to protect and stand up for patients, the psychiatric profession, and broadly the communities that we work in. And one of our big messages is that public health is health and public safety. And so health is not just medication. Health is having access to clean water and nutritious food, and living in a place that has lights and your kids have access to education, and that the roads are paved and you can walk safely down the street without concerns about violence, and that really the communities that have this are the ones with the most resources. And so we're really worried about the changes that are happening at the federal government that are going to strip these resources from communities all across the country, which will make us not just less healthy, but also less safe. We're also worried about this kind of barrage of misinformation that people are hearing, whether it's coming about CDC and vaccines, whether it's about mental health medications. But American families are really in a time now where they're getting a lot of targeted messages of information that may not be very accurate. And the thing that these messengers are doing that's really well is they're digestible sound bites, and they're targeted in a way to help people understand these confusing messages. And psychiatrists and physicians are really bad at this. Okay, well, here's a paper that will help you understand what the evidence is. But that's not very useful. So what the things we are trying to do is make this more digestible and accessible for people so that they have high quality, easy to understand pieces of information to help them make the best decisions for themselves and their families. And so, yeah, so a little bit about the committee. So happy to talk about that or anything else. I also will say we have physicians involved all across the country, so if you need someone to help work on something in your city and your state, please reach out and we can get you connected to some of our members. So I think, yeah, that's everything. Do people have questions? Yes.
So there's just been discussion about healthcare reforms at the federal level, as well as some state levels. And I guess from your perspective, the messaging around that is putting the care and the funding into patients' hands, which we know actually doesn't mean what it's supposed to mean, right? It's going to mean less insurance and less, And so my question to you is, how do you, as a providers here, how do we message around that? Because we're so focused on our little things, but those bigger changes can actually have a long-term impact on the mental health of the individuals that we work with. And then is there anything that states can do, especially when there's all these discussions again about healthcare changes? So.
Yeah, no, so that's a good point. And I think you're talking about the health savings accounts and these other ideas that are coming out. Well, what could be replacements for the Affordable Care Act, or replace what people might lose out of the healthcare exchange or from Medicaid. So I will also say that we're in a landscape where there's so much stuff being thrown at us, and so we don't have a resource for each specific one, but we are looking for partners to develop specific resources on it to help be an ally in doing that. So I don't have pre-prepared talking points specifically on this piece. One of the things my mind goes to is talking about that these are not a replacement for Medicaid. Medicaid supports the health of Americans, and these health savings accounts have not shown that and are likely, based on what we do know, to not necessarily do that. the 1/3 of Americans that are children that get access to their health care and their mental health care through Medicaid, how are they going to be navigating this health savings, or whatever the new proposals are, the health savings accounts landscape? Additionally, what we have seen is that the people who have access historically, or how health savings accounts are utilized, is that they don't necessarily lead to increased access and care. We do know that people with Medicaid have increased access to care. So that's what comes to my mind right now, but I think this is an area as well that perhaps we or others can start to think about some of the messaging on this.
So I'm curious, with you being a physician, what do you think about the federal government's attempt to reclassify professional degrees for those of mid-levels, like predominantly PAs and MPs, who play a vital role in the support of psychiatrists in the mental health setting? How do you see that affecting mental health populations?
Yeah, so this is, I think it's going to be really terrible. So health is not just physicians, health is not just medication. It's through this integrated approach, which involves a whole lot of professions, and so, social workers, that's nurses, physical therapists, a lot of stuff depending on the condition you have. And what we are worried about, not just in medicine, but in all these other professions as well, because another thing that's happened, even in the entities that are still in this designated professional category can get loans, the cap on those loans is much lower. So we are worried that this is going to have really profound impacts both on reducing the workforce, and then for the people that can access the education without the ability to take out loans, that this is going to skew our workforce to folks that only have, come from a background of wealth that can afford to do this, with minimal loans or with no loans. So I think that this is actually going to be moving us in the opposite direction.
I agree. Thank you for that.
Thank you for bringing up the concept of more limited government, but I think we also have to be cognizant of the bigger elephant in the room is the insurance industry is really operating at a distinct conflict of interest. Their job is to limit their expenses, deny, so that they make more money, whether it's C-suite bonuses or the shareholders make more money. And they profit way too much. So there's a distinct conflict of interest that actually limits accessibility to care. So on one hand, we're in a tug of war. Yes, we want some limited government, but we need government to step in and say, hey, United Health, Blue Cross Blue Shield, you guys are making way too much money.
Great point, and I will argue that that's been included in here, and maybe I didn't do a great job of talking about that. So the concern about government or bureaucratic influence into these decisions, what I believe and what the Committee to Protect Public Mental Health and broadly both the AMA, the APA, most physician organizations, is that the best people to be making that decision about that person's healthcare, that whatever their choice is at the moment, is that person themselves and whatever their chosen healthcare professional is. And it shouldn't be the government or the insurance company that's saying, well, actually, but we're just not going to cover that, or, well, you're just not allowed to get that, even though that, both the physician and the patient are agreeing that that's what's best for that person in that situation. And so I think we do, to your point about that, corporations that are publicly owned and they have shares and stockholders, they are legally obligated to provide results to their shareholders, and so that's exactly what you said about this being a profit incentive. And so then this doesn't necessarily align with what the incentive is of that person that's covered by the insurance that's trying to get that care. And so there is a role here for government to protect the ability of that patient to get that care and of their chosen healthcare professional to provide them with the right resources and the right evidence so they can come to that. So I wouldn't say that those are misaligned, but we don't want either, whether it's the government or the insurance company in that room with you, almost there as a third person just sitting there and saying, well, but actually, you can't do this. We don't want that third person there. whether it's the insurance or government. But there is, because of how these incentives are aligned, there is a role for government, whether through the parity laws or through other mechanisms, to make sure that the health insurance companies are providing the care that they are, saying that they are providing, and in many cases legally required to provide.
Hello, good morning. Thanks for being here, Doctor, and thanks for your leadership in giving providers a platform on this important issue. I think it's a really important perspective and voice. My name's Amber. I'm with Thresholds. We're a large community health provider here in Illinois. Normally, I would ask questions on the policy beat, like my colleagues have been peppering me with here this morning, but I actually want to ask you about how your group is structured, the committee, and how providers can connect with you. Like I said, I work for a really large provider here in Illinois. All of our staff are natural advocates, from the front desk people all the way up to our top docs. And so I know that we have many people who would probably be very interested in joining you. So I would love to be able to take that back to them and learn a little bit more about how you all are structured. Are you a national group and you get together on Zoom or something, or do you have state chapters or local, or what does that look like?
Yeah, sure. So I had some slides on this at the end that I kind of skipped because, there are not a lot of psychiatrists here, so maybe it's not super interesting, but maybe that was a misassumption. So we are a national group. It is right at this point, the members are just psychiatrists, and we wanted to limit it to this for now, both for kind of management, logistic purposes, but also because we really realize that psychiatrists have a really important role to play. And the places we saw misinformation coming from the federal government often was two places. One is around vaccines and kind of stuff at the CDC, and another one was cuts at SAMHSA, which is our one and only federal agency for mental health and substance use disorders, and this targeted misinformation around psychiatric treatment and medications and what it means to have mental illness. But there wasn't we saw a lot of pushback on the vaccine side. So even though it's it's still a tug of war, there are people that are pushing back, but we didn't see that same thing necessarily on the mental health side. And so we felt that this was a role specifically that psychiatrists should be stepping into. And so that was kind of the purview from that. And so the best way to get in touch is through our website, protectpublicmentalhealth.org. We have monthly stakeholder meetings, and then we have various work groups that work on either the materials or topical or to support specific initiatives. The support and materials that we do are designed both for psychiatrists, but also for psychiatrists to have something that's easily accessible and digestible for kind of the general public, who is the ones that are most kind of susceptible to this misinformation or disinformation that they're getting around mental health. So hopefully that's helpful. On the website, there's a contact form. I'm also happy to touch base if there's other stuff that can be helpful.
I'm going to have to end our question section right now. I'm sorry, I know Eric does plan on sticking around. I also want to make sure that you all know on your table, one of the QR codes where it says view the agenda, if you follow that QR code, go to the bottom of the agenda, there is a PDF file to download that which is the talking points one-pager that Eric shared. So you have that for your use. Thank you.
Please join me in thanking Dr. Earth. Thank you.
Thank you.
Thank you so much. I love the work that you guys are doing, which is why we asked you to come here. And thank you for being our allies in this. I'm happy to say we're back on schedule. In fact, we're a tiny little bit ahead of schedule. So let's make our break, which is happening right now. We'll be back here at 10:15. That still gives us 15 minutes and, gives me more opportunity to yak with people. And by the way, Alexander, our photographer, says that he would like to get a picture with Leslie and Mark and me. So I'm going to grab you two. Thank you all. Okay, I made a mistake with the restrooms. While there is to the left, there's also big ones to the right. So I'll see you all back here in 15 minutes. Everybody back? I know we got so much jam-packed into our meetings, because we always do. But I want to invite everybody to come on back in and take a seat, because as soon as Dr. Cook is back, you're going to hear some amazing research from an amazing researcher that we are very, very lucky to know, and that when I asked, she said yes. Dr. Judith Cook is at University of Illinois, Chicago, in the Department of Psychiatry. And she has run, and you'll tell us for how long, because I can't remember, but a long time. Your center, for your center. And I will tell you that I am really lucky to know a lot of things. And a lot of the things that I learned because of Judith's research. It's really true. And everybody's heard me talk about being from Philadelphia, and I have the great privilege of one of my dearest friends and mentors is Dr. Mark Salser, who also runs a technical assistance center. And he introduced us to the work of Dr. Cook many years ago, and it's really amazing. So I'm going to get off the stage, and I'm going to let her tell us more about what we know really works and how we work to keep it. So please help me in welcoming Dr. Cook.
Thank you so much, Debbie. I'm very pleased to be here today to tell you about the latest research showing effective, you know what? Let me get my glasses. And let's start over for the tape. So I'm very pleased to join you today to talk about the latest research showing effective ways to promote recovery of mental health and wellness. I'll also introduce you to free online resources that promote self-determination and self-management. I'd like to acknowledge the federal agency NIDLR for their support of the work I'll be describing today. And I also want to note that the contents of my presentation should not be taken to represent the policies of any federal agency. And finally, I have no conflicts of interest to disclose regarding the content of my presentation today. Today, I'll start by discussing self-direction as a foundation for recovery-oriented care and describe its empirical basis in psychological self-determination theory. So you're all going to get a theory lesson today. Next, I'll describe the 8 dimensions of wellness, along with social determinants of health, and how these need to be incorporated into models of care. I'll describe illness self-management education as a third evidence-based approach, followed by peer support and peer-delivered services. I'll introduce you to my center's solution suite of free products and learning tools with free training and technical assistance, and end with a summary of the many ways we can enhance self-direction for people with mental health disorders. So let's begin by understanding the importance of self-direction. By self-direction, we're referring to people's ability to direct their own lives, given their understanding of themselves, other people, and the world around them. But ability is not enough. People also need the skills that enable them to learn new things, manage their own behavior, and find and keep the motivation for recovery. To fully appreciate how this happens and why it's so important, we have to understand self-determination theory. This psychological theory posits 3 basic processes that need to occur for lasting health behavior change. The first is autonomous motivation, in which people engage in behaviors of their own volition because they believe in the behavior's value. It's valuable to the person when it aligns with their own self-interest, when they believe it will be beneficial, and when they find the behavior satisfying. Now, I can get you guys to change a behavior with controlled motivation. I might do that using the emotion of fear. If you don't take your medications, you'll lose control of your life and end up back in the hospital. Or I can use controlled motivation by building on your desire to please people. You really should lose weight to make your family prouder of you. But guess what? Research shows that that behavior change won't last. Lasting behavior change requires that you decide to change by engaging in activities that you believe will make your life better. And that's autonomous motivation. Perceived competence for new behaviors is just what it sounds like. It's the belief that a person knows what to do to adopt new behaviors and feels ready and able to do so. If you've ever taught a child to ride a two-wheel bike, you know that you may think they're ready to ride without the training wheels, but it's not until they feel ready to balance on two wheels that they'll be successful. And finally, relatedness occurs when a person's attachment to others and feelings of belonging link their personal goals to a larger community that cares about them. This atmosphere of caring and concern motivates people to keep working on improving their physical and mental health and move their lives forward. Now, this isn't just a nice theory with a nice name. We're all for self-determination, right? There are now over 5 decades of rigorous research demonstrating conclusively that interventions grounded in self-determination theory cause positive health outcomes. These outcomes include physical activity, quitting smoking or cutting down, losing weight, eating healthier food, lowering alcohol consumption, and controlling glucose among people with diabetes. But this research also found that these interventions can have positive mental health effects, such as lower depression and anxiety. Unfortunately, we are late to the game in applying self-determination theory in the field of mental health care, although we've made some strides in recent decades. We're also late to the game in our understanding that mental health includes wellness. And by wellness, we're not just referring to physical health. Wellness refers to a sense of satisfaction and accomplishment in multiple life areas called dimensions. These are the 8 dimensions of wellness, as articulated by Dr. Peggy Swarbrick and her colleagues. Some of you may have heard of these. Would you raise your hand if you've heard of the 8 dimensions? Oh, that's so great. All right. Hope this won't bore you. One of them, of course, is emotional wellness, as I've just described it. But there are other important dimensions. Financial wellness includes the ability to manage your money and a sense of satisfaction with your current and future finances. Social wellness means a connection to others, a feeling that you belong and have a network of people that support you. Spiritual wellness includes religious beliefs and behaviors, but also being able to expand your sense of purpose and meaning in life. Occupational wellness involves feeling personal satisfaction in the work you do, both paid and unpaid labor. Physical wellness includes having a healthy body, along with the ability to engage in health-promoting lifestyles. Intellectual wellness includes lifelong learning that helps you increase your knowledge and skills as you want to. Environmental wellness stems from living in a pleasant, stimulating environment that supports your well-being, free from crime, pollution, or overcrowding. All of these life areas contribute to people's ability to live a rich and meaningful life. So, when people are recovering from a mental health disorder, all of these areas deserve at least some attention. This is a fairly new insight in the field of mental health treatment. Another important consideration, sorry about that. Okay. Another insight for our field is one that also applies to the field of medicine in general. Increasingly, we recognize that health is not simply the absence of disease in the body. Health is impacted by the so-called social determinants. I think you've all heard about them. They include economic stability, physical living conditions, level of education, secure access to food and clean water, and community and social support. Another important determinant is whether people have access to good quality health care and the richness of the healthcare system that serves them. As with promotion of physical health, restoration of mental health requires paying careful attention to these social determinants. It doesn't matter how good supported employment services are if the person lives in an area with no job opportunities and there are no plans to help them find jobs elsewhere. It's not enough to help people feel better emotionally if they don't know where their next meal is coming from. It doesn't make sense to give people information about their diagnosis and treatment options without paying attention to their health literacy so they can absorb and apply what you're trying to teach them. It's a challenge, but the evidence shows that if we don't pay attention to these factors, we won't get the outcomes that people are seeking. Another important consideration is provision of peer support. Peer support is crucial for reducing isolation and dealing with stigma through sharing life experiences, empathy, practical advice, and instilling hope. We now have enough evidence to know that peer support is an important part of the care continuum. And we have over 100,000 state-certified peer specialists in the U.S. Many of them are trained in evidence-based models, and I'm going to talk a little bit more about that later. Many states are continually expanding the funding base for peer services through Medicaid reimbursement and other sources, such as state general revenue, your state tax dollars. Today, 47 states in the District of Columbia pay for at least some of their peer-delivered services using Medicaid dollars. Now, I'd like to take a moment to show you an interactive map from my center's website that illustrates each state's investment in the peer specialist workforce. And helping me will be the gentlemen in the back that are going to click on the magic link and load it for you. They are working away at loading this so you can see it. There we go. When you click on a state, you find out the number of certified peer specialists it had trained as of 2024, the type of certification available, that might be mental health, substance use, forensic, family, young adult peer supporters, and whether peer services are Medicaid reimbursable. So let's pick Illinois, which they've read my mind and already done since we're all here in Chicago. Illinois had 470 certified peer specialists, certification in mental health and substance use, and used Medicaid to reimburse at least some of its peer services. Let's take a look at Michigan, the mitten state. Michigan had 3,894 certified peer specialists, certification in mental health and substance use, and Medicaid reimbursement. And let's hop over to New York State. They have a huge number of certified peer specialists, 5,444 of them. They have certification in mental health, substance use, youth peer support, and family peer support, and also have Medicaid reimbursement. And we don't want to neglect the Pacific Coast, so let's hop over to Oregon, which has 3,788 certified peer specialists in mental health and substance use, and uses Medicaid reimbursement to fund their peer services. Okay, let's transition back to the presentation. When you get the slides, the web link for the interactive map can be found at the bottom of the slide. And I encourage you to explore it for your state and other states that you're interested in. This sizable workforce is especially important now, given the serious shortage of trained mental health clinicians in the U.S. And I'm thinking if this was a policy conference, that got talked about. If it hasn't been talked about yet, it'll be talked about later. Also, many peers are on board with the newest recovery-oriented emphases in mental health, such as the 8 dimensions of wellness, social determinants, self-direction. They get all that already. In collaboration with Mental Health America, we created this infographic based on a longitudinal study of 4 cohorts of newly certified peer specialists in 4 different states conducted by Dr. Leisha Ostrow. And she has a number of really interesting findings. They followed newly certified peer specialists for 3 years. They found a very high employment rate in the 3 years after certification, starting at 73% and then up at 77%. That's huge for people who have recovered from mental illness. They found significant increases in wages over time, thank goodness, and a higher likelihood of having employer health benefits than people that were certified peer specialists but working in non-peer support jobs. Check out that infographic if you're interested. It's something I'm really pleased that we collaborated with Mental Health America on. The final ingredient for an evidence-based recovery support system is called illness self-management education. It's another approach used in physical health care, but more recently adopted in the mental health field. It helps people cope effectively with long-lasting medical conditions by providing them with practical knowledge about causes and treatments for their condition, problem-solving skills, emotional support, strategies for dealing effectively with their medical providers and dealing with their families' reactions to their illness, and instills confidence in managing their condition. And this model is also backed by decades of research which show that it results in better health outcomes, higher functioning, enhanced well-being, and lower use of intensive and therefore expensive services. Now, this approach is increasingly being used in mental health. And one example is Wellness Recovery Action Plan, or WRAP. How many people have heard of WRAP? All right, wonderful, wonderful. This self-management program reduces symptoms, enhances hopefulness and quality of life, increases empowerment and self-advocacy with treatment providers, and reduces formal service use while getting superior recovery outcomes. I'm proud to say that I did some of the first research on WRAP with Mary Ellen Copeland, and those findings I just reviewed resulted from our randomized control trial of WRAP that we did in Ohio and in Illinois. Similar models with an evidence base include Bridges, which has a really long title, Building Recovery of Individual Dreams and Goals Through Education and Support, which comes out of the peer movement in Tennessee, NAMI Peer-to-Peer, NAMI Ending the Silence, Illness Management and Recovery, IMR, and DBSA support groups. Now, interestingly, many of these models are delivered by trained certified peer specialists. They don't have to be, but many of them are. And this approach has also been applied to increasing the physical health self-management abilities of people with serious mental health conditions. We all know they have a lot of medical comorbidities in addition to their mental health condition. And this approach has been shown in an intervention called Whole Health Action Management, or WHAM. And we worked with WHAM's creators and found that it increases people's ability and activation to engage in healthcare. It improves their perceived physical health. It increases their sense of hopefulness about their health. And it increases people's likelihood of employment, which was an extra little benefit we didn't necessarily expect, but we took it. Other models like this include HARP, Health and Recovery Peer Program, Living Well, which comes out of Maryland, and the Chronic Disease Self-Management Program. That kind of started it all off in the medical field. And interestingly, many of these models are also delivered by peers. So that's a lot of self-management interventions based by sound evidence, right? How do we know which one should be offered to whom? And the answer is to use an algorithm to help figure out where a person is in their illness journey, what types of learning and support they need, and which models are best given those factors. Now, the idea of an algorithm to guide referral to illness self-management education programs isn't new. It's used in physical health care all the time. When you're diagnosed with diabetes, the standard of care is that your doctor refer you to diabetes self-management education. The same is true with arthritis, heart disease, cancer, and other medical conditions. What is relatively new is that the Institute of Medicine recommends that people with behavioral health conditions also be referred for mental illness self-management education and support. And the IOM says that patients' preferences for peer support should be given high priority in this process. Now, we hope that most mental health providers are aware of these self-management education programs, but we felt that primary care providers might not be in the loop about this. This is important because primary care providers are far more likely than mental health clinicians to interact with patients who have or who are developing a mental health condition. Interaction with clinicians happens to a very small percentage of people with mental health conditions. So, primary care physicians also need to be aware of these IOM recommendations, and that's what led us to create this algorithm. It's based on the American Diabetes Association's algorithm for diabetes self-management education. And like that one, it starts by recognizing which of 4 critical phases in illness development a person is in. The first is at diagnosis of a mental health condition, or when the physician first notices that their patient is experiencing emotional distress. We all know that happens a lot earlier than a diagnosis might be made. The second is when someone is receiving mental health treatment or when mental health treatment is being recommended. The third is when symptoms are worsening or during a crisis or right afterwards. And the fourth is when care transitions are happening, such as changing or ending mental health care. So for each of these 4 phases, a certain type of education and support are needed. At diagnosis of first symptom recognition, education about the diagnosis and symptoms, hope for recovery, and peer support are needed. At the treatment phase, education about treatment options, self-management skills, lifestyle changes, and peer support is helpful. During worsening symptoms or a crisis, self-management skills, crisis and post-crisis planning, psychiatric advance directives, and peer support is needed, and so on. So we worked with the creators of 8 mental health self-management education interventions to design this algorithm. And in the bottom row of this chart, you'll see their recommendations about which phases their models are especially helpful for. And where do we have a gap, folks? Where do we not have anything other than DBSA support groups? In crisis situations and post-crisis situations. All of the creators of the other models felt that this was not an appropriate time for their model of self-management education. Now, I think you all know of some crisis management programs that are relatively new. Has anyone heard of living rooms? Okay, so living rooms, usually run by peers, staffed by a medical provider in case the person does need to go to the hospital, are a place to go and hang out for a short period of time, take a shower, relax, talk to someone, have a meal. They're not up there yet because the rest of the models are evidence-based, and the IOM says only evidence-based. So I hope somebody soon, I'm too old now, is going to do the randomized control trial on living rooms that will put that on the map. And we also know of other respite programs and places that people can go when they're in crisis and learn some self-management skills. So while we designed this for primary care providers, I was a little facetious when I said I'm sure all mental health clinicians are familiar with these models and when to refer people to them and what they do. So it's obviously also helpful for mental health clinicians who aren't in the know. Law enforcement, family members, educators, nurses. So I encourage you to take a look online at the address on this slide if you're interested in this particular algorithm. So to our question of what works, we have some answers. What works are interventions grounded in self-direction, that provide peer support, that teach illness self-management, and address different dimensions of wellness, and take account of the social determinants of health. So there's our answer. And I'd like to next introduce some other ways that we can promote recovery-oriented care that hopefully will tie a little of this together. And these are contained in my center's Solutions Suite. So the Solutions Suite contains 21 free products designed for use by people in recovery from mental health and substance use disorders. We designed it with Microsoft Office Suite in mind. Please don't tell the Microsoft people, they'll sue me, I'm sure. Most of you know Office Suite's products, including Microsoft Word, the word processing program, Excel, the spreadsheet program, PowerPoint, which I used to design this presentation, and Outlook, the emailer. The idea is that each component of the suite serves a different purpose, but is compatible with other programs in the package. And the same is true with our Solutions Suite. The framework we used in designing the suite is what we heard from the field based on our 30 years of designing and testing interventions. First, the suite's products are available for free, and they're designed to be delivered at minimal cost. Very important in today's public mental health system. They promote self-direction and self-management. The tools can be used with minimal to moderate training, and we provide that training in the suite itself in the form of a podcast and a webinar that show people how to use the tool with other individuals. Suite products are designed to complement traditional behavioral health treatment like meds or case management or psychotherapy. And the products are supported by research and evaluation studies, and some are evidence-based practices. All of the products were designed by us and our center's collaborators to respond to the documented needs of service recipients and also community service providers who told us what they needed. One special feature of the suite is that all of its products are supported by free technical assistance, which you can get from my center via telephone and email. You can't even pay us to give you this technical assistance. Finally, many of these products can be delivered by peers if they view the training webinar, and some of the products do require experience leading groups or working with people one-on-one. We developed the suite with our partners at Collaborative Support Programs of New Jersey, who are Dr. Peggy Swarbrick and Dr. Pat Nemick. And the solution suite tools and products are grouped into two categories: tools that integrate healthcare and behavioral healthcare, and tools that promote self-directed recovery. Here are the 13 products that integrate behavioral health and primary care. You'll see tools for enhancing immune health, smoking cessation, weight management, an online diabetes toolkit, journaling for wellness, and the Whole Health Action Management Program, WHAM, that I spoke about earlier. And here are the 8 products that promote self-direction in behavioral health treatment. These include a financial education course that we just tested in a randomized controlled trial, a self-directed life planning guide, a self-determination self-assessment, like those quizzes you get in magazines. Take it and find out how self-determined your life is. How to find and access evidence-based supported employment services. That's the Seeking Supported Employment one. And a guide for raising difficult issues with your service provider. Conversation starters that can allow you to talk to your service provider about difficult things in your relationship with that person. Each product is presented in the same format, and here's a look at the landing page for our weight management tool, just as an example. Starting with the left-hand panel, at the top of the page, you'll see a picture of the product itself, which you click on to download it. And then to the right of that picture and scrolling down, information is presented, starting with what is the program, which offers a brief description of it. Next is a description of who it's designed to be used with. Next comes a section on how the product works, in other words, its active ingredients and change mechanisms. Moving now to the right-hand panel, which isn't on the right hand, it's actually under the left-hand panel. We're just going down the page when you go to a landing page. There's a description of the resources that are needed to offer it and what levels and types of experience are needed by people who are teaching it or facilitating it. And if you scroll down further, you'll see 3 boxes. The one on the left is a red microphone, which you click on to listen to a podcast about the product and how it's used in the field. And to the right of that is a blue box, which links to an audio webinar with slides that teaches you how to deliver it or use it with other people. All the podcasts and webinars have transcripts for people with hearing challenges. And finally, at the bottom of the page, there's a red box, which is what you click on to request that free TA that I mentioned earlier. So, what about the what's next part? I think that's what you're all here to think about and talk about, share ideas about, get some motivation to go home and make happen. How can we promote wellness and self-direction with all of the tools and models I've described? First, obviously, we want to emphasize models that enhance self-determination and self-direction. Second, we want to provide the right self-management, and education and support at the right time to the right people. Third, we want to promote wellness in as many dimensions as possible, and we want to be guided about those dimensions by the service recipient. And also, we want to offer peer support. We also want to encourage use of the same supports we all use. We call these natural supports, such as community participation, civic engagement, leisure, and recreation. We want to make use of that large certified peer specialist workforce, especially in traditional programs and systems, given the workforce shortages that they're facing. Seventh, we want to empower families and other supporters to create communities of connection that nurture relatedness and therefore motivate lasting behavior change. And finally, we want to engage in advocacy and political action to promote a system that enhances recovery and leads to outcomes that participants themselves value. So I encourage you to explore the center's resources, especially the solutions suite, the self-management algorithm. Check out the interactive map. This slide, in mosquito font, contains the references for the research and other documents I cited in my presentation today. And finally, here's my contact information if anyone wants to follow up with me later. Thank you all for your attention today, and perhaps we have a little bit of time remaining for questions and discussions. Thank you. So, you want to?
Thank you, Judith. Thank you so much. Your research has meant so much to so many of us, and we use it all the time.
Thank you.
You're welcome. I love that map. That's great. So what state has the most peer specialists? Do you know off the top of your head? I don't mean to put you on the spot. I don't mean to do that. I'm just wondering, because we saw Illinois, and there were only 400 and some peer specialists. I'm thinking, hey guys, hello, all my friends here in Illinois. I'm looking at you, Mark.
Now remember, these are just certified peer specialists.
Okay.
There's a lot of peer work going on in Illinois.
Absolutely, absolutely. And Alicia and I know our home state of Pennsylvania has a very large cohort of certified peer specialists. You're looking at one of them right there. You know, and we love it. And we agree with you. And I could not help wondering, noticing, as we looked across your chart, in every single one of them, what makes that difference? Oh, peers, 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 peers. And that's something that matters so much to our MHA affiliates. And that was kind of why I was wondering, you know, like what states have a huge cohort of certification as opposed to, and it's good to have, I know California has a lot of peer specialists, but they haven't had a certification until very recently. So that plays into it as well.
Right. So I should know the answer to this question. I believe that there's a state that has over 10,000, but I don't know which one it is. So if you're curious, that's going to motivate you to go to the map and click on all 50 states in the District of Columbia. You'll find it. It's like right down there in, where DC is. And find out for yourselves which state has the most peer specialists. This was a huge amount of work to make this map. We had to contact all 50 states in the District of Columbia, and very few of them gave us the information we needed right away. It was amazing the number of states that didn't have a ready answer to the question. And we had to go back multiple times. Many advocates, peer advocates in the field helped me get the answer from their state. With the great state of Hawaii, they actually got out their spreadsheet, and we got on Zoom together, and we counted the number of people in Hawaii. So it's a workforce, but it's not necessarily, there isn't a lot of accessible information about it. And that's why we wanted to make the map. We had an earlier one for 2016, I believe it was. And when we catch our breath, we'll update it again maybe in 2030. But 100,000 certified peer specialists is a ready workforce to be deployed in the right way and honoring the peer support philosophy. So thank you for that question. I appreciate it. How about any? Yes.
How long do you think it'll be before living rooms can have existed long enough to be considered evidence-based?
I think that there's enough of them now that you could do a really good study on living rooms. So the problem is getting a researcher who then has to go to NIH or NIDLR or a funding agency to get the money. And then to call it an evidence-based practice, people have to be randomized. So we need to think a little bit about what is the control group going to get if they're in crisis. One way is for the control group to go in the hospital, because there are people who are diverted at the hospital door and invited to do the living room program instead. So anyway, lots of kind of logistical research questions. There is good pre-test, post-test evidence about the effectiveness of living room programs, so I don't want to say there's no research on them. But you know, research proceeds at a snail's pace. I've tried for 30 years to hurry it up, but like I said, I'm too old for living rooms, so someone else is going to have to pick up the banner and do the randomized control trial on that one.
I definitely appreciate that. I'm on the NAMI Illinois board, so I'm a huge fan of living rooms, so thank you for that.
Yeah, our state is made a big investment in living room programs, and I think it's paying off. I'm going to let you pick out.
Judith, while I have the mic, sorry.
Yes.
Can we use the language of promising practice then for living rooms? Is that fair?
Oh, definitely. And we can use the language of research-based intervention, okay? We just can't call it an evidence-based practice if our definition of evidence-based is randomized control trial, okay? I would send my family member to a living room program. That's how strong I think the research evidence is. But there's others to convince. And we know there is a reinstitutionalization, recriminalization movement of mental illness in the United States. So it takes a lot of convincing sometimes.
Hi, Carrie
Hi.
Bloomert from Mental Health Association, Oklahoma. 2 questions. Could you say the website again where we can see that interactive map? And then could you explain a little bit more about what living rooms are?
Okay. I don't have the slide in front of me to read out the link for the map. So, but if you go to my program's website and put in CPS for Certified Peer Specialist map in the search bar, it'll load right up for you, okay? And so living room programs are programs where when people are in crisis, they go, they might be ready for hospitalization, but before that, they try a program that is like a living room. I mean, it's supposed to be comfortable. It's supposed to be, imagine if you've ever been in an emergency room with a relative or a friend who is in a mental health crisis, you know what emergency rooms are like. They're overstimulating. The lights are loud. People are running back and forth. It's not conducive to calming down and looking at other kinds of options. So living room programs are very homey. They have couches and recliners. You can watch TV, get a good meal, take a shower, talk to somebody about what's going on in your life. Often that's enough to calm down and be in control enough to be referred not to the hospital, but to some other kind of care. Probably maybe intensive at the beginning. Maybe you don't want any mental health care and you just leave. But that's what living rooms are. They're a diversion program designed to give people what sometimes solves crises, because what are crises caused by in addition to mental health difficulties? Those social determinants we talked about. People are hungry. People are scared because they live in a crime-ridden neighborhood. And they've been isolating themselves and not taking care of themselves. All of those social determinants, plus good mental health peer support, is pretty much what living rooms do. There's usually a medical provider on site to certify whether the person is a danger to themselves or other people. But that's really, in most living room programs, that's the most that person participates. It's generally peer-led, but like a lot of things, living room programs can look different in different states. So great question. I'm sorry that I threw that out there, and you were probably sitting there going, living room programs, what's she talking about? How about some other questions?
Judith, real quick before I catch another question, we've had an audience request that you go back to the resource slide.
Okay.
Thank you.
I can definitely do that. And which resource slide was it?
The one right before the mosquitoes slide with all the, yeah, right before, there it
There we
is.
go.
That's the one, thank you.
There we go. So I didn't put the link to the map up there because I didn't know you guys were going to be so pro peer support. So sorry about that. But the link to the Center for Integrated Healthcare and Self-Directed Recovery is where you'll go, type in CPS map, and you'll go to that and can interact with the interactive map.
Thank you.
How about some other questions or even comments about what I've had to say?
Sorry, I have a lot of questions, but because I'm kind of new to this work, I'm with Mental Health Partnerships in Philadelphia, and my question is, when you're talking with legislators about certified peer specialists and things, what is like the most common question that you get, and what is like the, what are some of the biases or questions that you most come up with any policymakers, I guess, about this, and how do we sort of incorporate this, the evidence-based research into the language that we use?
Okay. So I think the policymakers are usually too smart to ask their real questions because they know that they might not be politically correct. So let me answer that by saying what I try to tell policymakers about peer support, which is, first of all, that it's evidence-based. Second of all, that people have recovered from their mental health condition, and there are safeguards in place so that if a person isn't in good shape, they're not delivering peer support. I talk a little bit about the workforce shortage and how peers can be considered a workforce, and mention the certification program, which most legislators don't even know they have in their state unless they're mental health specialists. And I try to talk about how peers have been used for decades in other fields like substance use and domestic violence, that it's not really a very new thing. Often they want to know, like I said, those things about the questions that are, difficult to ask, like what if they have symptoms, and what if they get things wrong, and are they supervised? I usually mention that the CMS, the Center for Medicare and Medicaid Services, regulations for peer support require good supervision for peer supporters. So there's just a bunch of people out there leading a support group, although that's good too. But when we're talking about peer support, especially certified peer specialists, we mean a lot more than that. So, I think be smart, know your legislator and what they're, likely to be concerned about. If they're conservative, you're going to mention some things, and if they're a little more informed about mental health, maybe some other things. I hope that was helpful. I don't talk much to legislators, but I know all of you do. So that was a great question.
Thank you. Hello. What, in addition to living rooms, would you say is actively being researched for crisis intervention to help with the continuum of care, specifically for children and adolescents?
Oh, I am an adult mental health person, and my knowledge for children and adolescents is very, very slim. I don't know of any living room programs for adolescents. Does anyone else know of some? Please comment.
The Loft in Chicago has some services for youth.
Perfect.
Could you, what in addition to living room for adult services would you say is happening?
In the area of child and youth?
No, for adult.
For adults?
Mm-hmm.
Respite programs where you can go and stay for a longer period of time than you'd stay in a living room program. So communities of people who move in for a period of time until the crisis is passed and where the services are brought in to them. I mean, that's a model that's 30 or 40 years old and, not, I would say, widespread around the United States right now. I think going back to the child and youth arena, I think people mistakenly assume, well, their families will take care of them if they're in crisis. And I, don't think that that's the case many times. And so respite care and care for the child in crisis in other locations is obviously a common model. We have a lot of work to do in the crisis arena, and some people are doing it. Does anyone else know of new crisis models they want to tell us about? Yes?
We run a peer, we don't run it, one of our organizations in New Jersey does a peer-run respite, which is a 10-day stay, and people in crisis are eligible to go there. Actually, it's Medicaid reimbursed as well, and it is a living room model.
And I believe you have more than one of those in New Jersey.
We have 3.
I believe you have 3.
They're run by CSPNJ. They're terrific.
Yeah. Thank you for sharing that. Anybody else? Are these questions or new?
This is a point. In Tennessee, we have one crisis stabilization unit for children and 3 more in the pipeline, but we also have the crisis stabilization teams have family crisis walk-in 24/7 capability, so families just don't have to wait until it gets up.
Right. So you're serving both the family and the young people.
Yep.
Really important, really important.
We're going to take 2 last questions over here.
I was going to add on to that point. So I chair for the state of California the 988 Equity and Accessibility Working Group at the state agencies. One of the things we are trying very hard to do, institutions have had a bad history of removing people from their homes, and so specifically for children and adolescents, where some of the research is looking at now, is how wraparound support and for a crisis continuum of care for children and adolescents, instead of just being someone to call, a safe place, or someone to come and a safe place to go, there being this wraparound team that can really support the child in their environment, whether that's at family or with school. And so then instead of interaction at the point of crisis, is this like a 1 or 2 week intervention with wraparound services? So that's where I think the research is heading.
Yeah, that crisis prevention, of course, is much better than dealing with the crisis, and that's what self-management is all about. If you take RAP and design a RAP plan, you have a whole set of procedures in place for different levels of not feeling good about yourself and what the plan is and who's going to help you, and leading up to crisis and a post-crisis plan. So self-management, I think, is really, really important to apply in this area as well. So I bet we're out of time because Debbie's standing up. Oh, we have time for one more?
Just a comment. In Georgia, we also have the wellness and respite, their homes in neighborhoods where people can stay a couple of days, and same thing that you were mentioning. But we also have children and adolescent mental health clubhouses for children after school, where they get supports and tutoring and those kinds of items for children with mental health conditions.
Wonderful. And does the Georgia Mental Health Consumer Association
Network.
Network, sorry. One of the early leaders in certified peer specialists, Larry Fricks, just passed away. Sherry Jenkins Tucker died several years ago. So we, states have been enriched by the certified peer specialist movement. All right, this guy knows. We don't need a map. You just can ask him how many certified peer specialists exist in different states. That's pretty cool. All right, Debbie, I'm going to turn it back to you.
Judith, thank you. Please, everyone, join me in
Thank you.
Thank you for being here, and thank you for all of your research. We so appreciate it. We have built our advocacy around so much of it, so thank you.
Thank you.
Absolutely.
Bye, everyone.
Absolutely.
Enjoy the rest of the meeting.
You're welcome to stay if you like. More than. All right, cool, because we are going to hear from some of my dearest colleagues who I have had the very great pleasure of working with for a lot of years. 2 of the 4 of our Regional Policy Council representatives. We're going to hear from Barb Johnston from MHA of New Jersey and Ben Harrington from the Mental Health Association in Tennessee. And they're going to answer that question that Julie had about, like, how do you talk to legislators and how do you talk across the aisle? And so take it away, guys, because you know.
The light.
Yeah, I know, it's hard.
Woo! Where are you going?
I'm going here.
Hi, everyone. We stand between you and lunch, I think.
Almost.
Almost.
There's one after us.
Ah, thank you.
Yeah.
We're really happy to be here with you today. I'm Barb Johnston. I'm the Director of Policy and Advocacy for the MHA in New Jersey. I'm here with my favorite colleague.
I'm Ben Harrington. I'm the CEO of the Mental Health Association of East Tennessee, and if you were at dinner last night, I am also Colonel Sanders.
And he doesn't like hard-boiled eggs, for those of you who were there last night. Yeah. So we've chatted up a lot in our RPC, and one of the things that we were talking about is just our experiences in working what we call both sides of the aisle. And we've both been doing this for a very long time. We live in very different states. And we really thought that we would share our personal experiences in what it's like and how to best influence and educate, because advocacy is education, how to educate the legislators that we work with on both sides of the aisle. That said, we have 10 or maybe it's 11 fun facts for you, again, based on our own experiences on what works and what doesn't work. So next slide. So these are our states, and we thought we would give you a snapshot of red is Republican, blue is Democrats, and I'm going to talk about New Jersey, and then Ben is going to talk a little bit about Tennessee. So while you see a lot of red in New Jersey, we currently in New Jersey in our state legislature have a supermajority of Democrats, because those blue areas are the most densely populated areas. And our both Assembly and our Senate are dominated by Democrats, but that doesn't matter because they still don't get along. So we have different messaging, again, even within our parties. So just give you a snapshot of what New Jersey looks like. Ben?
Yeah, so if you look at the maps of Tennessee, the top one shows us 25 years ago. And we were much more of a purple or blue state 25 years ago. But things have dramatically changed, and that means our message has to change to go with the state turning red. And everything is controlled by the GOP at this point, the governor's office, the House of Representatives, and the state Senate. So we have to find messages that are going to resonate well to be able to achieve what we would like. Or change some legislation that's been proposed, that sort of thing.
Great. Next slide.
Okay, so it's important to try to know each party's priorities and really dialing that down further to each legislator's priorities so you can have healthy conversations. And so some of those priorities are going to be the typical things: equity and services and environmental protection and privacy and civil rights for the Democrats, limited government, more fiscal responsibility, return on investment for Republicans. But there is some common ground, and that's our job as advocates to try to seek that common ground, because we have to work with everybody. It doesn't really matter what their political affiliation is. And so in that process, we do seek out who some of those bigger partners in the advocacy role might be, whether that's Big Pharma, whether that's the Hospital Association. The Chamber of Commerce is a really interesting one and fascinating one that we've leaned on a couple of times. But the purple areas that really resonate are return on investment and cost containment That gets a lot of resonance with the trifecta of control of the governor's office and Senate and House, but also access. Access is not an issue that is limited to one population. Access issues straddle both populations, whether it's a Republican or Democrat controlled area.
Exactly. Next slide. So in addition to knowing everybody's priorities, you also want to know how you're structuring your messaging. And sometimes we do create two message frames along the lines that Ben was talking about. For the Dems, we might talk about social impact, talk about equity, always around their districts. But for Republicans, are very interested in business interests, cost savings, efficiency of government. So, for example, in talking about our 988 fee, when we visit Republicans, we noticed that they were very responsive to being able to identify business interests, working with potentially having like a business partnership in some way, that they are always interested in saving money in the budget. So we were lobbying for doing education on a fee. And so we would point out how this fee could potentially save money in the state budget. And there was a lot of positive response to that message. The Dems were obviously very interested in access to care. Access does cover everybody, but you know, the aspect of voluntary care. We have a very robust involuntary system of care in New Jersey, and yet on the voluntary side, during crises, this is where we feel the 988 continuum of care fills that gap. The Dems were very responsive to that as well. And yet both Dems and Republicans have really heard the message about avoiding ER visits, early intervention, so they both get that. And it's interesting when you talk, I mean, there's variations within the parties, no doubt, so nothing is absolute. But in general, you'll see who responds to what kinds of messages as you begin to deliver, you know, your educational messaging and what you want to happen.
Right. So as Barb mentioned, the 988 fee. Fee is a very dirty word in the South and probably lots of parts of the Midwest. So fee is considered a tax, and that's sort of the thing that's going to get their ire up. And we built our whole crisis system on avoiding fee, but investing in crisis stabilization units, using block grant dollars to set aside for crisis services to build that, and we've never had to rely on a fee.
Right.
Yeah.
Yeah, fee's dirty in New Jersey too.
Yeah.
They're really nervous about it. We'll talk more.
All right, so focusing, next slide. Focusing on some shared values, you know, I think a lot of folks are very eager to engage in conversations about economic growth and safety and families and affordability, but there's a commonality. Everybody needs access to care. It doesn't matter if you're in Medicaid or Medicare or if you're in commercially insured systems, everyone needs access, and so that's what absolutely resonates. And so we don't, obviously, behavioral health issues, they don't discriminate based on age, gender, residence, or access, but boy, they create all sorts of barriers for us. And so what we just constantly preach is upstream access equates with early intervention and equates with prevention and mitigation of downstream costs. So my friends in the room remember when MHA National first started talking about before stage 4. That is it in a nutshell. Because stage 4 is crisis services, backseat of a police car, going to jail, or you're homeless, or you're going to the emergency room. If we can move everything upstream, we can mitigate getting into those high stream costs. And for the hospital folks, you know, I keep telling them, there's enough business to go around let's get these folks out of the hallways being boarded and serve folks upstream, and everyone will be happier, right?
Yeah, for sure. And just, personal experience, I'll name names even though I'm not supposed to do that. So personal experience is we have a very conservative congressman in New Jersey, Chris Smith, and he used to be my representative. He's not anymore. And whenever I would talk to him, if I talked to him about veterans or children's mental health, he would listen. Nothing else. Housing, never. Equity, never. But children and veterans always had an open door. So there you go. There's a stereotype for you. Next slide. So you have to have relationships with both sides of the aisle. You have to see what they'll talk to you about. So he would talk to me about children and veterans, and I would talk to him about children and veterans. And then I would sneak in some other stuff along the way where we can. But you want to, it says avoid transactional advocacy. You want to have those existing relationships. You don't want to just pop in and ask for something. And when you have the relationships, they're not always going to agree, but they will always see you. And they know that you're going to bring a message that sometimes they'll agree with and sometimes they won't. Share early drafts. Always share early drafts. If you can make one amendment on a bill that they like, that will be so important to them. And they'll remember, and you can always point out that amendment. Be tenacious. Well, we don't have to tell you, we're all tenacious. So, and then be proactive. Don't just see one side of the aisle. We are doing a lot of education on the 988 continuum in New Jersey. We're making fabulous progress, and we are getting responses on both sides of the aisle. So just, it's easier to meet with people who agree with you, but don't back down. You've got to see everyone.
Okay, next slide. So one of our important jobs is always trying to keep the conversation neutral and nonpartisan. And so that means, in our private conversations, we can use those words, with our colleagues and stuff. But when we're talking to the legislators, we are trying to make sure we are being extremely neutral in our language. So some neutral phrases for you to understand. The unhoused are homeless. Couch homeless means someone's living on someone's couch. Near homeless means they are one check away from being homeless. We talk about persons with lived experience. We used to, years ago, call folks consumers. We don't do that anymore. We talk about persons with lived experience. And we talk about peers, and we heard earlier today the concept of peers being folks with a certified peer specialty degree. Well, most of my employees are peers, but only 3 have certified peer specialist certifications. So that concept of lived experience is incredibly important. Some other things, we've heard lots of nasty rhetoric this year about DEI, right? And let me tell you something. DEI is not an ugly phrase. It really, really is not. Because literally, it means access for all. Access for all. And so that's the hardest thing I have to try to do is work with some of these legislators who don't understand what that means. And so I have to educate folks. If I say, hey, we work with the marginalized in Knoxville, Tennessee, folks make some automatic assumptions about that. But if the gerrymandered district of Knoxville has rural Knox County, and then the city is more blue, right? But it's a difference of where I'm sitting here and what's in that hallway is totally different. And it doesn't matter, it's the same thing. Marginalized means people are living check to check and making horrendous choices on what they need based on food is a higher priority, housing is a higher priority, and they've got to sacrifice health care or mental health care because folks need to eat, right? So the marginalized, need access, and we can't get caught up in that. So the other thing I want to drop on folks is a new term for some folks, Has anyone heard the phrase ALICE population? ALICE is the United Way, an acronym for Asset Limited, Income Constrained, and Employed Persons. These are folks that are right above Medicaid, and they are truly check to check. And, you know, they might be working and actually have insurance, but they are so, I can't say it out loud, SOL, you can interpret that yourself. They are so SOL because they literally have to choose food or seeing a therapist, food or going to the doctor. And they can't even afford to use their insurance copay because they're that limited. So to me, all these things just span every population. Doesn't matter whether you're blue or whether you're red, it just spans it.
Next slide. So this slide is about collaboration. And collaboration is critical in working with legislators because they want to know who else thinks the way you think. And the advice that we have is if you are on somebody's side once, it doesn't mean that they're going to be agreeing with you. And then if they never agree with you, they may agree with you on this issue. We find that a lot with hospitals. Sometimes we're completely aligned with hospitals, and sometimes we go to our hospital association and they, no thanks, but don't give up. That's not only true for our chair, our mental health coalition, and we're a consensus group. So we have consensus, I would say 95% of the time, and when we don't have consensus, we just part ways and everyone handles it individually. But legislators want to know who agrees with you. Yeah. And what I like to do is I like to tell legislators the people who don't agree with us and why they don't agree with us. Because I think the transparency of talking to legislators about both sides of an issue really helps them understand. And plus, it puts you at an advantage to show how sensible your position is and how irresponsible their position is. So, you know, if you do it proactively, it's better than letting the other side position themselves with the legislators. So look for other community voices that you may not even think about. Some of the public offices, libraries, schools, or parents of PTAs are great when it comes to children's mental health. Almost everybody has some experiences with that, and when the kids are really young, there is some willingness to come forward and testify along with you. So, and you know, next slide just means don't forget when you're talking to a legislator, understand who their district is. 5 minutes, ooh.
How about that?
Better move, okay. So this is about collaboration, so keep it in mind.
Okay, so let's go to the next slide, please. So one of the things we always want to try to do is clarify what our ask is and how we know we really need to be asking for what we're asking for. So there are a number of resources that I need to kind of just, you know, list off the top of my tongue here so folks can write them down. Number one, the State of Mental Health Report from Mental Health America National, right? You can use that. You can also plagiarize the heck out of it and use it in your local area. Take all those stats and go, oh, how do I look at the same thing in my footprint? So I would suggest you do that. It's worked wonders in my part of the world. The Youth Risk Behavior Survey. It's a 2-year survey conducted by your health department in bigger urban areas. The local health department will do it too, and then you get county-specific data. So that's really interesting. But when I want to visit with my congressman or a legislator in the state, I turn to the American Community Survey. And I know everyone's interested in what's going on in Congress right now, so I'm going to tell you 3 reasons to do it. Number one, the American Community Survey. You can Google that and ask the question into Google. How many SNAP residents in my congressional district? And it's going to give you the answer. And that becomes a talking point when you've got a legislator who doesn't understand what SNAP does and its mental health implication, right? Go back to what I said about marginalized persons. They're choosing food over mental health. Well, if we take food away from them, now what's going to happen? The ACA enrollment in the district, again, if you're trying to make a point about how folks connect, you've got to point to that. So the American Community Survey is incredibly important. I'm going to leave you with a couple of stats about that. Number one, ACA enrollment is higher in red states than in blue states. No one's talking about that, right? And in rural states, it's higher than in blue states too. So the folks that are represented by Republican legislators are not being cared about in that conversation. And that's the one that you have to have a tough conversation.
And we'll give you all these resources. If they're not in our slide set, we'll make sure we'll amend it.
We will.
So you have all the links on that.
Right.
Next slide.
Okay, so now we get to have some fun. Back in the day, when I was a snippy, young smartass, I would say to legislators, oh, hell no, right? And, you know, that just doesn't go over. So you have to have a little bit of, you have to figure out what to do. So at one point, and it was really kind of funny, a lady who was my chair-elect was coming home from Nashville, and she called me at night, and she said, Ben, you have arrived. I said, what are you talking about? And she said, they're in Nashville saying, what the hell is wrong with Ben Harrington? Because I was too mouthy, right? But that also made me think they were tuning me out. So I had to try to figure out what to do. And it was just fate. I was reading a book about diplomacy at the time. And so the art of diplomacy that, you know, the Prime Minister of France uses when talking to the Germans and the Germans are threatening to invade is totally, you know, different. They're trying to say stuff's important and don't do it. So, oh hell no means I'm gravely concerned. That says the same thing. It's not as in your face. Something is too costly, right? I'm not sure about the downstream consequences have been thought through, right? You're saying there's going to be downstream costs, but you're not saying, you're not screaming from the rooftop, it's too costly. It's too harmful. That's where you go to your maps and you go, you know, Senator, I'm not sure you realize how many of your constituents are impacted by this or adversely affected by this. Now, I'm not going to tell you what WTF and what WTH mean, but I think you all can go there. So the softer version would be,
They're signaling.
yep, Senator, the optics on this don't look good, right? And so those are the things. So the diplomacy matters. Go ahead.
Next slide. So you want to make sure that you identify bipartisan champions. How do you do that? People are going to drop hints to you about their friends, their acquaintances, their family members. They're going to ask for resources. They're going to seek help. Just be sensitive, be a good listener, be tuned in. People want to be involved. They do not want to self-disclose very often. So, you know, keep that in mind. Yet they'll volunteer and they'll be active. And eventually you'll get information, you'll keep it confidential, and then they will become your champions. We're all in this for a reason, and people generally will get involved and will be supportive because they have that personal experience. And we like to also say, catch them doing something right. When they do something right, we continue to reward that behavior. Mental health is not a bipartisan issue. Next slide. We all know the 1 in 5 statistic, 1 in 5 people will have a mental health experience and in a year, and we just know that that is true. That's true for legislators as well. Again, we just can't say it enough. Mental health is a nonpartisan issue.
Right. And to wrap up, closing what Barb said, I like to use a visual when I talk to my legislators. Before the pandemic, you could take a picture of Neyland Stadium, which is the football stadium at the University of Tennessee. 106,000 screaming people all dressed in orange and white. That picture would represent, pre-pandemic, the 1 person in 5 in Knox County, Tennessee, that needs mental health care. And then I would show them one more slide, and it would have 2 pictures of the stadium, because that's what happened during the pandemic. The prevalence of adults with mental illness and mental health treatment needs doubled. And now you can fill that stadium twice with the number of people just from Knox County, Tennessee. Now that's a visual, and it's a huge walk away. And now they get why mental health matters so much. So, thank you very much.
Next
Last
slide.
slide is our contact information in case anyone needs to reach us.
Oh, we have our data resources in there.
Oh, yeah.
Great. And one more slide. This is who we are.
Yeah.
Great. Thank you, everyone.
Thank you.
Thank you, Barb. Thank you, Ben. We know who you are. We love you.
Are we doing questions or anything?
No, you don't have time right now because
Okay.
we have one more presentation before lunch. However, for those of you in the room, these are two of our RPC representatives who work with our affiliates all across the country in little groups, little clusters, and they are some of the best policy minds anywhere. We have phenomenal resources, not just amongst our friends, but amongst our staff and our Regional Policy Council reps too. And right now we're going to hear from one of our staff members. Dr. Jessica Jackson is going to talk to us about something that's really brand new that we're all learning about right now. We're going to learn about technology, and we're going to talk a little bit about whether that's really a tool for a lot of good or maybe a tool for some harm, and how do we balance that? So Jessica, come on out, please.
Good morning, good morning. I am presenting, first of all, following up with those great points about how to say what we're trying to say better. I don't know if I can beat that. And I recognize I'm right before lunch, so I'm gonna ask y'all to bear with me as I give you kind of an overview. Where do I point this? Green arrow. Green arrow. Perfect. And I don't know why there's a blue dot there. So, I am Dr. Jessica Jackson. I'm the Vice President of Alliance Development for Mental Health America, and I'm a licensed psychologist. I also like to give context for folks before I give topics because I'm a big believer in take what you need and leave the rest. And you can't do that if you don't know who I am and what I'm talking about. So I have been a caregiver of family members who are navigating mental health challenges. I am also someone with lived experience in diagnosis and treatment. And when it comes to innovation and technology, I also chair the American Psychological Association's Mental Health Technology Advisory Committee, and I am the only behavioral health person appointed to the FDA's Digital Health Advisory Committee, which quite frankly is a shame that there's only one. And so that is the lens that I am coming from, is all of that together. It's a nuanced lens when we think about technology and innovation. So today we're going to explore digital mental health at a very high level, because I only have 30 minutes, and you could deep dive all day. So I do want to level set, it is a high level, that we're not going to talk about all technology, we're not going to talk about all tools, but we are going to be thinking through why it is important that we think about the way that technology can kind of move in our current ecosystem. My goal here today is not to get you to think like I think, but it is to get you to think of how do we marry what we know works well with what is also coming when we think about innovation. So why is this conversation important? Many folks don't understand the money of it. It is money, right? This is a diagram that Rock Health does. They do it at the beginning of the year, so there isn't one for 2025 yet. But as you will see, mental health has been the most invested in therapeutic area for venture capital for several years, right? There are over 10,000 mental health apps available, and that is not including those that come through prescription. That is not including those that are like virtual reality. That is also not including any of the technology that works on the back end, such as helping with administrative tasks and helping folks to get their Medicaid benefits or their disability benefits. That is just simply apps that are in the App Store. There's a lot of money that comes in to support digital mental health. The question that I'm going to be asking us today is, are we helping or are we overwhelming, right? How do we figure out, as we plan for 2026, how do we help people to have more good days using what we already know that works and being able to explore the possibilities without being overwhelmed by all that is available to them? And when we think about it, right, some of the questions I've gotten from folks before is like, well, why technology? And everyone doesn't use technology. As I mentioned the number of apps, but also OpenAI recently shared some information. I don't know if you all saw this, but they shared that 0.7% of active users in a given week share or exhibit signs of mental health distress on their software, on their platform. 0.07 doesn't sound like a lot until you realize there are 800 million active users weekly, right? That's about 560,000 folks a week who are talking about their mental health on ChatGPT. These are folks who are saying, I'm looking for support and looking for where to get it. Our role is going to be thinking about beyond ChatGPT, in the ecosystem in general, how are we making sure that the support that they're getting is effective and useful? So I'm going to talk about a couple of things. First, the promise of digital mental health, right? What is the evidence of help? I think it's important for us to be thinking even beyond diagnosis and intervention, right? Digital tools are useful because they can expand reach. I apologize that I am making noise, y'all. Because they can expand reach, they can help deliver prevention earlier, something that you all are very familiar with, right? MHA, we are about early intervention and prevention, right? Thinking about how digital tools can be a bridge for support. Everybody in here has probably heard about wait list, right? When folks are trying to get some sort of support. Digital tools can be a bridge. Research has found that when folks are trying to get support and they have to wait, they are more likely to attend their first appointment when they have bridge support. So when they come and they say, I need some help, and someone is able to say, here is an app that can help you with your sleep until you can get into your appointment. Here's an app that can help you with coping with symptoms of anxiety until you can get your appointment. Folks feel heard and they feel seen, right? So thinking about how we can even expand the reach that we have, right? Thinking also about things that are text-based check-ins. That is digital. When you're using text, when you're using the web, all of that is also considered digital. There are digital CBT programs, cognitive behavioral health therapy programs, right? Thinking about how we can use digital technology to transform a moment of crisis into a moment of connection for folks at the time that they need it. Digital platforms are also useful to extend peer support and therapy and not replace them. There are a number of apps where people are able to find a platform to find a peer that does not live in their area, right? Thinking about how can you think about, and I am mindful, I try not to always name companies because this is not an endorsement of them, but there are companies who have actually bought mental health startups that are focused exclusively on peer support, a way for people to have a pathway to get connected with others globally when they need it. Sometimes when you're in a peer support program, somebody may not be available at 2 a.m. and 3 a.m. where you live to support you, but they are available in another time zone, and there's a way for you to be able to reach those folks. We also want to think about how using digital tools can have personalized intervention, thinking about things like digital phenotyping. Digital phenotyping is when you take devices, wearables, things like your Apple Watch or Oura Ring, things like that, and use that data to then share it with your clinician to say, here are ways that I'm trying to make sure is my sleep. When I take this medication, I can directly see a correlation with my sleep. It's also data for you, right? Most of the time when we're going into an appointment, sometimes we can't track everything. I know how many folks have taken a PHQ-9 and I asked you how you've been feeling over the past 2 weeks? How many of y'all remember how y'all was feeling 2 weeks ago? Right? You're focused on how I'm feeling today, now, and that's not always helpful. You might even be feeling better, so when you're talking to someone, you're like, oh, I feel better. I was feeling really bad 2 weeks ago, but I don't exactly remember what it was, so they're not able to help you, right? So thinking about how we're using digital tools to do that. And finally, thinking about ways that we also have self-help programs. How are people tracking? People are using technology now, even for things like journaling. How do I pull out themes from that? How do I even notice patterns? Maybe for the past 6 months, I've realized that I've been feeling more anxious at 7 a.m. every day. I'm not remembering and tracking that, but because I've been able to write it down, there is software that can pull and say, this is the time period where you're feeling most anxious. That might be the time that we need to cope. Maybe normally I'm like, by the time I get through the day, I'm so anxious that I'm struggling at 5 o'clock and I don't feel like reaching out to anyone. But now I know what starts around this time, and it's been able to share that with me. So I know if I do something before 8 a.m., if I start my day, it's gonna affect how the rest of my day goes. So then we think about, to be fair, right, because I'm not biased when it comes to it, there are perils and blind spots, right? And I call them blind spots because you don't know what you don't know. And prior to coming to MHA, I used to work for a tech company, and I've done consulting and advising with them. And I will tell you, folks don't know what they don't know. There are folks, amazing things, who are building things, and they don't know everything about mental health. Just like you all are the experts, you may not know how to code. You have a great idea, but you don't know how to build it, right? So you have a blind spot. And so it's how do we bring everyone together to address these blind spots? So for every breakthrough, we always have a blind spot. Many tools, for one, assume stable Wi-Fi or digital fluency. That's a huge thing. That's a policy issue, broadband. It does not help you if there are 10,000 mental health apps if you don't have internet. Doesn't work for you, right? Does not help you to have a telehealth appointment if you do not have a stable connection or a way to have a device to be able to have that telehealth appointment. It doesn't help you if you're able to have a telehealth appointment, but you haven't had, your digital literacy isn't where it could be, and you don't know how to get things set up to be able to show up for the appointment, right? How do I log in? Then what do I do? Some of them can be really confusing. Some are straightforward. You just click on the link, it opens up. I assure you, they are not all that simple. I've been through them. There are things that you got to sign up, click for, you got to download. There are folks who will miss their appointment because they weren't able to get that done in time, right? So it doesn't help everyone. We also have to think about privacy and trust issues. Unless you've been under a rock, you have heard about mental health chatbots for like 7 months straight, I am sure, right? Everybody is doing things to talk about it. And there's many reasons for that, why everyone is getting involved, because they're wanting to talk about the privacy and the trust issues, right? So the FTC, which is the Federal Trade Commission, they're actually the ones, when it comes to digital tools, who handle the way things are marketed. They are responsible, so you cannot say, if you download this app, it will cure your depression. You cannot say that. That is FTC who manages that. They are the ones who are saying, well, we want to hear from folks. So they recently launched an inquiry into AI chatbots because they received complaints. That's how they get involved. And so thinking about how do we protect people's privacy and trust, we have to be able to know about it, but we also have to share with folks to say, hey, this is an issue. We want you to look into this, right? Recently, the House Committee on Energy and Commerce also had a hearing to talk about innovation. They had one on innovation with integrity, examining the risks and benefits of AI chatbots. They too were saying, what can we do? You remember the number I mentioned from OpenAI. People are using them. What can we do to make sure we can mitigate harm? We maybe can't get 100% of the harm out of the way, but we can do our part to say we're creating a pathway where people can feel safe. They can trust this. They can trust where their data is going. And then most recently, the FDA, the committee I sit on, the DHAC, they had a meeting about generative AI and mental health in general, right? And what they're looking at from privacy and trust concerns is if we're saying this is medical, if we start talking about reimbursement, how do people get it? What are pathways? So some of the things that we're talking about is what about over-the-counter, right? So what if you have a prescription digital therapeutic that you can get from a pharmacist, right? Or how do we think about the difference between children and youth when we're trying to protect them? And they have open comments. They had them open up until yesterday, I think, December the 8th, to hear from all these folks to say, how do we protect? How do we even make differences? This is all brand new. When you have AI output, generative AI output, it's different every time. How do you regulate that? Because they can't keep doing the same thing. They're not going to get, if they run a clinical trial, they do some sort of study, they're not going to get the exact same output every time. So then how do we regulate that? What does that look like? What is the age appropriateness, right? So folks are trying to address these, but there's such big issues that all of these groups, quite frankly, right now are addressing them and trying to tackle them, but they do need to hear from us. What are the things that we want to say, right? How many people are giving public comment when you see these opportunities, being able to say, here's what we're seeing in our community that could be useful. And then the last piece is thinking about clinical concerns. There is algorithmic bias. My colleagues would really hate when I'm about to say this, but I think it's the simplest way, right? Junk in, junk out, right? And that really is, how are we programming things? When folks are building a large language model, which is what generative AI is ran on, they're doing it based on the resources they have access to. That's why last year there was a lot of things in the news about what's behind a paywall. You may have noticed a lot of your newspapers and different things went behind paywalls. That's because generative AI cannot build a model from them if it's behind a paywall. But we also have to be mindful, what does that mean? If it's only able to use what's readily accessible and free, then that's what it's going to be built on, right? So how do we figure out ways to minimize algorithmic bias in a way that feels ethical? Also thinking about the idea that at the end of the day, we cannot automate empathy, right? So you might hear the phrase that people use all the time in the news and things, is human in the loop. What does that actually mean, right? And it means being a part of how digital tools are co-designed from the very beginning, how they are built, how they are programmed, even how they're marketed and launched. How do we make sure that we have humans that are a part of that entire feedback loop? So I'm going to share with you my idea of an ecosystem, right? This is a not fully baked idea, but like I said, it's to get you all thinking because you are all much smarter than me and can be thinking, how do we advance this? So I'm going to share kind of my framework of how we might think of an ecosystem to marry what we know what works with innovation, right? Because we all know that right now, most people in the mental health system are navigating a patchwork, right? They have a therapist or a clinician at one organization, then they might get peer support from somewhere else, or psychiatrist is with a totally different system, then they might download an app, maybe it doesn't work, but they don't change that data, then they use another app, right? They have medication management with someone else, it's all over the place. And so we currently have an opportunity to create an ecosystem of connection where all the pieces that we know work come together, the tried and true and the brand new, and we can talk to one another to serve the same goal, helping more people have more good days, right? So I'm going to take you on a journey with me, and I'm going to encourage you to really visualize this, right? Even in your mind, if you need to change the name to somebody that you know, but thinking about what a journey could look like marrying them. So I'm going to introduce you to Maya, right? Maya is a 42-year-old Medicaid patient who is living in a semi-rural area, and she is managing depression and chronic pain. Here's what a journey could look like for her if we marry what we know, the tried and true, with the brand new. Maya could begin with an evidence-based screening tool offered through Mental Health America, joining the 6.5 million people who screened with us in 2024, and thinking about what are the results that she gets from that. Again, online, it's digital, right? After she screens, she might recognize, actually, this is more serious than I thought. I want to be able to reach out to someone. So she might reach out to her local mental health clinic for a telehealth consultation, something that's quick, confidential, and available on her phone. She can do it from her home. She might then receive some personalized feedback and gets connected instantly to teletherapy options and a local peer support network. Next, she might move to Connection to Care, a care navigator app that helps her to figure out what her benefits are available to her, helps her to find out what's close to her, what's far away, helps her to navigate scheduling those therapy sessions, tracking medication adherence, and connecting with the peer support in a platform. She might even be able to get connected to a caseworker who can show her software that can help her to apply for benefits without having to go to every single office and get all of her paperwork. Next, she might be working with a psychiatrist who's monitoring her antidepressant treatment, and they're using digital phenotyping to be able to track when is the time that the medication is helping her the best. So when she takes it at night, when she takes it in the morning, are there any changes that she can actually see for herself as she's going through with the treatment? They can tailor her dosage and the timing based on what's happening with her digital phenotyping. After a year, she might even meet with that clinician and discuss the possibility of being able to say, well, what are clinical trials that could help me to have things that are getting better, right? This hasn't been working for me. What else is available? She can then go online, find out about new innovation, and be able to sign up for at least to see if she's eligible online, right? Maya would then continue to participate in her peer support groups that could be hosted on a secure platform designed with trauma-informed moderation so she can connect with somebody 24/7 to get support as she needs, as she's navigating how she's managing everything that's happening for her. She could even set up ways that her therapist could receive insights from some of her digital tools like journaling and mood check-ins to inform their sessions, so that if Maya does forget how she's feeling 2 weeks and 3 weeks ago, she does have a way to track it, and they can say, let's make sure we're noticing that around the same time every month, this is when things get worse. That might be when we need extra support, and we're able to track that for you. We then could use all of that information for patient-reported outcomes to share back with her clinics and all of those who are supporting with her to be able to close the loop so we're building things that actually work for Maya, right? One of the things I say in the digital health space all the time is what we're doing is folks are building tools without closing that loop. It's like building a house for someone who needs somewhere to live and you didn't ask them what they needed. And then they come and see that house and like, well, actually, I can't climb stairs and this house has 3 staircases, so I can't move in here. Or actually, you built a house that only has 1 bedroom and I have 6 family members. You built it and it's available for me, but I can't use it because you didn't build it for me, right? That's what's happening. We have to figure out ways to close this loop. So that's the last part, right? For this to work, for this ecosystem to work, every part of the system has to be built with inclusion in mind. From thinking about things like broadband access, so folks even have access to digital tools, to thinking about cultural responsiveness, to even being able to work across the board with community clinics, state programs, tech developers, and peer specialists to make sure the tools reflect how people actually live and not what designing for the way we think they should live. So how does that relate to why we're here today? Is we have to think about what is policy in this role, right? Policy, I call it policy as the backbone. Policy helps us to turn possibility into permanence, right? Once we know, once there's a process for people to get to their goal, it helps things to become more stable. Policy is our guardrail and it can be our gateway. It helps to ensure that innovation is safe and it's just. But it also helps us to think about how do these things get paid for? We could have that whole ecosystem I mentioned, but who's paying for it, right? Even if it helps folks, we have to figure that out. What is scalability? We build something for one community, but other communities can't use it. That's not efficient, but policy helps us to standardize things so that everyone is able to have access wherever they live to all of those tools. And how do we think about equity? Policy helps to make sure that somebody doesn't pay for one part of the ecosystem more than they pay for the other part of the ecosystem, so that folks can actually choose what works best for them. The thing is, we have to be thinking about this innovation because policy has to adapt, it has to evolve alongside the evidence. We can't wait for one to catch up with the other. We have to be thinking about these things in tandem. So what is the path forward? The question isn't whether technology will be a part of mental health, it already is. The question is how will we co-design it to be the most effective for the communities we live in, we work with, and we serve. We need to be thinking about how we center lived experience in research and trials. That means people have to be aware that these are options for them. I've had conversations with folks and they're saying, I don't want any technology, I don't want to use it. Well, they won't build it with that thinking, right? Because they don't know. They're going to build it for folks who want to use it. They won't know what your concerns are if you never use it or try it to be able to say, here's what's not working well. We want to be able to design equitable reimbursement structures and mandating transparency and data safety. This is brand new when we're thinking about it for the way things are working. The reason there's no regulations is this is actually brand new for humans, is how do we think about data that's shared in a way, for example, using the OpenAI example, they're not a health company. They don't have to follow HIPAA. So as much as everyone is holding them to a standard, legally they don't have to. That's because this is something brand new. You think about a chatbot that might be on your doctor's website. We have seen them pop up for customer service things all the time. How can I help you, right? It pops up. It's not asking for personal data. What we have now in technology is very different. We don't have policies. We have to invent them. So we have to be thinking about what does that look like in a way that also allows people to engage in the tools themselves. When we think about data safety, it's like it's thinking about boundaries. The role of boundaries is not always to keep people out, it's to show people how to come into relationship with you. That's how we have to be thinking about things like data safety. It's not to keep everything away. How do we have a boundary to show it how it can be in relationship with me to work in the way that I need it to? So, how do we help more people have more good days? As we look toward 2026, I want you to ask yourself, reflect and think about what is the evidence that we need and what policies must we have to shape to help more people have more good days? Who are the people who are not reached by the programs and initiatives we already have that digital tools would help us to reach? How many more people could be supported, could be helped, could feel like they belong because they have digital access that we've helped them to do? What are the policies we need to make sure that that comes true? Thank you.
Thank you, Jessica, for offering us so much to think about. We got a room full of policy people and advocates, and it's like, okay, guys and gals, we got to start doing stuff and thinking it. So please join me again in thanking Dr. Jackson. Thank you. Okay, everybody, it's lunchtime. And at all our meetings, everybody always said, we need more time to just hang out with each other, mingle, and network, and all of those cool words. So lunch is out there. Enjoy. I'll see you in an hour. Everybody enjoy lunch? Was it good? Good. I got to tell you, I'm really partial to that chocolate cake. The rest of the lunch was fine. It was really good. All right, don't tell anybody I've had 3 of those little chocolate cakes. So when I bounce off the walls a little bit, you'll get it. I'm really excited. We're in the home stretch. But that doesn't mean that what we're about to hear is any less important than everything else we've heard today. We've really packed a lot of info into what's happening now. And I'm going to be very brief. Sarah, you're here. Bridget's not here, right? Is that correct? Right. Okay. So MHA has a lot of amazing programs in our affiliates all across the country. And we are going to hear, obviously you can see that, from Sarah Norman, who is from Brain Futures. But Brain Futures is a program of our MHA in Maryland. And we have been talking at our last umpteen RPC meetings about psychedelics and how psychedelics are really a very promising avenue for helping folks with all kinds of mental health needs. And Sarah's going to tell us about a study of practitioner attitudes and where they are and how they're changing. So please.
Good morning.
It's afternoon.
It's afternoon. I know everybody just had lunch and you want to take a nap, but no naps for you. Okay. Ooh, I have to figure out how to make this thing work. Oh, that's it. And gosh, somebody earlier talked about the light, the gentleman in green. You are right. Oh my God, that light. I like to look at people and see what they're thinking and how they're reacting, but I can't look right over there, so don't take it personal. So I'm going to share a little bit about psychedelics, but first I want to kind of say hi, who I am, introduce Brain Futures, because I know you're going to want to work with us. I did add in Psychedelics 101 in addition to the survey because I think it's really hard to talk about psychedelics without first defining them. And people have very different ideas in their heads about what psychedelics are. And even if you get a bunch of folks who are expert in psychedelics, they'll debate it too. So let's open that debate so we know what we're talking about. And then, yes, they asked me to talk about, we did a survey with about 15,000 academics participating, and you'll not be surprised that there were 20,000 opinions presented as a result, but I will share some of them. And then since you're the policy leaders, I am going to talk a little bit about policy. So introducing Brain Futures. Yes, MHA of Maryland, and I know we have some Maryland folks. Anybody else from Maryland? Woohoo! Okay, and I know, where's the gentleman? Oh, the photographer. I'm not allowed to call you out, but he was from Baltimore too. So in any event, MHA of Maryland about 10 years ago looked around and said, there's all this innovation going on, and it doesn't really reach people. There's a 17-year gap between research and practice in mental health, and actually many other parts of health, and said, hey, let's do some work in that space. And the heck of it, why don't we start a new national nonprofit that does work in this place? And then Brain Futures was born. So our mission is to bridge the gap between research and practice. And for me, this is very personal. I've spent a lot of time in mental health and behavioral health. Right before I joined Brain Futures, I was at Shepherd Pratt. And one of the challenging parts at working at a large psychiatric hospital that does community-based services is getting calls from friends, from family members, from neighbors, not just the clients we might serve in our programs, but people who are really struggling and just excruciatingly frustrated. My daughter's in the hospital, but I can't get through to her. Can you help me get through to her? My son, you know, he is on the streets, and I don't know what to do about that. And so when you work in behavioral health, you know this better than I, it's a 24/7 job. And I saw how hard our clients were working, I saw how hard our staff were working, and still there's the incredible struggle across the United States and internationally. And so Brain Futures is gonna solve that all by saying, hey, this isn't enough. Like, the standard treatment options work for some people, and we support that, but they don't work for everyone. And we need to figure out how to get them the right treatments and supports to the right people, and what innovation is needed still. So we do everything from youth executive function, I'd love to talk to you guys about that, to psychedelic medicine, neuromodulation, anything new, anything different, anything exciting, or even a little wonky. Yeah, and I did want to spend a minute and introduce psychedelics. And what better use to do than a complicated graph that nobody can actually see. We all sort of vaguely know psychedelics are things that change our mood, that change our perception, our cognitive processes. But there's a lot of them, and the definition is a little unclear. Again, this is something we could debate. There's the classical psychedelics, you'll see them up there, LSD, psilocybin, most people know about them as mushrooms. Ayahuasca, you may have heard about ayahuasca tea ceremonies. DMT, not known as well. These are some of the classical ones. And then there's sort of some that are a little less classical, 5-MeO DMT. Nobody talks about it, but it's actually one of the more promising ones because that is a shorter sort of interaction time, right? For psilocybin, you're gonna be there 8 hours. For ibogaine, you're gonna be there 16 hours, maybe longer. But 5-MeO DMT, which doesn't get very much coverage, a lot shorter, and so actually may be better able to integrate into the medical system. And then there's things called psychedelic adjacent. Some people will say they're psychedelics, some people won't. They might have more of a dissociative profile. Ketamine. Ketamine is the only psychedelic adjacent one which is not a Schedule I substance. So, clinical research, I think the one thing that is really important to take away is that the number of phase 3 clinical trials going on in this is incredible. In terms of the psychiatric pipeline, this is where it's at. Therapeutic promise, I actually realized I missed a major bullet. I don't know, anybody want to call out which bullet that I should be talking about that's not up there? So major depression, there's a lot of research going on there. Treatment, refractory depression, post-traumatic stress disorder, end-of-life anxiety, and substance use disorder. There's a lot of phase 2 and phase 3 trials in those spaces. The one that I missed, anybody want to? Yes, Debbie gets points for generalized anxiety disorder. There's at least 2 phase 3 clinical trials on generalized anxiety disorder with LSD. So one of the things that's really interesting is, like, I was talking to the folks at the American Psychiatric Association the other day. I'm like, yeah, great. We know there's all these clinical trials. They're making us feel better about the potential clinical outcomes, but we still don't really understand the mechanism for action. And if we don't understand that, how are we going to really think about, are they helpful, are they not? And so this is sort of early understanding, but there's a lot of work going on to really piece back. What does psychedelics work? Really interestingly, there's research on psychedelics that don't have a hallucinogenic sort of attribute when they roll out, and so they've removed it. So is the sort of change in how you perceive part of the therapeutic thing or not, right? I think there's a lot of questions. Increased neural connectivity is clearly part of it. Reduced default mode network activity, I think that's one of the cooler things that's going on. So the default mode network is good, it's bad, it depends on how it flows, right? It's sort of a little bit your sense of self, your thinking, how you define yourself, and it can be depressed or it could be restricted, and it can be good or bad. The problem can be that if you have an overactive, it tends to align with symptoms of anxiety, overthinking, rigidity, and so there's some thought that what's going on with psychedelics is they're kind of breaking it back and allowing you to kind of reset your brain and sort of break yourself of less productive thought processes. Enhanced emotional release, often really strong emotions come out. Ego dissolution potential, which actually goes back to the default mode network activity. Psychological insights, all these things are part of it, but I think we're still piecing back exactly what the mechanisms of action are. I think one thing that's really important to talk about, and one of the big debates, is how important is it to integrate into psychiatry? And some of the trials are being done with very little, almost no therapy, but mostly psychosocial support. Our experience, and I think the broader behavioral health experience, is that you really do need to integrate these things into therapy. So what does that mean? What does that look like? Most clinical trials are following this kind of approach, screening and assessment. And that's mental health, that's physical health, and sort of to really make sure that people are preparing for this in the right mindset and sort of the right set of goals. Then you have the medication administration session, which can, really range in length, and that's one of the things that makes psychedelics a little different from traditional sort of interventions. They can be much longer. Psilocybin, 8 hours maybe. And then integration. How do you take these changes and integrate them into your life? Because that's where the power is. Now, nothing is without harm. Well, maybe that's an interesting question. Do no harm. But nothing is without risks, and I think it's really important to acknowledge that. And to the right or the left, depending on your perspective, is a chart which actually breaks out kind of harms associated with different substances. And though that font is really small, so I don't know if anybody can read it. But tall is bad. Short is good. And so you'll see, and this is a lot of sort of substance, you'll see that can anybody guess? What is the substance that is the most destructive, both to the person using it or those around them? Alcohol, right? And then at the other end of it is psilocybin. So it just gives you a sense of like where the risks are. I think the other thing that's really important to call out is there's different risks with different molecules. Most psychedelics have a pretty low risk profile around physiological or physical harms. Ibogaine, however, does have some significant cardiac risks. So that makes it a little different than some of the others. And again, you'd have to get into the details, but just to kind of sort of put it out there, in general, the risks are more psychological and environmental. And the clinical trials and hopefully medical practice will really try to use medical screening, clinical support, often called SET in the psychedelic field, and the environment or setting, like what the setting is like when you have it, to really control those risks and ensure you have the best possible outcome. Just a kind of a brief history of psychedelics. One is that they've been used in indigenous ceremonial use for thousands of years, or some of them have. You might have heard about ibogaine in the news, and ibogaine comes out of Gabon and has been used there for many years. Ayahuasca has different kind of places come from. Some of them are newer, but it's really important to acknowledge that and think about what that means. There was research, obviously, that went on, and some of it was better or worse in the 50s or 60s, and it showed promise, but I think there was a huge backlash. And in the 2000s, researchers across the country, Hopkins is one of them, started to relook at it, recognizing the failures of current treatment options. So what's going on? This is to make the point, really, that I talked about, in terms of thinking about what innovation in sort of the psychiatric field. This is a chart that shows kind of all the phase 1, 2, and 3 clinical trials with psychedelics. The red bullseye, it's funny, red is usually bad, but here it's approval. And so it shows, you'll be able to see phase 3 clinical trials, somewhat limited, but there's 2 on psilocybin, there's actually 3 on LSD, there's 1 on MDMA, and they're getting closer and closer. Next year, I wouldn't be surprised if there would be 1 or 2 approved. So this is coming soon. And Brain Futures, part of our role in this, again, is if we're shifting the gap between research and practice, is can't really wait till you get approval and then be like, oh shit, what are we gonna do now? And so we've been doing a lot of work on workforce readiness, clinical infrastructure and standards. We have professional practice guidelines. We have a lot of sort of tools around developing curriculum, et cetera, reimbursement and access, all this stuff. That's what we're trying to work on. So Alicia asked me to share one of our more recent studies to really ask this question. What's going on in the academic world? We know that there's many clinicians getting trained right now, schools of pharmacy, psychiatry, social work, nursing, who am I forgetting? And so we asked this question, are you training on this? Like, you know it's coming soon, yes, no, or otherwise. It's also a way to understand the state of the field from folks who are super informed. We did this with NORC, so a big shout out to Chicago. Anybody here from Chicago? Woo, okay. Yes, so NORC was our big partner. They know how to do surveys better than, well, I don't know, better than most people. And so again, 5,000 academic leaders we started with about 2,000 academic institutions. We tried to cover the gamut in terms of the relevant, this is an interdisciplinary field, so with psychiatry, pharmacy, social work, nursing. Oh, I have 15 minutes remaining. Okay, I think I'm good. And so did a big subsection to understand what are you doing in training clinicians as they go. About a quarter said they were doing something. And so you're like, not quite good enough, kids. But what was even more problematic is they didn't even feel like they were able to do it. 80% of these clinicians, and these are professors, right? 80% basically said, we are not ready to do an introductory psychedelics course, to even drop an hour into our med school curriculum or drop an hour into our social work school. We are not ready for that. But 70% wanted to do that, and they wanted the resources. And so I think that's a sort of a reassuring statement around sort of where psychedelics are in the academic world. People are already interested and excited. Again, sort of reassuring, about 80% of them either were somewhat excited, or definitely thought that psychedelics were part of sort of a promising future for psychiatric practice. And 83% wanted additional research. I'm gonna go quickly through this. I think we can skip that. So at the end of the day, survey shows, one, growing interest in psychedelic therapy, significant gaps in sort of the ability to translate it into an academic context, and then how we can really accelerate this. So I did want to stick in a few comments about policy, because you guys are the policy leaders, and there's a lot of state level activity as well as federal level in this space. We regularly are talking to members of Congress about their interests. It's sort of an unusual issue in that there's bipartisan interest in this, unusually. And there's resistance, I would say, in both parties and concerns, but at the same time, there's interest. And our policy priorities, I don't think, they really flow from what you need to sort of and make advances in psychiatric interventional psychiatry. One, we need additional research investments. And so we generally support, increases in both VA investments in that. Right now, the VA does have a research budget, but it's clearly insignificant and has underinvested in mental health. And so pushing that forward, but also NIH. Because when you go back to that previous slide about what we know, we have more data about traditional mental health and less about addiction. And so there's definitely specific needs to advance research in that space. The second is, and this has actually been very well received by members of Congress. Often they walk away saying, like, what can we do more? They all know that they don't have enough clinicians in their home, in their community. And so what we're doing is pushing specific ways that the federal government can invest, not just in psychedelic training, but also in sort of other emerging mental health treatments. Because if you ask at the end of the day what people are offered if they're struggling with treatment-resistant depression, it's often SSRIs first and foremost, maybe the right solution for them, but there's other sort of newer things on the table whether it's accelerated TMS or potentially psychedelics, that are not being offered, partly because the training isn't there. That's what the survey basically said. The other thing is, when you ask this question about why is there such a delay in getting new treatments out there, it's unfortunately access and coverage. You know this better than I do. At the end of the day, behavioral health is under-resourced, and that has profound implications around access, but particularly around innovation, because if you don't have the bandwidth to add, you don't. So we issued a paper around, as you think about psychedelic medicine rolling out, how do you think about applying mental health parity to that? How do you make sure that there's, that there's limited non-quantitative treatment limitations on psychedelic medicines afterwards? Also, we got to get deep into coding, but that might be too wonky for anybody but me. And then finally, one of the things we're doing is really focusing on veteran rollout. There's been a lot of indication that the VA is interested in rolling out psychedelics and recognizes that mental health support for veterans is insufficient. Actually, right now, one of my colleagues is at a closed-door roundtable with the Senate Veterans Affairs Committee. And they just asked the VA, they said, what are you doing to prepare for rollout of psychedelics? You know it's coming soon. What are you doing? How are you preparing for it? What do you need to do to prepare for it? And they're thinking about all the things that everybody is thinking about. How do you roll out training? How do you have tracking of outcomes to see? How do you think about ethical considerations? Who gets it first? How do you think about preparing that clinical infrastructure? How do you integrate it into their clinical guidelines? And so that's been a real focus of ours as well. So if you want to read anything and everything about psychedelics, we have a resource guide. We have probably about 15 papers up there. I will not test you in a week, but I might. Can we add an MHA survey question? Did you read no. But anyways, I actually kind of moved quickly through the second half because I'm really interested in people's questions or comments. Do I have time for that? Did I do it? Whew, much more interesting than hearing myself talk. So questions, comments? I'm not a clinician. I'll turn you over to clinicians if we get there, but I'd love to hear people's questions and comments. Oh, yeah. That's an easy question. Okay. Gentlewoman in the front row, I'm sorry. Yes, especially since I miss, oh dear.
I don't know that this is on.
Oh.
Okay. How did you get into this work? Because this is really great for the advancement of mental health treatment. As someone with a lived condition myself, major depressive disorder, seeing the advancement of this kind of work is great. So I'm just curious how you got into this.
Oh, me personally, I mean, to me, this has actually honestly been a focus of Brain Futures before I got there. I mean, I'm really interested in sort of changing the system and what's new and what's different. And so it was really Brain Futures' mission that drove me to it. I have loved working in the psychedelic space. I think one of the things that I find most appealing about it is it's an so frequently, for so many conditions, you're offered a lifelong pill. And this is something that might, I think we're still learning on how long psychedelics will be effective, but for some people, remission has been 3 to 5 years. And I think, yeah, I mean, this is where the data is still a little bit out, but to me, it also, SSRIs can really be transformative, but they also come with side effects. And so the fact that this doesn't have side effects, I think is a really compelling, well, I'm sorry, please don't quote me on that. The fact that it does not have sexual dysfunction and weight gain as these lifelong, potentially, side effects is very compelling. So a few minutes of thoughts, yeah.
Well, that sounds really, really interesting. I'd definitely be interested in following up in the future.
I'm excited. Oh.
Thank you so much. And that QR code with all your resources is incredibly helpful.
Oh.
So I'm a policymaker from here, from Illinois.
Oh, Oh.
And we're one of the states that hasn't done anything on psychedelics yet, but we've had a pretty robust bill that was introduced a few years ago that hasn't really moved, that would create a legalization framework, much like Oregon or Colorado. And I do a lot of behavioral health work, so my question to you, it's more of a policy question. What is your advice for state-level policymakers and what they could do to move the conversation forward? But I'm also putting on my reality hat that Illinois is not going to pass this bill this spring. It's just not going to happen. But I think we can get there. And so just introducing the same big legalization bill every year, I personally don't think is the way to go. I think there's some incremental steps. We did do a big subject matter hearing last year that was mostly related to veterans and psychedelics, but I'm sure there's lots of other things states could be doing in between to move forward and to be part of the conversation and to get to legalization later. And I'm curious for your perspective on what those steps could be.
Yeah, that's a complicated, thorny question. We have generally, I mean, actually, let me be clear. We have only engaged on the medical model of psychedelics. So I think I'm going to focus there. And I think some of what we've been thinking about is, given the likelihood for the FDA to move forward on a psychedelic in the next year or two, there's also incredible need to sort of, I don't want to look over here. There's also incredible need to think about getting ready for rollout. And so that's one of the things that we've very much focused on. You have to think about rescheduling. You have to think about, to me, I think connecting with workforce development initiatives and bringing in emerging mental health treatments is a very powerful way to start to get ready. Some states are moving into sort of research investments in psychedelics, which, you know, has its merits. I also think it's important that the federal government play a leadership role in research investments around psychedelics and other mental health. So I think in some ways, with the likelihood of the FDA shifting, it may be also shifting towards what does it mean to do rescheduling? What are the different scopes of practice that need to be adjusted and all that stuff? And we have looked at creating like a state readiness toolkit with the assumption, with the, I don't know, guesstimate that next year there'll be FDA approval of one or more substance. And so that's been a very big focus of ours. Oh, somebody you want to piggyback in? You want to say something? I just see, did I read your body language?
Oh, I'm just smiling and agreeing.
Oh, okay.
Did you? Oh, but Eric does have a question.
Yeah. Okay. Ooh, I'm not used to these time things. I need to work on that.
So my question is actually somewhat related. I'm part of the policy-making body for the California Medical Association and American Medical Association, and was involved over the past few years in designing and passing a policy to have these, entities work with the federal government around scheduling, because where we saw this last was with like medical marijuana, and that really has been a disaster in terms of being able to support research and being able for people to access the same thing we think about pharmaceutical grade medication, like pharmaceutical grade cannabis, and we foresaw that this could happen now with psilocybin or other psychedelics, where if we have this patchwork and it's hard to do research, and so then everything is de-incentivized, and then we have this route around legalization, but then do people get quality care associated with that legalization? Do you have any thoughts around this, either at the state or federal level, and how has the DEA been in terms of around rescheduling?
Yeah, so you asked a whole bunch of questions, and actually, so one of our, I guess I'm actually going to focus on the DEA. Doing research with Schedule I drugs is a giant pain in the ass, and that's the technical term. I'm sure, where's Mr. Diplomacy? What should I say? Doing research on, is what? A pain in the rear echelon? Okay, I'll try that one next time. There's unnecessary structural barriers, how about that, to research on Schedule I research. And interestingly, there was a rescheduling bill that actually affected, it's called the Halt Fentanyl Bill, and it was really focused on fentanyl. But what it actually did is take down a few teeny tiny barriers to doing research on Schedule I drugs. And so it really impacted the DEA. And I will say it's a step in the right direction, these particular sort of reductions in barriers to doing research on Schedule I. There's a lot of other legislation and sort of efforts in that space. We were actually just involved in a bill that's trying to make it easier for access to breakthrough therapies, because technically once the FDA issues a breakthrough therapy designation, you should be able to get access to it, especially in like end-of-life situation. But there's a total gap in it where it's very hard for physicians to actually prescribe it. And so there's a bill that was dropped like 2 days ago to address that. So I think there's like little bits and pieces of efforts federally to address kind of DEA and rescheduling. But it's not quite far enough, and we are going deeper into that space around sort of DEA oversight of Schedule I research and kind of how do you make it easier. You asked like 6 other questions. The other thing I can say is we haven't gone as deep into state work. We just honestly don't have the resources to do all the state work, but to some extent that's true. So I'll stick to the federal stuff. And if you want to collaborate on federal research kind of streamlining, come talk to me, because we're going to be talking to the DEA very shortly. Or we want to come join a meeting with the DEA. Thank you. Other questions? Please conclude. Okay. I'm concluding.
Sarah,
No.
can I please sneak in a question?
Yes,
All right,
ma'am.
thank you. You'll let me? Great. So I'm actually really curious about how peers, people with lived mental health experience and or people who have used psychedelics, maybe clinically or not, could be useful to the integration process. Is that something you're thinking about or practitioners are?
Yes. So gosh, you're not going to yell at me. It's her fault. So peers is actually, I'm so glad you brought this up. Peers are you talked about integration process, but I also think it's important across the whole process. So one of the big questions is a lot of the clinical trials, there's 2 clinicians in the room when you do a session. And while that sounds lovely and delightful, everybody wants to spend lots of times with clinicians. Well, maybe not everybody. Well, 1, that may not be people's preference, but 2, it's very expensive. And so one of the questions is, how do peers become a part of this process? And so it might be in the facilitation, it might be in the integration, but it also might be in sort of the conversations around thinking through what might be the right solution for you. And so I would love to do more work in that space, but yes, thank you for asking that question.
Yeah, thank you. I appreciate your
Oh,
enthusiasm.
and if anybody's want to work on that with me, or youth executive function, or anything else, just come find me.
Thank you so much, Sarah.
Thank you, Sarah. Thank you. Thank you. I mean, as you all know, we've been talking about psychedelics for a lot. We've been talking about new things coming on the horizon, new ways to do it. We're working both at the state and the federal level, and we are going to, of course, keep doing that. Now, we've got a couple more things, and everybody's been incredibly patient. And while the psychedelics are the old new frontier, I'm really very pleased that we were able to get Julie Nelson here today from Corporation for Supported Housing, because one of the other things that we are hearing that is moving not in that forward direction, but very much in a backwards direction, are things around housing policy. And we know that housing policy and good housing is good health care. And Julie's going to share some really good stuff with us today about that. So please help me welcome her.
Yep. All right. Good afternoon. How is everyone? So welcome to Chicago. I was not here this morning. Those of you who are from here, sorry. I know our weather's terrible. Glad we all made it. Handheld would be great, because I am so not tall. Being behind a podium is kind of difficult. So I'm going to talk about housing, kind of the landscape around housing, and then we'll dive into policy so that really My goal is to give you some foundational understanding around housing policy and ideas to bring back to your own states. So at CSH, Corporation for Supportive Housing, we really focus on all things supportive housing except managing actual units. We're not a housing provider. We really focus on supporting communities across the country in creating and maintaining quality supportive housing. We do that through a couple mechanisms. One, we actually are a CDFI, so we do lending specifically created to creating a new supportive housing building. We also provide technical assistance and systems change support, really trying to align systems so that they actually work better for folks who are directly impacted and what that kind of looks like on the ground. We also think a lot about quality supportive housing, which means the housing needs to be quality, the services need to be quality, and how is that really integrated for the tenant experience. And then last, we do policy and advocacy work. We do some federally, and then we also work at the state and local levels. So housing, it is a time. So it's a little small, but wanted to start with just definitions because who here has ever been really confused about the housing system and how people access housing? Right? Like, let's normalize that. The housing system is not intuitive. It is not easy to navigate, and that is true across the country. I think it looks a little bit different in different jurisdictions, but that is consistently true no matter where you live in the country. So definitions: market rate rent, market rate housing. That is the cost of housing, and what the price is determined by the market rate in that community, right? Like, we all saw, well, who here saw rents really increase in your community from 2020 to 2022? It was wild. I don't know that we were prepared for that, but it really shifted things, and it shifted the housing landscape for folks. For affordable housing, when we talk about affordable housing, that purely is, can someone afford that housing? Is the housing affordable to them at their current income amount? When we talk about affordable housing resources in your community nationally, we mean housing that is subsidized, so that the rent burden on the tenant is less than what the market rate rent is. So the subsidy can occur through a few different mechanisms, but when we say affordable housing, we really are thinking about housing that's affordable to where the rent is reduced. So it's either maybe workforce housing or deeply affordable housing for people with disabilities, seniors, et cetera. The housing is made affordable through a subsidy. That is literally the thing that lowers that market rate rent to what somebody can afford. A subsidy is going to function so that it's based on what I pay in my rent is based off of a % of my income. So you might have heard if I have a housing choice voucher, I'm paying 30% of my income towards that rent, and my subsidy is paying the rest. That voucher pays the rest. There's also a subsidy where the rent is a set amount, and it's based off of 30% of the area median income for that community. So it's a set rent amount, but it's still lower than what that market rate rent is. When you think about supportive housing, for the last definition, just to kind of level set for all of us, supportive housing is when the rent is extremely low, so I'm paying 30% of my income towards the rent, and I have services. So again, when we think about supportive housing, we're specifically thinking about housing where there's that integration of affordability plus services, and it's really targeting and kind of designed for households that have more complex support needs. Because if I don't need the services, then affordable housing is really what I need, right? If I need both, if I need the supports and services to help me maintain my housing, to help me access housing, then that's where we're in kind of the supportive housing territory here. So I know we're from all over the country, and Illinois is really special, but we're also really not at all special. So this is a snapshot, but your state is gonna look pretty similar to this. And there's a few things I want to highlight because I am just talking about housing. Housing in our state and really the housing crisis. Your state also has a housing crisis and your data is going to look a little bit different, but it's not going to look that different. So all of this is from the National Low-Income Housing Coalition. And there's a few stars up on screen here that I want to highlight. So household income that's 30% of the area median income in Illinois, statewide, that's $790 a month. So if we're talking about 30% AMI rent, that is based off of an income that's $790 a month. And that's 30% of that area median income. But now let's look at what is the fair market rent for a one bedroom? Over $1,200. Is that affordable for people who are making 30% of the area median income? Like, not even close, right? Like, that housing is out of reach. I literally cannot afford that. The last data point I want us to look at. How much is SSI right now? Assuming your state does not have an add-on, what's the SSI amount right now? It's over 600. You'd think I'd remember it off the top of my head right now. But annually, it's just over $11,000. So anybody who's really good at math in your head, 11,000 divided by 12, right? So a best practice for rent is that I am paying 30% of my income towards the rent because life costs money. I still need to eat. I still need shampoo. I need toilet paper. And I need to get to places and have transportation, right? Like, my funding cannot just pay for rent. That is not sustainable. So if I'm on SSI and I have met all the criteria for Social Security Administration to get SSI, rent that's affordable to me would be $283 a month. So this really, I put all of this up here to show us if I'm on a fixed income, if I am on disability, maybe I have a little bit higher income, I'm on SSDI. We have a rent problem in this country. We have a housing crisis, and it is severely impacting people with disabilities and all kinds of disabilities, and anybody who's on a fixed income, or anybody who's returning to workforce. So another data point, what causes homelessness? Yes. So I'm just tying it right back to that, so let's make sure our eye is on that prize. And the OMB, or the Government Accountability Office, did an analysis some years ago, I think it was 2018. For every $100 rent increase, we see a 9% increase in homelessness. So again, we have an affordability crisis. We have an affordability problem. And when you think about what's happening in your community, and when you think about the trends around homelessness and housing instability, we talked about already how rent has been increasing since 2020. We know housing costs continue to go up. We also know that for every $100 rent increase, that is the percent increase you're going to see in homelessness in your community. So nationally, this is an estimate, but we're short over 7 million affordable housing units in this country. For CSH, we've estimated that when we're thinking especially about supportive housing, which is that affordable housing paired with services, we're short just over 1 million units nationally. When we think about units that are specifically tied to mental health systems and supporting folks who have complex support needs and accessing mental health care services, we're short 55,000 units. When we think about folks who have been experiencing homelessness long-term and chronically, we're short 136,000 units. So that is our national picture. The last piece of this picture is there's also not just one path to housing. So as you go back and think about housing systems in your community and in your state, the Illinois example, we have over 100 housing authorities. There's 19 continuums of care, and I'll talk about what that even is later. We have housing opportunities for people with AIDS, HOPWA units. We have Section 811 units, which is a federal funding resource for additional affordable housing. There's a state bridge subsidy program. There's separate HUD resources, and we have the Chicago Department of Housing that funds units. And each of those has a separate path in order to access that kind of unit. And that is how it works in most of your states. I don't know of any state that's centralized at all. So now talking about where mental health systems and housing intersects. That intersection with supportive housing is one that we're really going to focus on. And supportive housing is an evidence-based practice. So the links in this deck, anyone will be able to access, and that just links to kind of a compilation of different research that CSH has pulled together, summarizing really the results of using evidence-based practices in supportive housing. Typically what you're gonna see, over 80% of people stay stably housed. Use of mental health crisis systems does reduce. For self-report, right? What is my experience as a tenant? My mental health and my health is improved. We also see an increase in folks accessing behavioral health services and staying connected to those appointments. Supportive housing is also an intervention when we're thinking about deinstitutionalization. So how are we helping people leave facilities, leave institutions, and move into the community and be successfully connected to resources, reconnected to friends and family, my faith community, work, all the things about life. Supportive housing can be a piece of that strategy as well, whether we're talking about mental health facilities, whether we're talking about people leaving carceral settings. Supportive housing can be kind of a tool in the resources for addressing leaving institutions. Supportive housing is also really created so that individuals can have that very individualized services and supports. We want to think about what services are available to everybody in the building, but also how am I accessing my unique healthcare needs? How am I accessing my mental health services, as well as a case manager that's in the building thinking about what are the services that need to be available to everybody in the property. And so that allows for some single-site supportive housing where it can be really created and developed to think about the needs of a specific community and to kind of really customize from there, whether that's with a provider organization, with a specific neighborhood. But again, anytime you're creating that supportive housing and a single-site supportive housing, you want to think about all those factors of who your prospective tenant is, what are the services that they're looking to access. Then another piece of the supportive housing field is what CSH calls the FUSE model. We're really talking about what are interventions that are effective and known to work for folks who are at that intersection of experiencing homelessness, in and out of the ER, in and out of the healthcare system, frequent hospitalizations, and who've also often been detained by the jail system, who really are in that system because the system is not including them, and there's not an out. So a lot of communities have developed what's called a FUSE model or a FUSE project that's specifically thinking about the needs of folks. The Chicago Flexible Housing Pool, I use that as one example, and the findings from their first phase research was that there's relative risk reduction, reducing a 37% reduction for inpatient days and 21% for ER visits. So again, these are projects that are really thinking about folks who are at that intersection of health, jail system, and homelessness. So now that we know, about supportive housing and kind of the evidence-based practices in that space, wanted to really talk about what are the opportunities that you might be thinking about in your state. So every state has a state housing finance agency. That's the group that decides how those federal housing development resources get used in your state, and they deploy those resources. Most states have one housing finance agency. There's a few of us that are exceptions and have multiple entities getting tax credit allocations, but typically every state has one housing finance agency. Your housing finance agency has what's called a qualified allocation plan That qualified allocation plan says, this is how we are deploying our resources, and this is how we want to see that happen in our state. So your state has one of those, and you can influence that. So thinking about what are the needs in your community, what are the needs in your state, how do you want to influence that qualified allocation plan that drives the creation of housing? Some of the things we're interested in our work in Illinois is how are we reducing barriers to lease up? How are we making sure that we're creating housing that has as few barriers as possible? Because oftentimes what you'll see is other barriers get baked in that aren't actually necessary. And so we really want to see more accountability and more practices that are about low barrier entry into housing. States can also use their qualified allocation plan as a way to address Olmstead concerns. So again, thinking about the deinstitutionalization. So that's something else you can talk to your HFA and your state leaders around what are we doing to address this. Housing finance agencies can also be interested in reentry housing and how they're allocating resources to support folks who are coming home from carceral settings. So all of these things are issues that you can speak to your HFA about, and you can get involved in kind of crafting how they're utilizing those resources and where they're using those resources, and think about what data you see and that you have access to that will influence that to drive the housing creation that will align with the needs of the folks that you're serving. Because that's really what it's about, right? Like, how stable can I be in accessing care if I don't have housing? On the Medicaid side of things, there's work done and will need to be done around retaining eligibility. And how are your housing partners a part of that? There's also the 1115 waivers through the state, or through the feds. And I will, on my next slide, show the map of this. But the 1115 waiver can be a mechanism for funding housing support services in your state. So that's another opportunity. You can also think about if you need service providers in housing, do community health workers have a role in that? And what does that look like? Again, when it comes to housing, think about how are you integrating access to services directly in housing or for people who are in housing that already exists. How are they accessing those services? How are we really supporting people in staying connected? And then on the managed care side of things, given the volume of data that they have and their resources, how are you partnering to help them leverage their resources in a way that will line up and align services for folks in housing? How can they be a part of the solution for creating new housing in a community? Like, those are all questions I think that you can always bring to the table, and opportunities in that Medicaid space. So what I just touched on with Medicaid, this is on our website, so you can link to it. But these are all of the states that have an 1115 waiver either in process or approved that really will allow that state to then bill Medicaid for housing support services. So you can see it's moving across the country. Anybody who's going through negotiations with CMS right now, I could not guess what the timeline will be on that. But you can see a lot of states are already through and are actually even at the point of making changes and revising based on what they've learned so far. So the current housing landscape, it is a challenging time for housing as it's a challenging time for Medicaid in general. So I think things to think about as you go back to your home state and your home communities, really how are the services and housing getting funded? And to examine that. So are you maximizing all opportunities with Medicaid? Are folks thinking about community health workers as a part of this vital workforce? The peer support roles specifically, are we maximizing those to help people support navigating the housing system? Because really, a lot of conversations I've had with supportive housing tenants is, who is better to help somebody else navigate the housing system than someone who has just already also had to navigate the housing system? Point well made, and yes. So think about those opportunities. Also, some states have dedicated funding streams to support services and housing. And that is something that at CSH we would strongly urge folks to consider, because again, even in our current federal environment, dedicated funding to support the services and housing is critical, because that is how you support tenants in having success, you support the stability of that entire building, and then how that's a part of stability for the community as well. Additional things to have our eye on. I am leading up towards the most important last. Protecting existing HUD resources is kind of the broad umbrella that I'm going to speak to now. Protecting housing choice vouchers and protecting those budget line items federally is critical, because we cannot afford to lose a voucher at all in our communities. We need every single one that is there. We need the project-based vouchers to be maintained, and so that is a huge advocacy point and to be aware of. How are you retaining vouchers? Because ideally we actually need to increase, but right now we really need to be very protective. The last piece is the HUD Continuum of Care Notice of Funding Opportunity. Anybody familiar with what that even means here? Okay, so for those of us who are not, a continuum of care is a regional body for organizing homeless response services in a community. That is a structure HUD set up in the 2000s, 90s. I should remember what year, I do not. But that is a HUD structure that's been set up. And it's, thank you, 97. I was like, wrong decade, so it was the 90s. So it's a structure that's been around for quite a while at this point. Communities have been organized, doing homelessness response and pushing resources back out. But again, it goes from HUD to a continuum of care to then local providers in the local community, a part of that regional body. That funding goes through what's called a NOFO process. HUD dropped this NOFO right after the government shutdown ended. The NOFO was dropped. What we learned at that point was that the NOFO really made a number of really significant changes in how housing and how that funding can be used. There were also some challenges with the timelines involved in that NOFO. So some of that is going through the courts. As of yesterday afternoon, the NOFO itself was pulled by HUD. But the NOFO tells us what direction HUD wants to go now with the current executive branch, right? Like HUD leadership has an agenda and we know what that is. So however this plays out right now with the time that's been bought while it's going through the legal process, we still need to be very aware of these changes because we know the direction HUD is going. So at a COC, what this means is a continuum of care is going to have, and again, talk to your local COCs. They are in the weeds of all of this right now. If you haven't partnered, they're not going to be able to respond to you this week probably, but they're wonderful partners, and I strongly encourage you to start getting engaged with them and figure out how to partner together to support the same people, because you are seeing the folks that they're seeing. And so partnering together really is the way. But what it means is that COC funding used to typically 85, 80, 90% would go towards permanent housing resources for that community. This HUD NOFO has flagged that HUD wants to see that ratio change, and the NOFO dropped it to a maximum of 30% of those resources could go towards permanent housing. So again, we don't know exactly how this specific NOFO what will happen, but we know that is the direction HUD is moving. And so with a COC and a huge massive shift like that, switching really from permanent resources more towards funding transitional, there are a lot of other pretty marked changes in requirements that also showed up in this NOFO. It is really important for communities to really start working together between services, mental health services, behavioral health services, and housers to really try and partner. It is highly likely communities are going to lose housing units through this transition, like permanent housing resources. And I'm going to take you through to one more slide quickly. This is from the National Alliance to End Homelessness, and this tells you of the supportive housing resources in each state, what % of those housing resources are funded through COC mechanisms, so through that HUD COC funding. So you can kind of get a sense of what is the potential impact in your state. just by looking at this map. And last but not least, so a few different resources. The National Alliance to End Homelessness is an excellent resource for up-to-date advocacy tools and resources. So they are there. There's links to also the National Low-Income Housing Coalition. Both are national entities doing advocacy, pushing out action alerts, and sharing toolkits and resources related to the NOFO. You're welcome to sign up for CSH updates and action alerts there. And the second QR code is that we had put together kind of a 2-pager brief on the NOFO and supportive housing resources by state. So if you want that brief for your state, use that QR code on the second half of that screen there to basically, you're sending me an email that says you want your state's brief, and I will happily send that out to you. So with that, I know that was a lot about housing, and it is a wild time, but I want to leave you with this. Like, partnership is so key, and so when you think about the folks that you're serving and the policy work that you're doing to really advance stability for folks, advance access to care and services, really think about how you can partner more deeply and more effectively with your housing partners.
Julie, thank you so much. I mean, you and I just met, but I'm going to give you a hug, please. Thank you. So folks will remember that we've always been talking about housing, and a couple of meetings ago, we had your colleague and my dear friend, Marcella McGuire from CSH, come and speak to us about this. And Marcella tipped me off in July when the executive order was coming down, and I happened to have been reading it sitting in my PCP's office just for a checkup, and I started reading it, and I just started sobbing. I'm sitting in the office like sobbing. But today, you made me cry a little bit more, but in a little bit of relief when you said they pulled that NOFO. Now, that doesn't mean they're not still going to do the things they're talking about, but what it means, folks, is that our advocacy is making a difference. So I'm so glad you came here today to not only share all those important things, and boy, is that for every $100 in rent increase, 9% increase in housing. If that's not the best advocacy tip you got today, I don't know what is. That was phenomenal. So thank you again. Please join me in thanking Julie. Thank you. Everybody's been terrific today. We know we have thrown so much at you, and we're not done yet. As we always wrap up our Regional Policy Council meetings, we hear from our wonderful RPC reps. We're going to hear again from Ben and Barb, and Shauna Movahill from Mental Health Minnesota is going to join us. Unfortunately, Shelley Palunko from Vibrant was unable to join us, but we're going to hear from 3 of the 4, and they're going to tell us more about what's happening in their states and give us a sort of call to action as we all go off. So come on up, everybody.
Hey, we're back. We're back.
Yeah.
Ooh, oh, I know. Tricky stuff. Who's going first?
And a hole right there.
I don't know. You want to go? No. Okay. Hi. I'm going to be brief.
Okay.
So I'm going to talk to you about something that's interesting that's happening in New Jersey. So we are actively, aggressively trying to get a 988 fee passed in our state. We have legislation which supports the 988 line and the, we call them M-courts, the mobile crisis teams, and so we are looking to fund the remainder of the continuum of care. And it is someone to call, and that's the line, someone to respond, that's the mobile crisis teams, and a place to go. And those include what we call a crisis receiving and stabilization center, which is a 24-hour facility that is a living room model, we talked about that, and has medical supports. And in addition to that, we have crisis diversion homes, which are 30-day supportive facilities. And this is like an amazing model of care. It is groundbreaking. It supports people on the voluntary side. We told you we have a robust involuntary type of mental health services, and these are voluntary. So we have legislation, we have support. My colleague Abby and I have been working with our colleagues, National Foundation for Suicide Prevention, NAMI, all of our mental health coalition is behind this, and aggressively messaging, working with our legislators. And so the good news here is that legislators that were really unaware of 988 are now very aware and have absolutely bought into and think it is miraculous. They understand it will avoid ER visits. They understand that in these times, people are not going to be able to go to the ER because they're not going to be able to afford it probably if there's Medicaid cuts, all of that. So they get all of that. That's the good news. The bad news is that we have resistance to the fee. So we have a lot of legislators that want the fee, and we're rolling along, ready to go with it. It's 40 cents a month, less than $5 a year. For less than $5 a year, you can, less than a cup of coffee, you can save a life. I mean, really, all of this is so great in terms of messaging. And then a key influential in our legislature floated a new piece of legislation with a new bill who said, I don't want a fee, I'm going to have a tax. So instead of the fee, we now have a bill that taxes commercial data collectors who, and there's an incremental fee and tax that they have to pay depending on their volume. It goes from 2 million to 10 million in terms of revenue and people. So this bill exists, and of course we're supporting it because we want this continuum of care funded. So we are in the middle of it. Will it be a fee? Will it be a tax? Oh, I'm sorry. In this tax, what I neglected to tell you was that $60 million a year is dedicated to the 988 continuum of care. So it's guaranteed money. It's coming from the private sector. It's a whole other approach. So we're in the middle. Will the fee go? Will the tax go? Or will nothing go? That's my story.
Okay.
But I'm talking about 988 too, so should I go next?
No, I'm not doing 988.
I know, I am.
Okay, go ahead.
So
You can tell we planned this ahead, right? So I'm going to talk a little bit about 988 as well, but about the relationship between 988 and 911 and some of the legislation that's happening in states around immunity from liability, because those are concerns that are popping up a lot, especially with like transfers from 911 to kind of that lower level service. So we all want people to get the right help at the right time, right? But we also know that a lot of times folks will call 911 when they could be much better served by 988 or another type of service. And, you know, sometimes just because it's easier to remember, right? And so they'll call 911. They're also, I've been doing some reading and some research lately about the impact of loneliness on the use of 911 and services. That people call 911 just so someone answers the phone. So anyway, we have been working in Minnesota for years now on building those relationships and trust between 988 and 911, and that's happening in states all over the place. But trust only goes so far if they continue to be concerned about the liability of, well, what happens if during the 12 seconds, you know, that I talked with someone during a 911 interaction and we transferred them and it was the wrong decision and something, you know, and something happens, then it, you know, then am I liable for that? And that's a really real concern that we're hearing from public safety answering points or PSAPs and dispatchers. So we've built trust within this work group, right? And they carry that message forward by talking about our procedures and, you know, as a 988 center, that for example, my staff know when it's time to hand someone to 911, right? Or to mobile crisis, if they're getting to a point where they're at very high risk for immediate safety concerns. So some states have started to put legislation in place to address some of these liability concerns. But there are a lot of different versions of it. So I've found 4 so far. And so I just wanted to note this as something to keep an eye on in your states. But think about potentially bringing forward legislation about this too, because it will continue to be an issue and stop 911 from transferring to, or sending out mobile crisis or other responses, because their default is always going to be law enforcement, EMS, fire. That is their initial response, is which one of those is the best response. But it very likely might be none of those things, but there's, then their default is probably law enforcement, because law enforcement tends to go out on every call. It's just, do we also send a fire truck? Do we also send an ambulance? So in Washington, in 2023, they passed legislation, and theirs, in my opinion, is some of the broadest and covers the most things. So I would look to that one as maybe a model to start with as we think about these things, because it covers not just 911 transferring to 988, but also to mobile crisis and 911 dispatch, and also covers 988 handing someone back, so, to those services. So it's really thinking about that continuum of wherever someone calls the first time, we're going to get them to what they really need, without worry that if I make the wrong decision, as long as I'm doing it in good faith, right, and following procedure, that I'm not going to be held liable as a result. So in Washington, their language covers 988 call center staff, mobile crisis staff, and 911 dispatch, and speaks to both those transfers, but also to dispatch decisions. So I do think that that's some of the broadest language. Nebraska passed legislation in 2024, but theirs provides that immunity for what they describe as each person involved in the provision of 988, but doesn't, and notes like the interoperability of 988 and 911, but doesn't specifically address transfers or dispatch decisions at all. So I don't know if it necessarily is going to address the concerns that I hear from those PSAPs. North Dakota passed language just this year that covers 988, 911, and 211, and provides that immunity from liability, but doesn't specifically speak to those transfers or dispatch decisions. And Wisconsin actually just passed this year as well, it just went into effect in November, language around providing those PSAPs and dispatchers with that immunity for any outcomes resulting from a transfer to 988, but doesn't speak to liability for 988 or mobile crisis, or address the potential of providing a mobile crisis response to a 911 call as well. So I think maybe not quite broad enough. So I would look to, to Washington as a good example. If you're interested in it, I'd be happy to send you the language. I think it's something we're going to pursue in Minnesota this year, because as long as these are issues, we're going to continue to have the same problem of, people not getting to where they really need to be.
Okay, I am not going to talk about 988, but that does not mean 988 is not on my mind too. I'm going to talk about pipeline, and I wanted to make sure folks know that some folks have seen it, some folks have not seen it, but there continues to be more and more unnecessary nuggets that we discover in what was called the Big Beautiful Bill, and I know Debbie has a different name for it. It's big, but it ain't beautiful. Anyway, So some of the nuggets there that are problematic, and it's not just problematic for Tennessee, but it's problematic for every state in the country. It's also problematic for every professional training program in the country. And I'm talking, you could do a Google search, top colleges of nursing, top master's programs of nursing, top colleges of social work, top master's programs of social work, and you can see, exactly those programs that just because they're a top program, you already know they're littering the country, Illinois, Washington, et cetera. So, but the major implications are this. Buried in that bill is the concept of capping graduate student loan fees or loan amounts. And so that's capping these dollars that folks can get access to help pay for a master's of nursing program, an advanced nursing program, social work, et cetera. And so the essential thing is what they've done is they are labeling essential professional programs that we value all across the country as non-professional and literally devaluing healthcare in the process. So they're saying they're not professional despite the fact that to earn those professional degrees, someone has to go through a very rigorous training program at the graduate level and above. There's a licensure process, supervision process, there's field placements, right? And then there's the license testing. And then beyond that, so what? You get your degree, you've got annual continuing education requirements too. So the concept of labeling the professions as not professional is just ludicrous, right? And so as I said, the decision is literally devaluing healthcare. Now, there are a couple of things I want to get off my chest and let folks kind of keep in mind. First of all, the average age of a psychiatrist in this country is 55 years old. The number of retirees from psychiatry far outpaces the number of new psychiatrists entering the profession. And it's by like 10 to 1. So no wonder we have the workforce shortages we do. But it also tells you why that workaround that every state has had to do for advanced nursing care to replace psychiatrists that are retiring is so essential, because the workaround is nurse extenders, physician's assistants, nurse practitioners, APRNs. They have prescribing capability, and so if we don't have enough psychiatrists, well, that's where we go. And now the federal government is saying, oh, you're non-essential. So that's a huge dilemma. And it's not just nurses, and I want to make sure my therapy friends hear me on this. It's not just nurses, because if you know what happens in community mental health, the social worker and the professional counselors, they play an extremely important role in treatment team decisions, intakes, assessments, that sort of thing. So, as I've said, the feds are trying to do this huge dumb down on the professions that we really care about. So what they really think is this. The federal perspective is that graduate school tuition is too high. I kid you not, that's what they think. Graduate school tuition is too high. And so they want to do this dumbing down, if you will, and they have this naive, and it is extremely naive with a capital, spell out the whole word, naive, interpretation that, well, if we make this change, the colleges and universities will have to change their structure and the lower tuition. Ain't gonna happen, people, because, oh, hell no. Oh, hell no. Yeah. Or what's Carrie, what's your phrase? Yeah. So, yeah, and I can tell you why. I mean, I can point straight to a shiny new building at the University of Tennessee campus. They tore down the old College of Nursing building, built a new College of Nursing building, and guess what? It's pretty, it's shiny. Yeah, it looks nice, but they planned on a certain capacity of faculty, certain capacity of number of students enrolled, and that would be what the pipeline would be because we have this thing called a behavioral health workplace shortage. So they planned on that. So they're not changing that, and colleges and universities are not going to reduce their specialty program tuition fees. The other nugget is, and I'm not sure if folks know this, but nurses and social workers already get through graduate school with a very similar amount of graduate student debt. They show up with $50,000 in debt. So now think about that cap. If you're going to go to graduate school and you've now got a cap that takes away $30,000 of potential loan money to help you earn that degree, now the naive people, you know who they are thinking, oh, it's okay, Barb, you go to graduate school and you get another $30,000 of debt. Again, that's extremely naive. There are going to be people that will say not only no, but heck no, right? And then there'll be others that then start seeking other educational opportunities. They might shop around for a social work program or a nursing program at a lesser institution, right? So they might try to get that degree from the 100th ranked nursing program or social work program. And what that does is that's not the same training field as the top 25. So then you have, pardon the expression, but you end up with a dumbing down or a reduction in capability to provide evidence-based practices because folks have not been trained and had the same benefits as a higher level program. So those are things that bother me. And it's one that I just have to keep speaking to. This is every state in the country. And we have to speak up, and how we speak up about it is, we got to tell folks what the ramification is, that downstream impact. That impact is if we think we got a behavioral health workforce shortage now, wait till folks that are in college and wanting to get a master's degree now realize that's not in the cards. Now we're going to have even fewer therapists and fewer nurses, and the shortage just gets worse. And I know in Tennessee, it's 95 of every 95 counties has a workforce shortage. And that's just for the folks that serve in the public sector. That's not in the private sector. Usually someone goes through graduate school for social work and they get field placed and placed at a mental health center, and then they get their licensure supervision done, and then they move on and they're in private practice. So we've got to keep that pipeline going, and these decisions to cap what folks can have access to with graduate student loans is so ridiculous, it's not even funny. Anyway, that's what I wanted to vent about today. But it's every state in the country. So, yeah, it fits.
Those are the best.
Hey, we did it in 22 minutes.
Did you have other things you wanted to share about what's happening in the states?
We want it known. We did this
Okay,
panel
all right,
in 22 minutes. So we
22
saved
minutes?
3 minutes.
3 minutes? Okay, well, we're not going to go there. Okay, but I'm going to thank some people. I want to say thank you to our friends in the back there, our sound people, our photographer. A special thanks to Catherine Reynolds and Susan, where is she, for putting together this amazing thing. For the rest of our staff that's here, Valerie, who's looking after our affiliates, as always, for Dr. Jessica, who's here supporting our industry partners, for my partner in crime, Alicia. Woohoo! For Mark Hireman, who is not only important to MHA National, but our host from MHA of Illinois. And a lot of folks know this in this room, maybe not everybody. So this is my last RPC meeting. This is, You know, so they say I'm retiring. There's nothing, I'm not retiring. But I am stepping away from Mental Health America, not because I don't love Mental Health America, because I love Mental Health America so much. And we all have done such amazing work together. And all of the work that we have done together, separately, and really have cared about, and the people we really care about, that right now policy changes are making it really difficult to do the things we know work. That's why we put together this meeting, because we wanted to give people good information, solid information, and really good advocacy tools to go out in the world. And I want to say a special thank you to Sean Sloan for being here for CSG. And if people are wondering what I'm going to be doing, I'm going to be making a lot of noise. And who knows, Sean, maybe I'll show up at your legislator meetings as one of the legislators. Who knows? Because we're all going to really continue the good fight. It's what we have to do. And I want to say thank you to everybody for all of these wonderful meetings. We've been all over the country for years. We've gotten to work with the coolest people and meet wonderful legislators, say thank you, meet amazing advocates and researchers and clinicians and people who are doing cool stuff. So I just want to say thank you to everybody. You've all said enough stuff about me, and you picked on me last night. It was all right. It was all right. It was all good. But I really want to say thank you to all of you, and I want to give all of you a hand. So thank you. Let's go out and fight, folks. Right, Ben? We're going to go fight.